Surgery has essentially four big views of the operative field, especially true when it comes to laparoscopy.
First instruments, our hands were not.
So, good morning, everyone, and welcome to Hall 3, the Desire Hall of North Zone UCCon. We start with the first session, and I request our chairperson, Professor Dr. Rajiv Sood, sir, the founder, Dean of RML, and the chairman of ISU and director of SUI, to please take his place on the dais. The other dignitaries and chairperson, if they are available. Dr. S.P. Kataria, sir, and Dr. Amitabh Singh, sir. So they have virtually joined us online. So I now request Dr. Tanvi Sood to please take the dais and make her presentation. Thank you.
Thank you. Good morning, organizers. Good morning, everybody, faculty and delegates. Thank you for the opportunity. So I'll begin with my talk. And today we are talking about survival expectations and how we've redefined survival expectations in the management of urothelial cancer. So to begin with, just to lay out the basics on bladder cancer statistics in India at the moment. And it is the 9th most common cancer, accounting for 3.9% of all cancer cases as per the Indian Cancer Registry data. And we all know that the most common histology is the transitional cell histology. If we talk about the incidence in male, it is about 1 in 250, which is much more significantly higher as compared to females, which is about 1 in 1,000 female patients. Talking about the demographics coming from Indian data from a tertiary center. So about 47% still present in a non-invasive bladder cancer setting, non-muscle invasive bladder cancer setting, whereas the rest they comprise of the muscular invasive bladder cancer or the metastatic setting. And this is the area of focus because the survival outcomes are still quite abysmal. And moving forward, can I get help? How do I go next? Okay. Yeah. So first to define what already exists, and then only we can redefine how we've moved forward in the management. So options for first line patients historically have been cisplatin based therapy, platinum based therapy for those who are eligible for platinum based treatments. And then there's another subset which owing to the performance status at presentation or the age of the patient, they are mostly cisplatin ineligible. I'll just shed light on how we define this subset in the subsequent slides as well. So gemcitabine cisplatin has withstood the test of time, and it's still the standard therapy, although there have been many trials that have come around and addition of taxanes or going on to high dose intensity MVAC therapy. Nonetheless, we have still stuck around to gemcitabine cisplatin based therapy for our cisplatin eligible subset of patients. And cisplatin can be substituted with carboplatin, again establishing that platinum are very important agents in these patients. So outcomes with different first-line chemotherapy regimens, the area to focus over here is what are the survival outcomes that we're really dealing with. Progression-free survivals are still ranging around 8 to 9 months for patients who are cisplatin eligible, and much lesser in cisplatin ineligible, about 5 to 6 months, not being able to touch 1 year mark up till now, no matter how many different trials have been tried and different chemotherapy agents have been tried. And overall survivals have hovered around somewhere close to 1.5 years. So there have been very limited advance. We can see all these trials, and all of these have gone ahead to show that there has been very limited advance in terms of chemotherapy. In terms of chemotherapy in the last 20 years, in terms of systemic chemotherapy. So these are a list of randomized clinical trials, as you can see, and gemcitabine cisplatin is still the standard. Right. So coming to second line options. So in this patient who have progressed on platinums, an era prior to the newer targeted agents and IO agents, we still dependent on single line chemotherapies, whether they were taxanes or even platinum rechallenge if the patient has had a platinum free interval of more than 12 months. However, if we have a look at it, the median overall survival is still much lesser. It is still less than 6 months. And this is why, because we have very poor tolerability profiles and not very durable responses. This is why this area has been an area of unmet medical need so far. So the challenges, again, just to highlight, have been that patients generally, they present with a poor performance status around this time, and most of them are cisplatin ineligible. So what do we have in our hand now to tackle such a situation? 2016 turned out to be a milestone year for urothelial cancer, especially in metastatic setting. Why? Because this was an era which marked the onset of IO agents. And this was the study that brought about the usage of pembrolizumab, especially in the second line setting. So this is when patients have progressed on platinum-based therapies, or the recurrence was anytime within a year of platinum-based therapy, peri-op platinum-based therapy. And we can see that pembrolizumab was used in this, and it was randomized and compared with any investigator choice of taxane or taxanes or vinflunine. And pembrolizumab was continued for about 2 years, or unless there was unacceptable toxicity. So here we can see the survival outcomes, and the median overall survival in the pembrolizumab subset was pushed to 10 months as compared to 7 months, with hazards of 0.7. And the progression-free survival was about 2 months. So this was the intention to treat population. And when we look at the subset analysis also, when we look at the patient subgroups, the overall survival, it was favored in the pembrolizumab group almost across all subgroups. This is again looking at PD-L1 CPS, and here also we saw that both more than 10 and less than 10 scores have showed that pembrolizumab is favoring survival outcomes but the PD-L1 CPS more than 10 score was the subset that performs better. So at present, the standard of care in a post-platinum setting, we have a range of PD-1 and PD-L1 inhibitors, and we have FDA approval across all these IO agents, pembrolizumab, atezolizumab, nivolumab, durvalumab, and avelumab. So again, when we redefine our survival expectations, this is how I wanted to portray that moving forward, somewhere from 6 months, we've been able to push it to about 10 months of median OS in this post-platinum setting, owing to these agents. Why were these agents even more important? Because they're much easily used and much more favorable for patients who are in performance status more than even 2, and mostly for patients who are platinum ineligible by that time. So who are these platinum ineligible patients? About 50% of them would present in such a setting, and this impacts the outcomes in terms of survival as well. So patients whose ECOG status is more than 2 or creatinine clearance less than 60, already a baseline hearing loss is there more than grade 2, or NYHA class 3 heart failures, or a pre-existing peripheral neuropathy, maybe because of a prior treatment, or comorbidities. So what are we looking for a new standard of care when we talk about first-line cisplatin ineligible metastatic urothelial carcinoma? So moving from the second line, now we are focusing on first line, and specifically in the subset of platinum ineligible patients. So we want like a sugar and spice and something nice kind of combination, which has efficacy improvement versus the already pre-existing gemcitabine carboplatin, and of course, safety improvement as well as compared to these chemotherapy agents. So coming to the new standard of care, we have a new first-line pembrolizumab in cisplatin ineligible patients with locally advanced unresectable or metastatic urothelial cancer. So this was a Keynote 052. It was a multi-center phase 2 study, which brought about a change in this space, where pembrolizumab was used in this subset of patients and continued for 2 years or until treatment toxicity. And the baselines were well balanced, as we can see that there are a lot of old patients also that were included in this trial, and a lot of patients who had visceral metastasis as well. So this is the overall survival outcomes, and here I've shown the overall survivals in the entire population as well. CPS score more than 10 versus less than 10. And we can see that the overall survival was about 11.3 months. So this is the updated outcomes at 5-year survival. This is a recent update. And we can see that in the CPS more than 10 subgroup, the median survival is as good as 18.5 months. And in the less than 10 subgroup, it was about 10 months. So the objective response rates have also been very favorable, especially in the CPS more than 10 scoring. And these patients tend to have about 47.3% overall response rate, which is definitely commendable. And this is again highlighting in the CPS more than 10 score. And this is the subset in which the approval also came initially. So these patients tend to do well. This was the exploratory analysis, which particularly focused on patients more than 65 years of age, and also patients who have ECOG PS more than 2. So we can see that there's a higher objective response rate that was observed and specifically restricted based on this PDL1 scoring. Right. So the duration of response also was around 63% at 2 years for patients who are aged more than 65 years. And if you look at the ECOG performance, the poor performance status also, we are still able to touch duration of response in about 50% patients. And the median overall survival also, the OS survival at 12 months was also about 50% in this poor subset, where we say that they are elderly and they have a poor performance data and definitely ineligible for platinum therapy. So this was a landmark approval, and this is the updated approval by the FDA, where they have included even patients who are CPS less than 10. So this is irrespective of PDL1 status, and this has come in the subset of cisplatin ineligible patients. So this is as early as August 2021. Whereas in India, the current approval is for the treatment of patients with locally advanced or metastatic urothelial carcinoma who have disease progression during or following platinum-containing chemotherapy or within 12 months of neoadjuvant or adjuvant treatment with platinum-containing chemotherapy. So that is in the second-line subset. And now we do have FDA approval for the cisplatin-eligible and first-line subset as well. So as we move forward, redefining our survival expectations, there have been several phase 3 trials, also in combination with chemotherapy with these IO agents, not very favorable outcomes. And now when we talk about first line, the things are getting more and more refined. We have switch maintenance options as well. So as we move forward, it would come down to historically second line meant that post-platinum is second line means it is post platinum based therapies only, and based on that our keynote 045 updated analysis is also there, and these are the IO agents that help us in this subset. But now that we have switch maintenance also, it could be a new way to look at it, but that a second line would mean post platinum and post IO. So what would be the options in this area? Again, there are a lot of targets that can be exploited in urothelial carcinoma as well, which has come up as FGFR3 inhibitors and also membrane protein inhibitors. So these keep on further redefining the subsets for survival outcomes and keep pushing even second line and beyond as much as 13.8 months, which is quite significant in this area where we were talking, if you recollect, I spoke about less than 6 months to begin with. So the landscape of urothelial carcinoma has been evolving, and it's been a journey where we've gone through chemotherapy not progressing and being still in the area of platinums, gemcitabine platinum, very little or no survival benefit added with taxanes. And pembrolizumab has come up in a big way, even in the non-muscle invasive bladder cancers, which have progressed after BCG intravesical therapy as well. And moving forward, even in the first line metastatic setting, we can see that now we have approvals for pembrolizumab, regardless of PD-L1 status for these cisplatin ineligible patients. And also in our second line therapies, where it is the only agent, it is approved regardless of PD-L1 status. So these are the current NCCN guidelines. Just to recapitulate, when we're looking at a cisplatin eligible patients, our preferred regimen still remain gemcitabine cisplatin. And there is now space for an IO agent maintenance also, which is called a switch maintenance. And then moving forward, if in the first line setting, it is a cisplatin ineligible patient as per the Glaskey criteria, then the preferred regimens could be gem carboplatin, or we could prefer based on these, especially if it is a PDL1 higher CPS score, we can base our judgment call based on these trials and choose an IO agent. And moving forward, in the second line setting, if the IO is already used, then we have our FGFR2 inhibitors, where we can test our patients if these targets are available for targeting, like erdafitinib and enfortumab vedotin. And if the IO has already not been used in the first line setting, then we still have IO agents to explore in a second line scenario, where pembrolizumab is a category 1 recommendation, regardless of PD-L1 status in a post-platinum setting. So that would be it. Thank you so much for the opportunity. And this, I hope it has shed some light on, urothelial carcinomas, which have been a very tough to treat subset of cancers. And IO agents have really made us push forward. Thank you.
Thank you very much. Thank you very much for this short and crisp presentation about the new agent, which is only approved, FDA approved in August in these settings this year only. And you have mentioned about future directions, which include the intravesical installations. And earlier also we were having some trials on HIVAC, that is mitomycin intravesical, and systemic pembrolizumab was tried. So what is the logic of giving now intravesical alone of pembrolizumab, or it can be given in a locally advanced where TURBT complete resection is not possible and muscle invasive is there also we can give intravesical?
Yes, so we have, as I had showed in the treatment paradigm also. So pembrolizumab has come up in a big way, not just in the metastatic setting, but also in non-muscle invasive setting where intravesical BCG therapy has failed, and pembrolizumab can be used as an option as systemic therapy, which has survival advantage.
One question, Sandy. So in metastatic setting, what I could understand, the pembrolizumab can be used. Can you hear me? Okay. So what I could understand that in a metastatic setting, pembrolizumab can be used irrespective of PD-1 staining.
Yes.
Whether it is more than 10 or it is less than 10.
Yes.
But what about this evolumab, nivolumab, and this another immunotherapy?
Right. So biomarkers in terms of PD-L1, so we know that CPS is the scoring that's required. And in this subset analysis, pembrolizumab is the only one that has showed survival benefit irrespective of CPS scoring. And now when we look at it, now nivolumab and avelumab are also there as options, but they are better preferred in CPS more than 10 setting. But pembrolizumab is the agent that can be used regardless of PD-L1 status.
Okay. So next question is, there are like so many patients who are locally advanced from the beginning and they fall in CKD category. So pembrolizumab is very costly. It comes around like 3 lakhs per dose. So, like, is there any option for using nivolumab or like this combination of nivolumab or some other chemotherapies? Although I know there are trials which are coming up with the
Yes.
combination of IO and chemotherapy.
Correct.
So, what is
yes.
your thinking about this?
So these are the phase 3 trials that I wanted to highlight. And unfortunately, as expected, we saw that chemotherapy and IO agent would definitely mean that it would translate to further survival advantage. But that has not been the case in this setting. And the only thing that did come out to translate in terms of survival advantage has been a switch maintenance post chemotherapy. So post gemcitabine and cisplatin after 4 cycles, patients who have been good responders can be kept on IO agent maintenance with avelumab. However, these 3 trials like IM Vigor 130 Danube trial, which tested out durvalumab, and even the Keynote 361, this has been recently, the outcomes have been recently updated. And these are the ones that wanted to test out whether chemotherapy and IO agents can be combined and if it translates into any sort of survival benefit. However, that has not been the case.
So, in chemotherapies, they are combined with the cisplatin or carboplatin or like just
With pembrolizumab cisplatin or pembrolizumab with cisplatin gem combination or with carboplatin gem combination.
Okay. So, right now there is no approval for any immunotherapy in neoadjuvant setting.
No, not along with chemotherapy. No. So these trials unfortunately have not come out to show the kind of survival benefit that would have been expected. However, in a switch maintenance setting, that it is approved now.
As a single agent, there is no approval for neoadjuvant immunotherapy.
Not in the cisplatin eligible patients. Cisplatin and gemcitabine still remains to be the standard of care. However, in ineligible patients, we can opt for IO agents, especially if a PDL1 is CPS score more than 10, because we've seen as compared to conventional chemos, they have a better survival benefit. So again, coming to your questions, if patient, of course, affordability is a huge factor when we speak about IO agent, right? And we always talk about even single agent gemcitabine for that matter in such patients, if we are not even able to offer carboplatin to them. So we keep our options open when we talk to the patients, but as a preference, standard of care, IO agents would help in adding to survival benefit.
So, you mean to say, if suppose we are doing QRBT, and if we feel that it is a locally advanced disease, then we should always like have of this mind that we can use immunotherapy as a neoadjuvant to downstage the tumor. So we should always ask for the CPS staining also, PDL1 staining also, just to see the scoring.
This PDL1 status, which is not required, irrespective of that, we can give pembrolizumab.
Yes.
When it was tried for other urothelial cancers, as in urology we are talking, it was tried, limited approval was given for, say, prostate in 2017. So it was mandatory to do PDL1 status. So is there any reason for that? In solid
So
tumor,
PDL1
was applied, that analogy was applied
yes.
on prostate.
So PDL1 is a very dynamic biomarker, and across solid cancers, we've noticed that different subsets tend to behave differently, especially even if we talk about lung, more than 50% PDL1 status, they do the best based, with the IO agents as compared to maybe 1 to 49% and the least amount of outcomes in less than 1% patients. And across various solid cancers, we've also seen that the scoring also differs. So in these subsets, we are using the composite score, whereas in other subsets, we are looking at just the tumor cells. And in breast, we look at only the immune cells. So it's a very dynamic sort of a biomarker. And in urothelial cancers, also initially when the approval had come, they had only approved for the PDL1 CPS more than 10. It has only been after the 5-year updated analysis that it was seen that it has been extended the approval for even less than 10 subset. Because initially the kind of data that we had gotten, it was highlighted then less than CPS, it was actually much inferior and there was not much benefit. But as the data has evolved, even the CPS less than 10 subset, they also do well with these IO agents.
So say after radical cystectomy and when lymph node status is positive, and after that when we give it to on progression of disease after chemotherapy, or if the stable disease is there, non-progressive is there, but regression is not there, or it is there also it is given, because there are trials for avelumab.
Yes. So in that setting, avelumab has been the only agent that has come out in terms of switch maintenance. Like I mentioned, even in the neoadjuvant setting, addition of pembrolizumab or durvalumab or atezolizumab did not translate to survival outcomes. And in this setting where post-cystectomy and if there is a local progression, also node positive disease is there, and we've treated with platinum-based chemotherapy, for responding patients, definitely avelumab is the standard of care now in terms of maintenance. And I wanted to highlight this only, that now, when we have these kind of agents in upfront setting itself and we're exploiting an IO agent, what do we do on progression? So what are our second line options? In such a subset, which is why we could look at our FGFR targets. So whenever there's a progression, now we try to look for FGFR targets and whether we can use anti-FGFR2 and FGFR3 inhibitors. Or we can even, again, if there's a 12-month interval, we can even re-challenge with a cisplatin therapy if patient is still eligible, cisplatin or carboplatin.
So once we start it, for how long we give the maintenance, or what is the duration which is now
So
we
as
are recommending?
as per trials, it was 2 years. So for 2 years, unless there is intolerable toxicity. So usually with IO agents, in the trial setting, 2 years, but then even up till progression. So realistically speaking, it actually is up till progression.
So do you think that these agents with these targets, they lead to endocrine problems, and they are more in pembrolizumab, or they are at par with other agents compared to?
Right. So all IO agents, they have about 5 to 10% immune-related side effects, and endocrinopathy is definitely one of the more common one in form of thyroiditis, even diabetes mellitus. So these can be noticed as early as 1 month on therapy, 2 months on therapy. These are one of the earlier side effects that can manifest, which is why on follow-up and even while on therapy, every 4 weeks, we test our patients for TCH and we keep a close monitoring on RBS levels as well. That being said, when we are talking about urothelial cancers and we're talking about as an alternative to platinum agents, I feel these are still much more better tolerated as compared to cytotoxic chemotherapy. So it doesn't come with those kind of side effects that would come with conventional chemotherapies. And we have to have an eye out for endocrinopathies, no doubt.
When the target therapy we discuss and the side effects are there, then the agent, the medicine, whichever you are giving these agents, they are supposed to be more effective when we talk about various conditions. That if side effects are more, then efficacy is more. Is it true in this case?
Hard to
Because
comment. So that's something I know about
as
anti-GFR inhibitors for sure.
As a urologist, we say that if you are giving sunitinib, sorafenib, then if hypertension is there, thyroid problem is there, then the efficacy is better. It is, but the drug is working. So do we apply that here also, or here only we say that they are mild variety and milder than chemotherapeutic agents?
Right. So there is data in other targeted therapies that I'm aware of, but for IO agents, whether more immune-related side effects translates to actual higher efficacy or survival outcomes, I'm not entirely sure about that. But definitely compliance and also tolerability, keeping in mind the performance score of the patient, that translates to survival outcomes.
So the immune-related side effects are at par with the other agents like nivolumab and all, and for the duration, or they have some difference? Is there any class effect? that all these agents have almost similar effects, or pembrolizumab is different?
So PDN1 inhibitors, the endocrinopathies are a little bit on the higher side as compared to other agents where the pneumonitis would be higher.
So there the adrenal side effects are also we have seen in our
Yes,
patients.
hypophysitis can also happen
So
in
in
some rare
addition,
amount of
yeah.
patients.
So
Yes.
that is very carefully we have to use it, and also they are easily manageable side effects. So one should know that these agents are new and they have some difference, and accordingly we have to tailor our management, individualized treatment in these cases.
Yes.
So so I think this was wonderful discussion for it is almost a launch meeting here for pembrolizumab. It has a future in renal carcinoma we are already using, and for bladder cancer it has come big way, and we have now hope. And as has been discussed that overall survival is the endpoint which we are concentrating, and it is improving with the newer and newer agents. And pembrolizumab, when it is given now intravesically also, it is boon in disguise for urologists, because medical oncologists treat it with the different agents when it is advanced. But as the prospects are there now for non-muscle invasive also, and this has a big future. Thank you very much, Tanvi.
Thank you for the
Thank you.
opportunity.
And you want to say something?
So just I want to add one thing, because this pembrolizumab has been FDA approved for the BCG refractory CIS only, not the TA or T1 disease.
Yes.
And I think, sir, it is systemic in that class only. It is not local.
Yeah, that is the most difficult
Yes.
in our biopsy specimens. Also, we get CIS in the recurrence only in 3% cases, and it is not that common, and we need some treatment. Otherwise, we are going for cystectomies after that. So this is giving hope, and thank you very much for this, the audience and all the wonderful discussion. Thank you.
Thank you.
So I thank Dr. Tanvi Sood for her insightful presentation and explaining to a general urologist about the interests of the IU agents. So I will request Professor Dr. Rajiv Sood sir to please present a memento to Dr. Tanvi Sood, ma'am. So I now request Dr. Rajiv Sood sir to please present a memento to Dr. Amitabh Singh sir. Dr. Amitabh Singh sir, please can you come on the dais and accept your memento, please. So thank you so much. This will bring us to the end of this sponsored session, MSD Keytruda. So now moving on to the next sponsored session by J&J Ethicon. Can I please request our chairpersons, Dr. Sameer Khanna, Dr. Salish Shahai from Max Super Specialty Patparganj, and Dr. Arun Makkar from RML Hospital to please take your places on the dais, please. So it will be better if you sit on the side. Better if you sit on the side. No, better. So this is a sponsored session by J&J.
Good morning, everybody. This is a sponsored session from Johnson Johnson. I presume there will be a pre-recorded video which will be run. So let's start the first presentation. It's on science of bleeding management, the surgical powder and its application. To be presented by Dr. Vivek Iyer.
But Vivek, we are not able to hear you. Are we audible? Are you able to hear me?
Pre-recorded view on the burden
But आवाज आ रही है?
and the value of adjunctive hemostat.
Pre-recorded तो भी नहीं आ रहा.
Hi and greetings from Ethicon. My name is Vivek Iyer. I lead and assist for all the education initiatives that Ethicon does for the surgeons and healthcare professionals in India. And I would, at this point of time, like to thank the organizers for giving us this session and the opportunity to discuss with you on the burden of bleeding and the value of adjunctive hemostat. So surgery has essentially 4 big killers as per Professor Atul Gawande, and they are infection, bleeding, unsafe anesthesia, and what can only be called the unexpected. Now, we also spoke and discussed with a lot of surgeons before coming up with adjunctive hemostats as a solution. Because some of the comments that we came across were disruptive bleeding prevents me from moving to the next procedure step, where efficiency is the key. And bleeding slows me down by obstructing my view of the operative field, especially true when it comes to laparoscopic surgery, where a small amount of bleeding can also actually cause enough obstruction to stop you from proceeding in the surgery. Uncontrolled surgical bleeding adversely affects patient outcomes. From 32 to 68% of cases in open procedures experience major uncontrollable bleeding events as per some reports. The challenging and uncontrollable bleeding during surgery is associated with high mortality rates. And not only this, it also increases the cost of each of these procedures when that happens in a surgery. Various factors which contribute to this increased risk of surgical bleeding. And one of them is the patient factor, because currently there are a lot of comorbidities that the patient comes with, the advancing age that the patient comes with for various surgical procedures, and the various drugs that the patient may be taking for various comorbid conditions only leads to increased chance of surgical bleeding that a surgeon may come across. Patient medications which contribute to surgical bleeding in approximately 10 to 25% of the procedures is what some report says. And these drugs, which all of you are aware of, are like aspirins and clopidogrels and so on and so forth. Now, if this is true, and considering it true, there are various factors which lead to increased chances of bleeding in various surgical procedures. And not only are these patient factors, but there are also some sites and situations where when a bleeding is encountered, the chances of controlling this bleeding becomes a little difficult, or it becomes a little challenging. And at this point of time, I would want to highlight that in no way can these solutions replace the primary mechanism of achieving hemostasis during a surgery. These methods or technologies that we may talk about will supplement or complement these primary methods of hemostasis that a surgeon would try to achieve. Now imagine surgical situations where the tissue topography is uneven, which means an adjunctive hemostat cannot be easily placed. Similarly, there are difficult to control bleeding sites where compression could be difficult or challenging, wherein you may not be able to achieve or give compression because of the site or the tissue where it is involved. Similarly, if these sites where the bleeding is occurring is not easily visualized, and some other reasons like difficult to access, bleeding near critical structure, because of which energy devices may not be conveniently used in these places. And there are tissues where you want to minimize charring. So all these reasons would actually point a surgeon to consider a use of an adjunctive hemostat in addition to the primary mechanism, wherein the primary mechanism may not be able to be used at the fullest. This in addition to the patient-related factors like various comorbidities, previous surgeries that the patient has gone through, anticoagulant and antiplatelet therapies that the patient has on, and the aging population only makes it a little more challenging to control using primary mechanism, and hence an adjunctive hemostat comes into picture. Now, basis various interviews, suggestions from the surgeons that we got, feedback from the surgeons we got on the bleeding challenges and the situation, we could actually kind of summarize them into 5 different types: continuous oozing, problematic bleeding, difficult to access areas which bleed, potential rebleeding risk, and finally the high pressure vessel or the arterial bleed. These are some of the bleeding scenarios which can be summarized for any of these surgeries. What we're going to talk about now is only the continuous oozing part of the bleeding challenge and what could be the solution of choice that we would want to introduce. Now, surgeons experience this continuous type of bleeding in many surgical types, and they often resort to the use of topical absorbable hemostat in addition to the primary mechanism to control these bleeding when they encounter it during the surgery. One of the commonest, which is also our technology that we provide in India, is the Surgicel family of absorbable hemostat. Now, again, as I told you, basis feedback, there are different types of Surgicels which are available based on the bleeding scenario, based on the bleeding site, and so on and so forth. So, quickly taking you through, we have a family of Surgicel absorbable hemostat, which has 5 products now and has experience of more than 50+ years. And if you may have come across, this is nothing but oxidized regenerated cellulose, which is ready to use right from the package, has local site bactericidal activity against the mentioned organisms. It's fully absorbable in 7 to 14 days. And this helps in control capillary venous and small arterial hemorrhage as a family. So some of the options that we have and you may have heard of are the Surgicel Original, the Surgicel Fibrillar, the Surgicel Snow, and the Surgicel Newnit. These are different types of Surgicels that Ethicon provides. Now welcoming to this family is the newest member, which is the Surgicel powder that you see right in the center of this family. Now, Surgicel powder, as is the image in front of you, comes with a very unique device which only further enhances the deployment of this product and technology and helps in solving the continuous oozing bleeding problem in surgical scenarios. What is this? The Surgicel powder absorbable hemostat fulfills several unmet needs for continuous oozing bleeding. For example, and oozing can delay a surgery, and hence, when this product or technology is deployed, it has a better penetrating action compared to the other family members of Surgicel. It is 52% faster time to hemostasis than a Surgicel Original, the first of the hemostats that we introduced. It's more adherent and hence gives you a durable clot, has proven in vitro bactericidal activity, and is more precise delivery control during application, because of which a broader surface can also be managed much more conveniently. And because of the device applicator tips that you have as options, can use it for open surgery as well as a laparoscopic surgery, depending upon where you want to use it. A quick glimpse of the unique mechanism of action it has. Absorbable hemostat spreads across a large surface area because of its powder nature. It saturates, the blood saturates the material, providing a surface for platelet adhesion and aggregation, initiating a rapid clot formation. Works fast to stop the bleeding, and it forms a durable clot that won't wash away or rebleed when irrigated. And that is if it is rightly used for the right indication. Now, this is Surgicel powder, which got introduced very, very recently in the Indian market. What are the target bleeding scenarios that we can look at? And this is just an indicative list. There are many more surgical sites that can be used for the continuous oozing as a problem. So in gynecology or oncological surgeries, in procedures like hysterectomy and myomectomy, in cardiovascular surgery, in the general and hepatobiliary surgeries, in procedures like hepatic dissection, wherever there is a tumor bed or pelvic sidewall where there is broad surface oozing, surface of the pericardium, places or sites where adhesiolysis has been done and there is broad surface oozing, exposed wide raw surfaces of liver with multiple bleeding sites, and so on and so forth. So these are some indicative sites that I would want to show. But please remember, there are many more sites wherever continuous oozing is a problem. Having said that, this Surgicel powder is built on the proven Surgicel absorbable hemostat technology, and it just gets better with a better delivery mechanism and some other modifications which makes it act faster and act better. Before I stop, just again a glimpse of all the Surgicel family that you may have come across to be used as an adjunctive hemostat, and Surgicel powder as the newest introduction, which has the legacy of 50+ years of the Surgicel family. With that, I would like to thank the organizers again for this opportunity, and we can have questions if any at this point of time. Thank you so much.
Surgical bleeding definitely is a very problematic situation when there is a diffuse ooze from any surface, be it pelvis, which we are mostly dealing with in urological oncology. So Surgicel fibrillar used to be there, which we have been using quite often for a long time. Now they have come with a powder form, which we can spray, and it is much more efficacious and faster hemostatic than the fibrillar, which we used to be. So, yes, sir.
From the gut and you use this powder, will it cause adhesions?
So it is not to be used for gut,
Cirrhosis.
because it only penetrates in the blood vessels, capillaries, and then forms clots there.
I'm Dr. Sethia from Udaipur. Sir, any history of allergic reaction, or we have to be careful about that because it may be absorbing directly into the blood?
Till now, there is no allergic reaction reported as such with this material because this is cellulose.
Okay.
And basically, it's not the mechanism of action doesn't lie in penetrating the blood vessel. It just provides a scaffolding on which the platelet comes and they forms a stable clot. So usually it does not go into the blood vessels, just on the surface of those.
Thank you.
But again, it is not to be used directly over the bone when there is, chances of callus formation is there. It is not to be used, in the hollow viscera. It is to be used when there is diffuse ooze.
So can we use
The
it
liver
in?
surface may be there, splenic surface may be there, or
Partial
general pelvic surface it may be there.
Can
Works
we
only with
use
the diffuse bleeding.
when we are doing some partial nephrectomy or something like that, if there is a oozing?
Obviously, that would be the area we would be interested in because as till now we are using Surgicel and we are making bolsters.
Exactly, because our
So-
interest is that only.
Yes, so they claim that this powder form has 52% faster action. So it means it arrests bleeding in a much faster time as compared to the Surgicel which we are using, the standard one, original one. So I think there should be a role because other part already we have been using in the partial nephrectomy. So maybe this has a role, but there is no asset data because it's a very new product in the market.
Okay, so far we don't have any experience of using that.
Till
Do I
till now
have-
we have not used it in
We
partial
have not.
nephrectomy.
So this is powder form is a new formulation. Otherwise, we have been using Surgicel.
Yeah, that we are
original-
using. I'm
so
just
it is
asking.
just a modification. The surgical, after Surgicel came the Surgicel fibrillar, which is in the form of, foam or flaky.
That comes with the
material.
name of new
So
knit.
we used to
The same we are
peel
using.
it off and then apply there, or we can apply as a whole. So this is now a powder form has come, which they say that is more efficacious than that.
In my personal experience, this after radical prostatectomy robotic when you're doing, so we have been now using this new knit, the fibrillar one. It's the thicker one. So it's better than the Surgicel old one that we are using, but that's a very thin one and it's a very fluffy and fits well and give a good hemostasis.
Okay, thank you very much.
How much is the cost?
Cost the company people. will be
I think new knit is somewhere around 7,000-8,000.
7,000.
The larger one. There are two sizes, I think.
10,000 is okay.
So there are two sizes, I think. There is one bigger one, might be the 14,000 the bigger.
So coming on to the next lecture, which is for surgical smoke, a risk too real to ignore by Dr. Vineet Agarwal. And it has been come to focus in the times of COVID, how the surgical smoke should be evacuated in the OR. So can we have the presentation?
A very good evening to all of you, and thank you to organizing committee to give us the opportunity to interact with you today. My name is Dr. Vineet Agrawal, and I lead the Ethicon Education Solutions for India. And today I am going to present to you a topic called the science of smoke. The reason why we are talking about it now is because of this image, and it really reminded me of the situation we are in today. I'm sure you've come across this story of everybody, somebody, anybody, and nobody. And it reminds me of the time where surgical site infections were very common. This was before disinfectants and sterilization was common. And it was only when somebody discovered that because instruments, our hands were not sterilized, they were not cleaned, it was resulting in surgical site infections. And then the importance of microorganisms and how to deal with them. Now we are in a similar situation when it comes to smoke. Now smoke has been around, surgical smoke has been around since the time surgery started. Since the time there was introduction of energy sources. And because it has become such a part of the OR environment, it is accepted that there is going to be smoke and nothing needs to be done about it. But just like SSI, there is a lot of merit in dealing with smoke and to ensure that there is a smoke-free OR environment for everybody. So there are studies done, there are surveys done, and OSHA, which is a big guideline body for occupational safety, they did a survey and found out that more than 500,000 healthcare workers are exposed to surgical smoke every year. And when they did a survey with around 500 nurses, they found that 3/4 of them had at least one symptom related to surgical smoke. One of these symptoms could be, a cough, irritation in the eye, headache, and so on. And when further studies were done of the actual smoke, which is captured, so they found out the contents of the smoke, and they came down to these studies where if you're using, say, an ESU, which could be a monopolar or bipolar, every gram of tissue that you burn is equal to inhaling 6 unfiltered cigarettes in 15 minutes. And there are also studies which are showing mutagenicity. So the smoke, just like surgical smoke, just like cigarette smoke, even surgical smoke has the potential to cause some harm equivalent to cancer. So what I'm trying to say is surgical smoke is dangerous. You need to think about it. You need to be aware of it. However, there is no study showing the safe level that if you're exposed to half an hour, or if you're exposed to a certain volume, then you'll be okay. And beyond a certain point, then you need to really worry about it. So we're going to explore smoke more in detail. What are the components? What are the potential risks to you, the patient, and anybody in the OR? And what are the practical steps we can take today to manage smoke? So first thing for us to understand is smoke can be created by a lot of devices. So anything which is energy based, whether it's a drill, pencils, saws, even lasers, all of them are going to create a surgical smoke. And what may differ is the size of the particles, the volume of smoke, etc. So we're going to deep dive into what is surgical smoke, why is it a health concern, and what can we do to reduce the risk. So surgical smoke is also known as cautery smoke or smoke plume or bioaerosol. It is essentially cellular fluid, which is around 95%, and released as steam. And it can have both organic and inorganic compounds as the 5% of the particulate matter. And this particulate matter can also be bacteria, fungi, virus, etc. In all the studies that I've done till now, they have found live cellular material, blood fragments, viruses, bacteria, and so on. Apart from the chemical compounds, which I will talk about in a bit. And the biological matter, which can be live also, they are carrion aerosols in both open and laparoscopic surgery, as well as the particle size. It varies between 0.01 to 200, but the majority is between 0.3 to 5. And why that is important is, if you see all the filters, you might have heard recently because of COVID, a lot of filters being talked about, HEPA filters, ULPA filters. So they all give you a measurement saying that it will effectively filter out 99% of particles between 0.3 and 0.5. And the reason being, majority of your particles are in that range. So apart from biological matter, the compounds which were found, formaldehyde, benzene, carbon monoxide, hydrogen cyanide, you already know these are harmful compounds which we should not be exposed to too much. In one of the studies that was done, they found all these bacteria and viruses in smoke. Such as Hep B, HPV, HIV, tuberculosis. And what was also interesting that when they took these bacteria and viruses and they tried to culture it and grow it, they found that they could be regrown. So what it means for you is there is a potential of getting infected even through surgical smoke. So our body does have some mechanism to counter smoke and take care of it. But when you study the respiratory tract, the bigger particles, yes, they do get trapped in your nasal cilia and even in your throat and bronchus. But as the particle size decreases, so you saw the particle size was 0.3 to 0.5, they reach the alveoli and they tend to lodge themselves, which results in chronic diseases. The other cause of concern is we have a sense of security, that, okay, only the people who are around the OT or around the OT table are exposed to smoke. If I'm sitting somewhere far, if I'm an anesthetist or if I am a biomedical engineer and I'm sitting somewhere away, I'm not exposed to smoke. That's not true. Because of the airflow systems you might have in OT, sometimes laminar, which is even faster. The moment smoke is released, it travels throughout the OR. And no matter where you are going to be exposed to the same amount of smoke as the surgeon who's on the operating table. And even after the procedure is over, it takes 20 minutes for the particle count to reduce, which means that anyone who's coming to clean the OR, to take the patient away, they are all still getting exposed to smoke. And all ORs have a duct system where you have your laminar flow or regular air conditioning, where the air is getting changed maybe every 10 to 20 minutes. But they don't have filters. Like they may have a HEPA filter, but there is exposure happening before the filtration is happening in the duct. Even for the patient, there were studies which found that in laparoscopic surgeries, the patients absorbed this surgical smoke, some compounds, and benzene and toluene were found in the urine samples. Apart from that, as a surgeon for you, this is something you've already experienced. You have, if you're doing a laparoscopic surgery, you have to regularly maybe degas, open the vent of the trocars, take out the smoke, and again go back in because of reduced visibility. And doing all that can increase the overtime and also increase the risk of complications because you're not seeing well and you're having to do multiple instrument exchanges. So what do we currently have for surgical smoke? So one is your own mechanism that I spoke about just a while ago, your own ciliary motility and the mucus, which can filter out particles. But what happens with long exposure is the ciliary motility is damaged. So it's not moving back and forth as effectively. It's not capturing those particles as effectively. So that's not something for us to rely on. The other things which became very much in focus in 2020, all your different masks and respirators. So the N95 masks. So what N95 is, 95% of particles that are more than 0.3 microns. Now it's a good, it is a good way to filter out smoke, but it's difficult to breathe. It's not the most reliable. If you have facial hair, it's not going to stick properly. There's always going to be some smoke that you're going to inhale. PAPR was used a lot by anesthetists and endoscopists who are getting exposed to secretions a lot. So it's a full face covering and it has its own breathing mechanism. So although very effective, but you can't be wearing this every day in the OR. The other things are your non-woven mask and cloth mask. They're practically useless because it's a loose fit and you are inhaling smoke. The other things which came in focus were HEPA filters. So HEPA can filter out 99.9% of particulate matter more than 0.3 microns. So it is a good filter. However, the disadvantage of fitting a HEPA filter, exclusive HEPA filter, the machine has to be on all of the time. It's noisy and it has to be within 5 centimeters of surgical field. Having a HEPA filter in your duct system is not going to help. ULPA filters, even more fine or even more advanced, they can filter out 99.99, almost 100% of particles more than 0.2 microns, which is even smaller. These filters are used more in semiconductor industries. The particle size is very fine. The exposure of the workers there is very high. Is it feasible to do it in a hospital environment? Maybe not. Some of you may be using wall suction, just suck out the air, but that's only suction. There's no filtration. That air is being circulated somewhere. So when we look at the different energy sources that we use and the solutions or ways in which we may be handling smoke, you can clearly see that different energy sources create different sizes of particles. And that's inherent to the energy source itself. So surgical mask, you can see all red. It doesn't help you with anything. N95 will help you against slightly larger particles, but not the smaller ones. HEPA is slightly more effective, and ULPA is one of the most effective filters because of the particle size it can capture. So what solutions do we have? So there are dedicated smoke evacuators. You might have heard about them. They can be attached to your energy source. So if you're using a monopolar pencil and there's an attachment for it along with a tip. So the smoke gets evacuated as soon as it's getting generated. And this can be used for laparoscopic surgery, open surgery, robotic surgery, and they are adaptable to open different energy sources, whether it's monopolar, bipolar, ultrasonic, and even advanced bipolar. And they switch on only when you activate an energy source. They use ULPA filters, which can remove 99.99% of particles 0.1 to 0.2. And we saw that ULPA was the most effective filter out there. There's no noise, and you can adjust the flow rate or the suctioning rate depending on your preference. And over the last 2 years, there have been many best practice recommendations that around PAPRs, which are respirators, should be used for personnel who are using or exposed to endoscopy, bronchoscopy, extubation, etc. Smoke evacuation devices were called out specifically to handle smoke. Clean rooms are favored over HEPA filters. So what that means is they should be treatment, or you should be managing smoke where it is creating, where it's being created, rather than depending on your filters in the duct system of the OR. Apart from SAGES, there are other guidelines. NOSH, OSHA, AON, all have given a lot of emphasis on managing smoke and what every employer needs to do for the employees. In this case, what the hospitals need to do for all the OR personnel. Even AON in 2017 gave guidelines for surgical smoke safety. I'm sure we'll be able to share this with you. It's commonly available. And it has detailed guidelines about how the team should be managed and what are the precautions we all should be taking. Apart from that, there are other countries which have given guidelines. Now, in all of this, unfortunately, you will see that from India, there are no specific guidelines. Even when you look at NABH, which is our main body, they also mention smoke in passing, that there should be ventilation in the OR, etc. But there are no dedicated guidelines of smoke management. And that brings me back to the first slide I showed you about that somebody, anybody, nobody. So we need your help, we need your support to create awareness, to push for more policies, guidelines around smoke evacuation. If you wish to know more about smoke evacuation devices, please feel free to reach out to the Ethicon sales representative at the hospital you're working, and we'll be happy to help you with more information. We can also conduct these sessions for the stakeholders in your hospitals, whether it's the nurses, surgeons, biomedical staff. So please feel free to reach out to us, and we'll be happy to help. Thank you so much for your patient listening.
I'm sorry to the organizer, we couldn't stop it because it was pre-recorded. Just one question from my side to Dr. Neja, Dr. Rawal. Sir, during COVID times, were you using any smoke evacuator device, and did it help?
We had a smoke clearance system at Apollo, but I think, this becomes superfluous the way we work. It is not as, and finally we gave it up.
So didn't you feel any problem of decreasing the pneumoperitoneum? What I felt, I use this and it detects the smoke very fast. So even if you don't want suction and start sucking, your pneumoperitoneum is gone.
So that's
the problem I faced.
Nuisance. This is what we felt. We are, as surgeons, we have very little patience. So that is how it works. So it is maybe somebody else may be happier, and technically, yes, it should be used, but as surgeon, as we are impatient, sometimes this happens.
Dr. Rawal also. So were you using smoke evacuation device during COVID, and were you satisfied with it?
Yeah. We actually bought 3 more COVID this suction device during COVID time, because 2 robot and laparoscopy. They are quite beneficial. Only thing, the running cost is high. They say that filter works for 4 cases, it works for 2 cases only. Uh, uh, COVID or no COVID, I think they are useful device. But if you are using air seal, then you don't need them. In laparoscopy or robotic, if you are using air seal, then you don't need them.
Thank you. That brings us to the end of the session.
So this brings us to the end of the session. So I'd like to thank the chairpersons for their insightful comments and chairing the session. May I request Dr. Rajiv Taneja sir to please present a memento to the chairperson, sir. Thank you, sir. Dr. Sameer Khanna, sir, please. Sir, can you come on the dais and please accept the memento? Yes, sir. Dr. Saleh Sahai, sir, please. And Dr. Arun Makkar, sir. So this brings us to the end of this session. The next session is sponsored session by Intuitive Surgical India Private Limited. May I request the chairpersons to please take their places on the dais. Dr. Ajit Saxena, sir, Dr. Rajesh Taneja, sir, and Dr. G.S. Kocher, sir.
ये बंद कर दो यार, ये इसमें लगा दो। ये लगा। इसे बंद कर दो। मैं ठीक हूँ, दोबारा।
Good morning, everybody. I welcome you to this intuitive session. And with me is Dr. Ajit Saxena, who is the pioneer of robotics at Apollo, Delhi. And I'll ask Dr. Ajit Saxena to invite the first speaker.
Thank you very much, Dr. Taneja. Now, the first speaker is going to be none other than Dr. Sudhir Rawal. And he's going to talk about newer advances in Da Vinci intuitive robot. Dr. Sudhir Rawal needs no introduction. He's all in all in Rajiv Gandhi Cancer Center.
Yes, sir. Thank you, sir. Just sorting out some problem of audio visual.
So while we are sorting out the technical problems, let me share something about Dr. Rawal. Dr. Rawal is the director of Rajiv Gandhi Institute, and he's the one to whom everybody looks at when there is some innovation in robotics, whether it is a technical robotic issue or whether it is a surgical robotic issue. So Dr. Rawal, are you ready now?
Yeah, they're just sorting out some.
Okay, they are sorting out. So if you have any problems, whether it is a surgical issue or whether it is a technical issue, we all look up to him. And
I want to reassure Dr. Rawal that there are over 500 persons watching you through the internet.
Thank you, sir.
yes,
Yeah.
Dr. Anup, that's the advantage. So innovation is very important. And today, if you see why we are using robotics, it is because we innovated from open to laparoscopy to then robotics. And now robotics to what next is artificial intelligence. And perhaps, as we were talking yesterday, it is about programmed surgeries. So you feed the data of a tumor in the kidney as an MRI, like we have MRI fusion biopsies. So we have something like that. You just need to put ports and give the anatomy of the renal vessels and everything as a 3D into the MR, where it can differentiate between the normal and the tumorous growth. And then let it be. You just be there and let it be as an autopilot. So I think that is what is the future of robotic surgery.
Quite right, quite right.
Okay.
But Rajesh, I want to
Okay.
ask you, you worked on the standard SI.
Yeah.
Okay, we are good.
And
Shall we?
Okay.
Yes, yes,
Please,
of
please,
course.
please.
Thank you. These advances have come in last 20 years. If you see, I made comment yesterday that if we would have had more company, probably we would have had more advances also. But then they are there. They're very good, and we have used all of them. One is the Sureform. Sureform is the stapler device. There's a small video which is I'm going to play. This is the stapler, which actually gets attached to the robotic arm, and everything can be controlled by surgeon. You need not to depend your assistant at all. They are very good for intracorporeal diversion, like ileal conduit and neobladder for urologist. But and more than us, I think it is GI surgeon will be benefited with these devices. And the existing foot pedal are used for firing them. You can see how flexible, how maneuverable, and how much angle you can have with them without any, difficulty. So this has got 120-degree of cone of articulation, smart fly technology, single patient use, no reprocessing. That's probably a disadvantage for our country. Anvil-centric design, reload dose to the anvil, and then operates through a 12-millimeter cannula. You have to change the cannula when you are planning this surgery. Using them, you have to have another cannula. Under that, the robotic cannula goes. Available for the Da Vinci X and Xi. SI they don't have. As I told you, this is 120-degree cone of articulation. You can see how much angulation you can do inside the abdomen. And so it's completely surgeon's control. You need not to depend on your assistant when they have to fire it, and you are just holding the intestine. These are the reloads, 5 reloads, gray to black, 6 staple rows in each reload, 12 fires per device. There is a device. There's actually a device on this stapler they get attached. That device actually can fire 12 reloads, and that device is only for one use, which is around 20,000. And reloads, they have reduced the cost even lesser than Johnson and Ethicon and Covidien. So ultimately, if you ask me the cost in a neobladder, we landed up in charging almost 40,000 from the per patient. Then next innovation which they have done is forced bipolar. And this is bipolar, which they have augmented with the dual grip technology and bipolar functionality and efficiency-led innovation, which they have done. This is a stout bipolar, stout fenestrated bipolar. And these are its feature that it actually takes one more function of needle driver, mega needle driver. So you can use this device as needle driver. So you can reduce the cost around $170 according to the cost of the Western market. I have used this. Using this in the lymphadenectomy is a bit problem, is because it's a stout, but it's very good. It has got very good grip, and when you suture anything, this is very handy. Many of our surgeons like me, I use fenestrated bipolar as a next needle holder. I do not use this, but many times we got this instrument because they said this is good. So we tried it. We are not using it rarely. We are using it rarely, but then probably in GI surgeon and other surgical specialty, it may work. But it's a very good instrument. It has a grip which can be activated from the yellow pedal on the left side. Then you all know, I think everybody has this Firefly fluorescence, which has multiple use, not only in the partial nephrectomy, you can use it for even highlighting the nodes, lymphadenectomy, or people are using for sentinel node also in gynae-oncology surgery, where you inject the indocyanine green dye, and then you can take out the lymph node, or you can do the partial nephrectomy, where in partial nephrectomy, you can use to define the vessel also. You can clamp the vessel first and then see how much of the supply going to the tumor. If you have two vessels, or you are going for a dissection into the hilum having the multiple branches, so one of the branch you can clamp and then give the dye. So that will tell you, okay, how much the kidney tumor is unperfused or perfused, or else you can inject it in first and then clamp it, and they can define the tumor and the normal parenchyma, where it is used in these cases. And this is in X and XI, both the robots. There is another device which is we are using monopolar. They are saying this is advancement, and advancement is because probably in the beginning they came with the hook. There was no monopolar scissor, hot scissor. They came with the hook, and most of the surgery were done by hook in the beginning. But then they came with this monopolar hot shear, which is very popular now. And I think most of the surgeons love using this device, including me. And it has got auto cut, it has got dry cut, it has got classical coagulation, it has got swift coagulation, it has got forced coagulation, depending on the pedal which you are using. So these are few advancements which Intuitive has done in last 20 years. And I think the way the things are going on, we will have more and more advances in the robotic field. Thank you.
Thank you, Dr. Rawal. I have a question for you.
Yeah.
So suppose you were granted that whatever you want, you will get it. So what is the innovation in your mind that you need in the next, say, 5 years? That, okay, I want this.
Yeah, that's a very good question. You should have told me before so that I could have thought. But definitely, I would like to probably have some automation. So where actually we do not to be very, where there are steps where not much skill are there once you define the pedicle. And when you just press the button, let the robot take over, and you are just watching. Yes, it's doing perfect work. That is probably, I will think, like involving AI in this. And instrument wise, I have a thought of many, but I don't remember now because.
So I will ask, why I ask this question is, unless we as surgeons ask these questions to the engineers, they are not going to produce.
Yes.
So we need to take lead in these innovations, and we need to drive them to think that, okay, this is what we want.
Yeah, many times actually we did suggest them few things, but they don't
So let
acknowledge
us make
the
a
surgeon.
charter. Let us make a charter. All of us who are using high volume robotics, we can sit down amongst ourselves and we find out, let it be a
No,
closed meeting.
you do that, you even many times they come to and ask you.
No,
Problem
that
is
when
they
we are
do
not
not.
prepared. That is when we are not prepared, like I asked you. So let us sit down, have a brainstorming session,
You
create
can
a
do,
chart.
but problem is, Rajesh, they will never acknowledge you. They
It's
will make the
okay.
instrument. They will never acknowledge you that this was done by Dr. Rajesh Taneja. They will never give you money. Rather, they hunt for these ideas.
No,
Many
so
times they hunt for these ideas.
exactly the only way to get it acknowledged, get it documented in a session like this. That, okay, whatever we do in a closed group meeting, we present a PPT in USI. And after that, if the Intuitive comes up, they have to acknowledge our contribution to that.
Yeah, hopefully, let's see.
I think that's
we
a good
can
idea.
definitely think of depending on the
It
situation.
is a good idea.
Yeah.
Which can be taken up.
Yes.
You have to lead the.
Okay.
Yeah.
Sure.
Thank you very
Okay.
much, Dr.
Thank you.
Rawal. Thanks for the nice talk.
The next talk is on robotic partial nephrectomy in T1B renal tumors
by Dr. Anup Kumar.
So thank you, respected chairpersons. We were discussing what we want in future. And I just want to carry on the discussion. We were discussing with our Ethicon guys and the persons who make harmonic. And we have a robotic harmonic also. So what I told them that we want the robotic harmonic same as we have now the advanced harmonic scalpel, which can be like a Maryland. You can dissect, you can cut and coagulate at the same time. That we don't have currently, and it will not take more time. It will just take, I think, few months, and they can come up with that probe. Number one. Number two, the harmonic which we have currently can coagulate up to 7 millimeter. If we have up to 1 centimeter vessel can be coagulated, you don't need any suture for DVC. This is the next advancement we are thinking, and that's possible. So I think that's how we can.
Yeah, one of the
and we can-
difficult portions of surgery is the DVC, and we cut it and we make it bleed and then we stitch it. I think that wastage of 20 ml of blood also can be saved.
Yeah, that's how. Okay.
It is not about the 20 ml. It is the vision and the beauty of the surgery that it spoils. That is important. Thank you. Please.
Thank you, sir.
Applier by Da Vinci, clip applier by Da Vinci. It takes one clip and then you apply again.
Yeah.
They have done it for money again, but they are a company who are developing multiple clip applier. You just need not to detach it. Just keep firing, cutting, keep firing, cutting. This is going on already.
So
That is one
multi-loaded.
field which they should do it like this rather than you take one clip and put it. So they count actually for this thing. That's the problem with that. They everywhere they hunt for money. That's the
And
biggest
assistant
problem.
finds it difficult to ligate to clip the ipsilateral lateral pedicle of the
Absolutely.
prostate.
If you have this, you can use the clip
And we
applier.
should have dissolvable clips so that they don't migrate into the bladder later on.
So I will be talking about the robotic partial fracturing, some challenging cases. And this was the first case, 60-year-old male. And he was instantly detected to have this tumor. You can see in the CT scan, a 5.1 centimeter tumor in the left side kidney. It was going into mid and lower pole and abutting the PCS. And this was clinical T1B and renal score was NX Hyler. So we planned for robotic left partial nephrectomy. So these are typical instruments which we use for robotic partial. I think this is for our young urologists who are watching this live telecast. The Maryland scissors, programs, needle drivers, air seal if you have, it is really a very good armamentarium in your pocket. Hemolock clips and applier, lap Maryland scissors, 2 or 3 vlog suture. So the sutures, if you have, suppose you have to repair any vessel, suction device, and open instrument trolley. So this is the typical position of the kidney which you use either on the right or left side. And we are using exercises, all the ports are in same line. That's our air seal port, which we use in obese patients or complex tumors. So this is a small clip. And we start with the colonic mobilization. And there is no need for dissection of ureters, except in patients having a big lower polar tumors. Otherwise, you have to go straight away for the renal hilar dissection. So to get into that plane, once you get into that plane, then the hilar dissection is becomes very easy. So our aim is to clear this hilum inferiorly and superiorly. So they should not be in tissue superiorly or inferiorly. That's like a 2-window technique. And here you can see we are dissecting one of the renal artery branch, the renal vein. They've been dissected and looped. And in this case, we typically clipped and ligated the gonadal vein because it was obstructing our view of the main renal artery. It's not required in all the patients. And once that, we are directly onto the main renal artery. So that's our aim. We always loop all the vessels, although we will clip only one of them, but we loop all of them. Then, of course, the kidney has to be mobilized all around because it's a posterior tumor going into the close to the hilum. the kidney is flipped towards us. Now we use this intraoperative color Doppler in all patients, whether it's laparoscopic or robotic. And that gives us a good view of the margins which you have to take. Typically, we take 2 to 3 millimeter all around. And typically, if patient can have an endophytic component also, so that ultrasound will help you how depth you have to go when you are dissecting and cutting. So that's here we are marking the tumor all around. Now on this patient, we clamped the renal artery only, and we are cutting in the scissors. And you can see the fourth arm is giving the traction, and suction is being used. And we have got a very good plane. So once you've got the plane, you just keep on following it. There should not be any tumor violation or tumor spillage. And you can see now the tumor has been dissected all around. Of course, with the robotic vision, we can see PCS opening very easily. So I always close the PCS separately with a 3O vital suture. We have never come across any urinoma or any other perinephric collection because we always close it separately. So that's our PCS closer. And then we go for the 2-layer rhinography that we use for all the patients. So once you have done the PCS repair, so typically I use a 2O and a 3O V-lock suture. So this is the 3O V-lock suture for the first layer. And we're taking cinching sutures, deep bites. That will take care of all the small bleeders which are there in the bed of the this tumor. And that we goes from one side and come out on the other side. So definitely the robotic assistance will help you in decreasing the warm ischemia time. And typically we have around 15 to 16 minutes of warm ischemia time. In complex tumor, it might exceed to 20 to 21 minutes, but never more than 25 minutes. And now we are applying. So now when we're dissecting that, there was, because it was approaching to the hilum, there was some opened veins, and that we came across. So we clipped, dissected and clipped those segmental veins which were coming there, because they were not visible when we were cutting it, but now they are visible, and that we are now clipping and cutting. So once we have taken care of this, then we have declamped the artery, so as to we can decrease the warm ischemia time, and now start the second layer with a 2O V-lock suture. And again, we apply a reinforcing Hem-o-lok clips on either side so that it provides good hemostasis. As we were doing that, again, we found a small bleeder in the hilar area right there. So there was small segmental, one more renal vein, which was bleeding. So, but the good thing is, because we have already unclamped the artery, now there might be some bleeding, but you can take care of that by properly dissecting that particular twig. We can now found the twig there, and we will clip that twig. So once we have clipped that twig, then we can go ahead with the second layer. So then because it's a hilar tumor, you will see the second layer of rhinography, we have modified it. We are approximating the upper part and the lower part, but in the middle part, we are keeping it open because there is no parenchyma to support. So this is how you modified your rhinography in complex hilar tumors. And the robotic assistance definitely helps you in dealing with complex tumors and avoiding complications, avoiding positive surgical margins, decreasing warm ischemia time, which we call as trifecta, that you can achieve a perfect trifecta with a robotic approach for complex tumors. That's now we decrease the pneumo to 8 millimeter mercury, and we look for any bleeding. And then using this flow seal or T seal is optional. If you have, you can use it, but not necessary in today's era. Only if you feel that there is some oozing, then only you can use it. Now, so this is a specimen. A second patient, again, small clip, 70-year-old male. And this patient again had a 4.8 centimeter tumor. It was again near the hilum tumor, one more posterior hilar tumor, but this patient had 2 accessory arteries. So there were multiple renal arteries we have to dissect. So that's why I'm showing this. This T1B, 8P is the renal score. We always use renal score just to assess our technical difficulty. So this again, very small clip I'm showing, and colonic mobilization, that is standard step. I will just fast forward it and go for the hilar dissection directly. So the hilar dissection, I said, we have to take care of all the accessory vessels one by one, loop them. And not necessary to so this in the like, because in this patient there was ureter right in the closure of the hilum, so that we have just dissected in the close to the hilum, but not necessary to dissect the ureter otherwise. And this is the hilar structures we are dissecting now. So the hilar dissection, I think, is the most important part of any partial nephrectomy. Once you have taken care of all the hilar vessels, your job is perfectly 50 to 70% done. So this is the first renal artery axis we are dissecting and looping, and gently then we are going for the further dissection. Sometimes you are in a very obese patient, you have a very sticky fat which is covering these vessels. You have to be very patient and try that, you gently dissect the hilum, especially the small veins you can injure, they can bleed. So especially the posterior lumbar vein. So therefore you have to be very careful when you're dissecting the venous structure. This is the second branch of the artery we're dissecting and looping. And so now by going for the final one, and that's the third one. So all the two accessory artery in the main renal artery we have looped, and we have cleared the hilum inferiorly and also the superiorly. So there is nothing below and above. Now we are going for the perinephric dissection, mobilizing the kidney. In all posterior hilar tumor, you have to mobilize it totally like we do for a lap donor, and you can flip it towards you. That's our aim, so that kidney is totally free and we can flip the kidney towards us. So that's how, now that's a tumor you can see. It has got 80% was exophytic and 20% was endophytic. So always use the Doppler, intraoperative Doppler. We mark the margins, we know the depth, how much depth you have to go. And there how we plan our excision, how we are going to approach this excision of the tumor. So now we are marking it and then we start cold cutting it. So now before that we will clamp the vessels, the only arteries will be clamped. Sometimes we go for very super selective arterial clamping so that we can further decrease the warm ischemic time. But overall, I've seen that the warm ischemic time of around 15-16 minutes is a very good, our target. If you have, then you will have very good functional outcome in the post-op period. So this is the tumor dissection we are doing. Good. Once you are going to the PCS, that means you are in the right plane because you have opened up the PCS, and then you just keep cutting it. And that's the tumor is separated now, and then we go for the same steps. So this I can avoid now in the interest of time. But as I said, the PCS closure, they're all the same. I do first PCS closure and then the rhinorrhaphy in 2 layers. Again, it's a posterior hilar tumor, so the rhinorrhaphy, it will be again modified. Will not approximate in the middle part. We only approximate in the superior portion and the inferior portion. So this is known as modified rhinorrhaphy for hilar tumors. And finally, we don't use any bolster and any hemostatic agent because this rhinorrhaphy is so good, the hemostasis is very good. We don't require that, but in some patient you might require the hemostatic agents. If you want, you can use that. So now that's the final picture, and then we decrease the pneumo to 8 millimeter, and we look for that's the perfused kidney and specimen is delivered. So okay. And the last small picture, this is the patient having this is a big tumor, this was the recently done 7.8 centimeter. It's a really interesting case, hyperdense mass in the upper pole of right kidney. You can see there, and there were multiple cysts along with that, and single renal artery with early branching. That was again one thing we need to look for. So it was a T1B, and renal score was 9A. It was anterior, but it was looking not, if you look at the picture carefully, this is not a typical clear cell RCC which you find. We were thinking we are dealing with something not typical clear cell RCC, and therefore, if you look at this video, small video, colonic mobilization is done, and
Doesn't look like a typical.
so I will just fast forward it, and this is the hilar dissection.
It's
The
not
renal,
an angiomyolite,
we are going towards
because the
that.
angiography is not.
So what, the two things, one is the tumor is big and the consistency is not like a typical clear cell RCC. So these were the two things. And third thing was early early renal artery branching. So there are three things which were particular in this particular case. That's why I'm just highlighting those. The ureter was dissected only near to the hilum, otherwise not required to dissect the ureter. And then we go for the hilar dissection. This is the main renal vein being dissected, and we will dissect and loop it. So after looping of this, and then that's the main renal artery, you can see there. So now you can see the tumor we are dissecting, and that's the tumor. Because look at the consistency of the tumor. This is not like a typical clear cell RCC, and it was the upper polar, and the tumor, the fat was sticky on this tumor. I mean, it was like a dapsoplastic reaction. It was sticky on the tumor, but we still we could separate it. So the tumor was dissected all around like this. So you can see that's the tumor all around, and the hilar dissection, it was a single renal artery and vein. So now, as you can see, this is a simple cyst in the vicinity of the tumor, and we are using the intraoperative Doppler, small one more cyst. So we took this cyst along with the incision marking because this is a very small cyst. We thought we'll cut this cyst, and this is around 2 millimeter margin we are taking in help with the Doppler sound right there. So it was again 80% was an exophytic, 20% was endophytic. So that's why the ultrasound helps you in the depth perception, how deep you have to go to take the good margin, which is negative margin. And that's how we are marking here. That's it. That's the marking we have done. That's a tumor. And now we're going for the clamping. So we'll clamp only the artery, as we do normally in 99% cases. And that's the artery which is being clamped and the vein being looped. So now we are dissecting the tumor. So now again, we got into very good plane. We opened up the PCS. Once you open the PCS, then you just keep following that. We always get into a very good plane. And then just by gentle traction, you can remove the tumor. So our main aim was that they should not only tumor spillage and negative margins. That is our first aim. And of course, we should preserve at least 50% of renal parenchyma. So that we are preserving here. 60% is being preserved, and the tumor is dissected now. And then, of course, we repaired the PCS and then the 2 layers of renography. That I can fast forward in the interest of time. And this is the first layer. So the typical technique which we use in all the patients, first layer and that's the second layer. That's the second layer completed. And that's the final clip we are applying right there. And then we unclamp the artery and decrease the pneumo to 8 millimeter mercury. Okay, so that's the tumor. Now you can again see the what is the final picture. It doesn't look like a normal, and this is the papillary renal cell carcinoma. That's what we are expecting, that it's not a clear cell RCC. So this is our plan: early mobilization, chest physiotherapy. We typically remove the Foley's in first post-op day, drain removed in second post-op day, patient discharged in second post-op day. So we are concurrently doing this trial between the robotic and the 3D partial, and I'm not going into the details of that. So I just want to conclude that the robotic partial, in comparison to 3D lab partial, what we have seen so far, especially in T1B renal tumor, the lesser mean OT time, lesser blood loss in robotic arm, lesser warm mixture time. However, similar intra-op and post-op complication, similar positive surgical margin, and comparable trifecta rate. This is what we have found in the around now we have 50 cases in each arm, and the trial is still going on. Thank you very much, sir.
Any questions from the audience? Dr. Anup, did you ever need to use absorbable Hemalock clips in the hilum?
No, sir. We never use absorbable Hemalock clips because firstly, we try to always dissect the hilum before clamping, and we try to clip before clamping. Only in one first case I showed that in that case, we skipped those small tributaries of the veins, but in that case, we use the normal Hemalock clips. So we don't use the absorbable Hemalock clips.
Dr. Anup, you mentioned that there are similar results with 3D laparoscopy and robotic. If it was your relative, which one would you choose?
So again, as I told you, sir, the three advantages in robotic arm, the warm shear time is lesser, the blood loss is lesser, and it is faster. And the fourth thing which I did not compare is the ergonomics. That means the patient, the surgeon's comfort. So definitely these four things are in favor of robotic. And therefore, my message to all the youngsters who are always watch this, that if you have a robo and patient can afford it, go for the robotics, because that definitely is better than laparoscopy. But if there is a problem of cost, you should not deny the patient benefits of minimally invasive surgery just because you don't have a robot. You can do justice with your 3D lab or 2D lab, whatever you're comfortable, and you can still deliver the goods. The trifecta rates, pentafecta rates are comparable to robotic. Whatever trials we have, although some trials have favored in favor of robotics, but still we have trials which are saying both are comparable. But I do agree, robotic is better than lab in these aspects. And if a patient can afford it, my choice would be robotic. I'm pretty sure about that. Sir. Thank you. Thank you, sir.
Thank you very much for a very excellent exposition, Dr. Anup. A round of applause for the.
Thank you, sir. And we'd also again like to thank the sponsors of the session, Intuitive Surgical, for always coming and supporting various programs of the North Zone. And as a token of appreciation, we'd like to give a memento to our chairpersons and also to our speakers. So for that, I would like to invite Professor Mahesh Desai, sir, and Professor KK Sharma, sir, on stage, and both of them, sir, chairpersons. Dr. Mahesh Desai and Professor KK Sharma, sir, to give a memento to our chairpersons. Sir, either, sir.
Dr. Mahesh Desai will give memento.
Professor KK Sharma, sir, to Ajit Saxena, sir. And to Rajesh Taneja, sir. And Kocha, sir. I would also request Mahesh Desai, sir, and KK Sharma, sir, to give a memento to Sudhir Rawal, sir, and Anup, sir. Thank you, sirs. And now we are going to have another sponsored session. This is going to be sponsored by Novartis, and for that we thank them for actively participating inside our conference of North Zone. And the chairpersons for this session would be Professor Rajiv Sood, sir, Dr. Sudhir Rawal, sir, and Dr. Manasa T. Could you please come and take a chair? Now for the proceedings, I would like Rawal, sir, to take over the proceedings, please.
Can I call Dr. Atul Sharma? Dr. Atul Sharma is here? Eh? Online. He's going to- Online, okay. Okay, he's from AIMS, I think. Dr. Atul, are you online? Can you hear us?
Yes, sir. Yes, sir. I'm
We
here
can't
only.
hear you.
Am I audible?
Yeah, now you are audible. So Dr. Atul Sharma is going to speak on target therapy in metastatic RCC, optimizing use of first line treatment options. Dr. Atul, please go ahead.
Thank you, sir. A very good morning to everybody. Can I have my slide set here? So the topic of this session is targeted therapy in metastatic renal cell cancer. What are the first line treatment options? Next slide. Next slide. So the management of metastatic RCC has undergone a tremendous revolution in past almost 15 years. The first tyrosine kinase inhibitor, sorafenib, was available in 2005. And now we have numerous TKIs as well as immunotherapy coming into the first line therapy. And here in 2021, we have going ahead towards the combination of TKI as well as immunotherapy. Next slide. So these are the 2019 guidelines. This is 2021, but we can see, I'm not going to discuss the cytoreductive nephrectomy part, but in 2019, the category 1 recommendation was for tyrosine kinase inhibitor, both sunitinib and pazopanib. They were the first line category 1 options. And within 2 years only, now we have immunotherapy TKI combination as the first line. We have multiple options such as, next slide. We have multiple options such as pembrolizumab in combination with lenvatinib and pembrolizumab in combination with axitinib. On the other hand, nivolumab in combination with ipilimumab or in combination with cabozantinib. Here, but this option remains practical to very few patients, in particular in our country, because the cost involved in the management of immunotherapy because of the immunotherapy. So a lot of people are not, majority of people are not able to afford immunotherapy. So the practical first line option remains the tyrosine kinase inhibitors such as sunitinib and pazopanib. So in next few slides, we'll go through the evidence behind that we have, particularly in favor of pazopanib. Next slide. Next slide. So these are the ESMO 2000 guidelines, 2016 guidelines. I have just enumerated that most of the guidelines, the European Urology Association, the NCCN, and ESMO, they recommend. In 2019, just 2 years back, the TKIs, they were the category 1, and now we have the combination therapy. These are the 2019 ESMO guidelines. I just want slides to be moved a bit more quickly so that we can discuss. So these are European Union. You can see the previous guidelines, sunitinib and pazopanib being the first line and immunotherapy in the second line. Next slide. And now, so this is European Union 2019 update. This is more about the cytoreductive nephrectomy. I think this will be discussed in subsequent sessions. As per the evidence, we may have to choose patients for the cytoreductive nephrectomy based on their performance score as well as their risk score. So the evidence is strong, not going for cytoreductive nephrectomy in the poor risk, and strong in favor of the good risk, and intermediate risk you may choose based on the performance score as well as the metastatic tumor volume burden. Next slide. So we can see that we have many VEGF targeted agents now available in metastatic RCC, and somehow we can see that cabozantinib is a drug which is active in against most of the receptors, particularly VEGF. Next slide. Next. So these are all the targeted agents: pazopanib, sunitinib, axitinib, cabozantinib, lenvatinib. So this is how the pazopanib acts. It inhibits the PDGFR and VEGF and c-KIT receptors. Next slide. So there is evidence that there is upregulation of VEGF genes coding for the VEGF receptors, in particularly in the RCC, and somehow with the risk scoring group, the major chunk of these is in the good risk and the intermediate risk. That's why the TKIs are more effective in the good and intermediate risk. So this is studies about phase 1, phase 2 studies giving evidence that pazopanib is active in metastatic RCC. Next slide. This is the first phase 3 randomized trial, though it was against a placebo, but it showed benefit of pazopanib in metastatic renal cell carcinoma. Next slide. And then this was followed by a non-inferiority trial as well, the COMPASS trial, which compared it to be non-inferior to sunitinib. Next slide. Then there was another trial. Next slide. Then there was another trial which was patient-based, where next slide. So this is the COMPASS trial which I was discussing, that pazopanib is non-inferior to sunitinib in case of metastatic RCC and may be better tolerated because of the toxicity or safety side effect profile. Next slide. Next slide. So this in COMPASS, they compared the head-on sunitinib versus pazopanib. The Votrient is the trade name. Next slide. Next slide. So you can see the survival curves almost overlapping with each other. Next slide. Next slide. I don't think the slides are moving. Next slide. Next. 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 I think we have gone through this. Next slide. So yes, this study I was talking about, the PISCES study, the preference for Votrient or sunitinib. What in this, the investigators, what they did, they first exposed a group of patients to the pazopanib for first 10 weeks, and the other group was exposed to sunitinib. Then there was a washout period for 2 weeks, which was followed by the changeover. That is, the group which received pazopanib first, that was given sunitinib now, and the group which received sunitinib beforehand was given pazopanib now. And then patients were asked for their preference. So 70% of the patients, they selected for pazopanib because of the better quality of life and better toxicity profile, particularly the fatigue, hand-foot syndrome, and others. Next slide. So this, you can see that graph showing that the 70% of the people, they preferred pazopanib once they were exposed to both of the drugs. Next slide. So these are the various toxicity parameters on which the pazopanib they scored better as compared to the sunitinib, and I have discussed with you various side effects. The only issue with the pazopanib was a higher incidence of liver function dysfunction or the transaminitis. On rest, all the parameters, pazopanib usually scored better as compared to the sunitinib. Next. The next slide. So this is just about the dosing of the pazopanib, 400 milligram twice a day. Next. It is, people find it more convenient to give pazopanib because of the toxicity profile. So out of the two tyrosine kinase inhibitor, the pazopanib remains better tolerated and non-inferior to the sunitinib. Next slide. Next. And it is more cost effective as well, in terms that the cost of the pazopanib is almost 5 to 6 times lesser as compared to sunitinib. Next slide. And there are various assistant programs available as well for the pazopanib. Next slide. Next. I think thank you everybody. I think we are done. The carry home message is in 2021, the first line options for metastatic renal cell carcinoma remains the combination of immunotherapy and tyrosine kinase inhibitor. However, majority of patients, they are not able to afford immunotherapy. So we end up giving them tyrosine kinase inhibitor. The two most commonly used tyrosine kinase inhibitor are sunitinib and pazopanib scoring over sunitinib in terms of the cost and the toxicity and side effect profile. Thank you. I will be happy to take any questions.
Thank you, Dr. Atul, for your summarizing all the current contemporary use of pazopanib. In the sequencing of the treatment, how you place pazopanib? If you are giving it upfront, what after pazopanib? And earlier we used to say TKI after TKI, TKI, mTOR, and now newer options are available. When you are talking about economic and you are talking for cheaper options, how you sequence the thing, or is there any combination recommended with pazopanib or under trial?
Sir, now, I mean, we have available the other TKIs, we have generic forms available as well. For example, axitinib, we have generic forms available. Now, recently, cabozantinib is also launched by many companies. So we have, since the generics are available, and I think particularly my choice, I prefer generics over the original molecules as well, because I don't think there is much difference, and they are way cheaper as when we compare the cost. So if immunotherapy is not, I mean, because majority of people are not able to afford immunotherapy. So in case of TKIs, we have at least 3-4 lines of TKI available now with their generic forms available, particularly cabozantinib and axitinib, they are available in Indian market.
So you say that if we go for axitinib and then after till the response is there, generic axitinib, and then can we go back to pazopanib also? Is there any possibility?
Sorry, sir, I'm not able to get. First line we used pazopanib.
First line we have used, and because of intolerability or because of any reason, axitinib has been given. So we go for new immune check inhibitors, or if they cannot afford, we go back to some other TKI.
Sir, in second line, we have evidence for single agent nivolumab as well. So in case somebody is affordable for nivolumab, we can try that. Else, we can again go to a subsequent TKI. I mean, we can go to the next TKI.
So when we give upfront pazopanib, and that is the biomarkers which are available in the main tumor, and in the secondaries, they may be different. That is what I'm asking. If we go for manageable tumor is there, and to reduce tumor burden if nephrectomy is done. So do you feel that any difference in the approach can be there, or we can retry the pazopanib?
Sir, in today's time, in any point of time, if we think we can address the metastatic tumor as well, we should try to address it. Previously, there was, we consider only for the cytoreductive nephrectomy, but now they say in case you think you are able to address the metastatic tumor as well, you should go for a metastectomy as well.
So, okay, precisely my question was that biomarkers may be different, that you are targeting, they may be different in the primary and secondary. So we will not know that this is, you are right that this is the thinking, and some trials have shown that we should attack all the primary, secondary together. But there are also studies where primary has different biomarkers, secondary may have different biomarkers than primary. So,
agree, sir. So there was one study where they did gene profiling, and they were able to show that the IMDCC criteria or the MSKCC criteria, they actually, when they risk stratify, the tumors with higher VEGF expression or higher gene upregulation for VEGF receptors, they are selected more into the good risk and somewhat into the intermediate risk. Maybe those who are more immunogenic or less expression with VEGF, they go into the poor risk category.
Okay,
That's why.
now on the adverse effects which are there of the drug, the thyroid, we know that all the TKIs, how we manage. If the liver enzymes are deranged or some dysfunction is there, but patient is doing good, patient's performance is better, quality of life is better, but there are derangement and biochemical derangements are there. What is your strategy?
Sir, particularly liver function derangement is an issue with pazopanib. It causes almost twice or thrice the transaminitis as compared to the other drugs. I'm not sure if you are pointing towards the per se liver dysfunction without metastasis in RCC. That is also a known entity, but usually I think that presents in the upfront scenario only. So the other TKIs, they are less hepatotoxic as compared to pazopanib.
Patient was all right. Patient was all right liver wise, and after pazopanib, there are some enzyme raised or some dysfunction you are seeing. So you change the TKI or you change the pazopanib, or you can continue.
Sir, if the trend is rising, the transaminases are rising, then definitely I would like to change.
If it is continuously rising.
Yes, yes.
If it is stable within 1.5 time or so.
Then we'll observe, sir.
You observe because quality is better. The pazopanib is quite safe. Dr. Atul, you have shared your practice experience with us and also the contemporary use of pazopanib, and we are enlightened. All the audience, if there is any question, that can be asked, or we go to the next session. Is there any question from the audience? Thank you, Dr. Atul. Thank you very much for enlightening us on the subject. Thank you. Thank you, Novartis.
Thank you. Thank you.
So very thank you to Novartis for the sponsored session. And I would like Professor Amilal Bhatt, sir, can you, sir, please come on the dais to present a memento to our chairpersons, Dr. Rajiv Sood, sir, and to Dr. Mansa. So thank you to our chairperson and thank you to Dr. Amilal Bhatt, sir, for this. So this will bring us to the end of this session. The next session here will be at 12 p.m. That will CMC Best Poster. We have a break time till then. Thank you.
But I can change it from here.
So good afternoon, everyone. We are going to start a very prestigious session, that is CMC Best Poster Session 1. I would request Dr. J.S. Kocher, sir, and Dr. Pankaj Wadhwa, sir, to please take their place on the dais. And please start the session. Thank you.
Do we have the first speaker? Dr. Tarun Parikh, Dr. Kapil Chaudhary, and Dr. S.K. Singh. Welcome to this afternoon session. The first talk is on curious case of differentiated paratesticular liposarcoma with PSMA avidity. This is from PGI MER Chandigarh. The speaker is Dr. Tarun, right?
May I start, sir?
Please start your presentation.
Good afternoon, sirs. As the title suggests, I'll be presenting a case with a unique association between a rare tumor, that is a giant paratesticular liposarcoma, with only few evidence in the literature being found, with a not so common association of PSMA avidity in non-prostatic tissues. My patient is a 71-year-old man who presented to our OPD with a history of right hemiscrotal swelling of past 1 year duration, which he says has progressively increased in size and is associated with heaviness. However, there is no history of any pain, fever, and trauma, and no change in the size of swelling on cough and change of the posture. He is a known case of low urinary tract symptoms, for which he is on alpha blocker for the past 13 years, and is comfortable with that. He also gives a history of being operated on the same side for a small swelling in 2010, with histology showing it to be angiolipoma, with no further treatment received for the same. Examination revealed a 10 into 12 centimeter firm swelling in the right hemiscrotum, with testis not separately palpable. Opposite hemiscrotum and genitalia were normal. DRE revealed a grade 2 prostate, firm with a benign field. All blood investigations were normal, including testicular tumor markers. However, PSA was raised to 9 nanogram per ml. Patient, being a well-read one, was quite anxious about possibility of CA prostate. So in consultation with the patient, we did a PSMA PET scan, which revealed a PSMA avid right scrotal swelling to SUV max of 8.9. However, there was no uptake in the prostate or elsewhere in the body. This is the picture showing PSMA avid right scrotal or hemiscrotal swelling rather. So based on a history of being operated on the same site for a soft tissue sarcoma and present situation showing PSMA avidity, we decided to operate him with high angle orchidectomy to give him maximum chance of achieving a negative margin. This is the cut intraop specimen, with the cut section showing well differentiated demarcated two areas with compressed testicular tissue on the sidelines. The histopathology with immune histochemistry showed it to be a de-differentiated liposarcoma. The HP slides showing demarcated areas of well-differentiated lipomatous element and de-differentiated element on the lower side, which is a spindle cell variant, and showing strong Desmin positivity. The 3 months follow-up with a CT scan and physical examination showed no signs of recurrence. So to conclude, giant paratesticular liposarcoma, being a rare entity, presents us with a diagnostic dilemma, and its association with PSMA avidity is rather a curious association. The potential pitfall of increasing number of PSMA avidity in non-prostatic tissues is probably a byproduct of increasing number of PSMA PET scans being done nowadays. But with further studies, it has a potential to be developed in good theranostic potential for both treatment as well as diagnosis of other non-prostatic malignancies. Thank you.
I have a question. At your follow-up, what happened to the PSA?
So PSA has come down to 1, sir.
It has come down to 1.
Yes.
And was the prostate also evaluated at the time when you found the high PSA? Or you straight away went for a scan and localized to the testes?
Yes, sir. So the DRE was showing a benign feeling, and we have a project running at our center in which we are using PSMA PET scan as a primary diagnostic modality, and doing a PET guided biopsy to decrease the number of false negative biopsies.
But
So
not in MPMRI
no,
prostate?
so that's why in consultation with the patient, we did a PSMA PET scan instead.
Okay.
What
Any
are the other
questions?
tumors giving false positive PSMA PET scan?
So most common or most commonly being studied is RCC, renal cell carcinoma. Then there are thyroid tumors which can give PSMA positivity. Tumors of hepatobiliary origin as well as colon can also give PSMA PET ability.
Any other questions from the hall? Yes.
But yes, sir, but that was a normal. Yes.
Or something else in the retroperitoneum.
It was just normal uptake. So there could be normal uptake, physiological uptake of PSMA at other places also. So at what reported was a normal uptake as well.
It was confined to the left,
Right
upper-
hemisphere scrotum, sir, most 8.9 SUV max.
Okay. So you can't go back and because there's, right, okay.
Yes.
Right. Thank you.
Thank you. Thank you, sir.
Let me like to call the next speaker, please, which is Dr. Gopal Sharma, will be speaking on development and internal validation of a nomogram predicting biochemical recurrence following RARP in patients with prostate cancer.
Good afternoon, sir.
Yeah.
I'll be presenting my poster on development and internal validation of a nomogram predicting biochemical recurrence following robot-assisted radical prostatectomy in patients with prostate cancer. Aims and objective: biochemical recurrence is a commonly used proxy marker for disease-specific and overall survival in patients with prostate cancer. Literature pertaining to such factors is limited for the Indian population. So with this study, we aim to develop a nomogram predicting the risk of biochemical recurrence in patients with prostate cancers following robot-assisted radical prostatectomy. For this study, we queried our retrospective RARP database to identify patients who underwent RARP for prostate cancer. We defined biochemical recurrence as those patients who had 2 consecutive PSA values more than 0.2 or needed adjuvant therapy following RARP. We used multivariate Cox proportional hazard analysis method to identify predictors of biochemical recurrence. A nomogram using such predictors was developed, and we internally validated the nomogram using bootstrapping text for proportional hazard assumption and context index. And the inclusion criteria for this study was we included only the Indian patients who underwent RARP at our center from October 2011 to July 2021. We excluded patients belonging to non-Indian race, and on those patients on which biopsy data and clinical data were missing, patients who received pre-radiation therapy, pre-operative radiation therapy were also excluded. Slide. In results, of the 688 patients who underwent RARP at our center, 492 patients were included. After a median follow-up of about 18 months, ranging from 1 to 108 months, 212, that is 43% of the patients had biochemical recurrence. On univariate analysis, we noted that patients who had biochemical recurrence had significantly higher PSA, biopsy ICP grade, DM-ECO risk staging, and adverse features on the final histopathology. Using multivariate Cox proportional hazard analysis, we found pre-biopsy serum PSA, neoadjuvant hormonal therapy, extraprostatic extension, seminal-vesical invasion, positive lymph nodes, pathological grade of tumor were identified as independent predictors of biochemical recurrence. So we developed a nomogram using these variables, and we then internally validated this nomogram, and we found that the nomogram was valid using bootstrapping test for proportional hazards, assumption, and concordance index. So to conclude, we developed and internally validated a nomogram predicting the probability of biochemical recurrence in patients with prostate cancer following RARP in the Indian population. Now, there are some limitations to this study. First is it is a single center study, and also the nomogram that we have developed in this study lacks external validation. Thank you very much.
From the audience? So how is it different? So you're providing Indian data, I understand that, but is this your own, is this not different from other nomograms which are available?
Sir, it is slightly different from MSK-CC or Capra nomogram, but more or less the variables are same, but we have not externally validated per se. We have tried to develop our own nomogram. We have taken all the variables which we think and which have been found to be significantly valid in the previous nomograms, and then we run the logarithm of Cox proportional hazard, and we found these variables to be significant, and then we internally validated and developed the nomogram of those variables.
So your nomogram has a scoring pattern, which is not there?
Yes, sir. Nomogram usually, what nomogram is for visual interpretation. Yes, sir.
Yeah.
And if we have using this logarithmic equation which comes from the nomogram, we can develop a app which is commonly available for MSK-CC nomogram, which is
Yes,
easily available.
but have you done that?
No,
on
we
the
have
last
not
one?
done that. Sir.
Right. Okay.
Yes.
So it's still in its.
Yeah, it's
infancy.
still in early phases, sir.
Okay.
What is the positive predictive value if the nomogram
Yes.
suggests a high incidence of
Yes.
BCR in any way, whether the nomogram says it or doesn't say it, you're still going to follow the patient for BCR?
So regarding that, regarding the actually area under the curve is calculated to determine the sensitivity and specificity of the nomogram. But since this is a nomogram predicting survival function, which is a hazard function, which is time to event analysis, and it is not a binary analysis like we usually give, whether this biochemical recurrence has occurred as two variables, yes or no. It is usually given for those sort of data. It is the biochemical recurrence we have given as a function of time to event analysis. Therefore, we had used a different test, which is Cox proportional hazard analysis. So for that, AUC cannot be given. So we cannot tell the sensitivity and specificity. What we could have done for that, we could have taken biochemical recurrence as a binary logistic variable, having two events, yes or no. In that case, we could have given area under the curve, sensitivity, specificities. But for this cannot be given, sir. Thank you, sir. Thank you very much.
Next speaker is Dr. Zain Tamboli. He is restaging QR review in non-invasive high-grade urothelial carcinoma and over-treatment in tertiary.
Good afternoon, esteemed judges. My name is Dr. Zain and from SGPGMS Lucknow. Today we'll be presenting the poster on is restaging TURBT in T1G3 bladder carcinomas and overtreatment in tertiary care centers. So coming to the topic per se, upstaging of a T1 bladder tumor to a muscle invasive disease has already been reported in 4 to 29% of the patients on restaging TURBT. The incidence of persistent disease after the first TURBT is 33 to 55% in T1 and high-grade tumors. The restaging TURBT has already been emphasized by all the prevalent guidelines. But recent meta-analysis shows no improvement in the survival outcomes with the restaging TURBT. In addition to this, there is a financial burden of restaging TURBT for both the patient and the hospital. This is true, especially in today's times of COVID. And it is difficult to counsel the asymptomatic patient to undergo another surgery for a tumor which is not there. So coming to the materials and methods, this was a retrospective study over a period of 9 years at our center. So 65 patients from our center were included into this group of and they were underwent restaging TURBT. At the same time, 20 patients from those who were operated outside at private hospitals and referred to our center underwent restaging TURBT. All operated patients outside, the slides were reviewed by dedicated uropathologists. The technical details of the re-TURBT were using a monopolar or bipolar current, 1.5 centimeter margin around the growth, separate deep muscle biopsy taken, cutting current used at the base. The re-TURBT was performed at least after 4 weeks of the surgery. As we compare the group A and group B, that is the patients operated at our institute and those operated outside, there is no significant difference in the demographics except the sex ratio. Patients who had either T1 or high grade, where there was no significant difference between the two groups either. The mean size of the mass was about 2.3 centimeters or 2.2 centimeters, is almost the same. Mean number of masses were almost the same, and most of the tumors were papillary in morphology. So out of all these patients who underwent a re-TURBT, we could see that in group A, that is those operated at our institute, 10% of the patients had the same stage of the disease on re-TURBT, and 6% had an upstaging. While those who were referred to us from private institutes by an inexperienced surgeon, 55% had the same stage of the disease and 10% were upstaged. So the percentage of the significance of those being upstaged was significantly higher. While those who had no malignancy in the re-TURBT operated at our institute for the first URBT, there was 83%, and that was also significant. So out of these 11 patients who had persistent tumor, if you see that there was recurrent growth in almost 90% patients, even in those operated in our institute and those operated outside. So in this residual tumors, we could see that the tumor morphology, like the sessile tumor, multiple tumors, that is more than 3, size more than 3 centimeter, were predictors of upstaging and residual tumor on multivariate analysis. On seeing the overall survival and the progression-free survival and the recurrence-free survival, there was no difference in 3 years recurrence-free survival and progression-free survival in patients who had a residual or recurrent tumor. That even though the progression-free survival showed a trend towards a difference, but it was still insignificant. So we conclude that only sessile tumors with size more than 3 centimeters and multiple growths at primary resection should be subjected to a restaging TURBT. This is the final question. Thank you.
Yes, please.
Yeah, I have a question that in restage TURBT you have mentioned, is the muscle was included in every specimen? Muscle. Because sometimes what happens, the muscle is not included, then of course you need to do a restage TURBT.
Yes, sir. We at our whatever patients we have operated our institute, we have taken a separate deep muscle biopsy in
But
every
outside
patient.
you have mentioned.
Yes,
20
sir.
cases.
That was not the criteria for.
And second thing, you have not mentioned about the treatment after the TURBT.
TURBT.
Because
Single intraversical mitomycin was given in all the patients.
no, but not the mitomycin only, but the T1 high grade you have to given the any BCG therapy or something. No? But that
yes,
you
sir.
have not correlated, because if you are talking about the progression of the disease, then treatment should be also be, I think, mentioned.
Yes, sir. We have those who have at our institute, those who have already undergone a re-TURBT. For those we go on to give the intravesical BCG. Sir.
Hello. Regarding the, I have one question, sir. In the factors you have considered as a predictors for patients who should be considered for considering restage TURBT, have you considered the grade of the tumor or the patients who had CIS? This is the first question. And second is, and when was the TURBT done? Restage TURBT. I think which.
Yeah. So I'll answer the second part first. Restaging TURBT was done at 4 weeks after the first TURBT, and the first. Yeah, and the first part, CIS was not included in this. We took CIS is a flat lesion. We are not going into a restaging in this. We are not included that in the inclusive criteria. This is with T1, G3.
Whether you should have, if there are patients, you should have considered both high grade and CIS, because this has been one of the most important factor to consider patient for restage TURBT or not.
If it is a CIS and there is a deep muscle which is
no, not only CIS, I'm saying high grade tumor also, whether you have considered it in your multivariate analysis.
Yeah, we have included the patients with a TA high grade. You're talking of TAG3.
No, I have not seen a slide containing a grade of the tumor comparing it to the in univariate or multivariate analysis. I think I have not seen that.
Okay, no, that we have just talked about.
Yeah,
the
so
morphology size and the
grade is
tumors.
an important factor, I think, for considering this.
Yes, definitely. Yes.
Okay. We ran out of time.
Thank you.
Thank you. Could we have the next speaker, please? That's Dr. Nitish Agarwal from AIMS.
Good afternoon, everyone. The title of my poster is Clinical Management and Outcome Success in a Retroperitoneal Growing Teratoma Syndrome of Testicular Origin. The germ cell tumor are the most common solid tumor in the age group of 15 to 40 and constitute 1% of total male tumors in this age group. The presentation may vary from patient to patient, and one very uncommon and quite challenging presentation is a growing teratoma syndrome, which constitutes around 2 to 8% of such presentation. It's an uncommon phenomena where the serum tumor markers normalize, but the tumor size increases on imaging while ongoing chemotherapy. And a rarer phenomena in this GTS is the malignant transformation, which can occur in 2 to 8%, the most common being the sarcomas. So the management usually requires a complex multidisciplinary team, a team of surgeons from different departments. For a complete resection, as relapses will be less if there is an R0 resection. But it will occur at the cost of an adjunct procedure, which may be a vascular reconstruction or some nephrectomy, which may occur in 23 to 100%, and which may lead to a considerable morbidity, that is 18 to 44%. If we look at the model of the GTS development, for example, as a patient of NRGCT with an embryonal carcinoma component. So whenever they undergo a chemotherapy, they de-differentiate into a special group of cells, that is TACs, that is transient amplifying cells, which may further with the ongoing chemotherapy will differentiate into a teratoma forming. And since these teratomas are quite resistant to your chemotherapy, they will lead to a formation of a GTS. So I will present here one of the case which I encountered during my residency. That is a 16-year-old male. He's an urban dweller with a gradual, painless, progressive left scrotal swelling, for which he underwent a left high inguinal orchidectomy. The histopathology was in mixed NSG-CT, which the components of yolk sac and a mature teratoma. The CT imaging shows an RP mass with left hydronephrosis, and the tumor marker showed raised AFP and beta CG. In view of this, he underwent cisplatin-based chemotherapy. If you look at this table of with the ongoing chemotherapy, the tumor markers got normalized. But if you look at the comparison between the pre-chemo and the post-chemo CT, you can see that the RP massive, which is at the level of the aortic cable and the left aortic, there's a considerable increase and more splaying of the renal vessel and increase in the degree of hydronephrosis in the left side. So a diagnosis of GTS was made in view of the normal markers and the increase in the size of the lesion. So the patient underwent a post-chemotherapy excision of the mass. It was done in a CT-based OT with collaboration of our vascular surgeons. And the approach was via a midline incision. And after mobilizing the bowel, we could see the two RP masses sitting over the great vessels. We did a split over the septa, you can see here, and we mobilized from middle to lateral aspect. And with the meticulous dissection, we were able to develop a plane, and the vessels was separated from the mass, and the highlight dissection was, and with salvaging the left kidney and without any vascular reconstruction. The specimen showed here. The patient. So in these cases, we need an early recognition of this paradox of normalizing markers with the increase in the size. A complex. This patient should undergo the completion of the chemotherapy, and there should be complete resection of the mass.
Right. Any questions for this paper? So just a comment, it's not that common, luckily, but of course, that's nicely done there. Any other questions?
So I think, what is the message of your presentation?
The message of the presentation is that one should know about this entity first of all, because if initially there are two scenarios. One, whenever there's a growing teratoma syndrome, it can lead to life-threatening bowel compromise or the neighboring organ. So if that is the case, then you have to stop the chemotherapy. You have to take the patient for surgery. But if this is not an entity, it's a slowly growing teratoma, so you have to complete the chemotherapy, because there'll still be some viable cells of the other component which has to be dealt with. And the second option, that this needs a multidisciplinary team, which not only urologist, it needs a GI surgeon or a vascular surgeon and a team of surgery which is in a high volume center, which is dealt in high amount, because the outcome will depend upon the complete resection. And since this complete resection will need further adjuvant procedures, so if it's done meticulously, we may be able to salvage certain adjuvant procedure. And since the morbidity is quite high, but still in this patient, the patient got discharged at post of day 5 without any morbidity. Still the patient at the follow-up of 1 year.
All that holds true for all post-chemotherapy residual RPLNDs.
Yes.
Those are not easy things to do ever. Right, thank you. Next speaker, please. Is Dr. Amresh Seth, Professor Seth here? Or? Okay, his name was, I thought he would be, sure, okay. That's Dr. Pratik Maheshwari?
Yes, sir.
Right.
Should I start?
Could we have the, yes, please. Could we have the slides, please? Poster number 5.
Good morning, everybody. My name is Dr. Pratik Maheshwari. I'm from All India Institute of Medical Science in New Delhi. And my topic is tumor seeding of percutaneous nephrostomy from low-grade carcinoma of urinary bladder. As we all know that urothelial carcinoma is a pan-urothelial disease, and there can be around 5% chances of upper tract recurrence after bladder cancer. However, the metastasis of urothelial carcinoma to the skin is rare, and there is very scarce literature on that. And mostly the literature that we have is from high-grade TCC, and that too from renal pelvic tumors. So and they are associated with poor prognosis. And we have a case of 52-year-old gentleman and who presented with painless gross hematuria, and on evaluation was found to have urinary bladder mass. And on initial TURBT, which was done, there was around 2 into 3 centimeter tumor, and which on histopathology was suggestive of low-grade transition cell carcinoma. So he had multiple recurrences over a period of 3 years, and all were suggestive of low-grade transitional cell carcinoma. He was also given intravesical mitomycin, 6 courses of induction in between. And in his last recurrence, he has a growth. He has a small growth in the right lower ureter, which on histopathology was suggestive of low-grade carcinoma, low-grade transitional cell carcinoma. After that, we did URS at that time, and there was no tumor in the ureter or in the renal pelvis. And after that, a DJ stent was inserted. So after 3 months of DJ stent, patient presented to us with right hydroureter nephrosis with features of AKI in the casualty. And after that, right PCN was inserted in view of his AKI and sepsis. So right PCN was inserted, and patient was discharged in a stable condition, and his creatinine came down to normal. And after that, patient lost to follow-up and came to us with after 6 months with a non-healing ulcer. We can see in the image that there was around 5 into 6 centimeter non-healing ulcer, and on H biopsy was taken from that ulcer, and it was suggestive of a transitional cell carcinoma. And we also did PET scan, which was suggestive of a tumor that was coming from the kidney and was going to the skin. So it was decided to manage him with 3 cycles of chemotherapy. So after chemotherapy, his skin lesion decreased in size, but there was still a non-healing ulcer. And after that, we did a right nephrectomy with wide local excision of PCN tract with LD flap. And histopathology was high-grade TCC. His post-op course was uneventful, but in view of locally advanced disease, he was decided for further cycles of chemotherapy. And after chemotherapy, he had chemotherapy-related vomiting, and with which he had aspiration pneumonia, and cause of death was his aspiration pneumonitis, not related to the disease. So from this discussion, we can conclude that PCN should not be kept for long duration in a patient with transitional cell carcinoma, and wide local excision with surgery can give us good results, oncological outcomes.
Right.
Dr. Prateek, what is the compelling reason to do a PCN in this patient?
So actually, he presented to us with AKI with sepsis, sir. And he was also diabetic, sir. His creatinine rose to around 3, sir. So
why not a long-term stent, double J stent?
So actually, he was already on DJ stent, sir.
Okay.
So we had to insert PCN, sir.
So that's where the question is. So this patient also had multiple recurrences despite having a low-grade lesion reportedly.
Yes.
And was treated with intravesical therapy
So
with
he was-
mitomycin, you
yeah,
said.
He was given 6 cycles of induction mitomycin.
So, but with the fact that he had multiple recurrences despite an induction of mitomycin C, would that not be an indication to place him into a higher category, maybe intermediate risk rather than a low risk?
Yes, sir. But sir, actually, all the recurrences were very low grade. We used to fulgrade that.
No, but he's failing.
Yes,
He's
sir.
failing on your primary intravesical
Yes,
therapy,
yes.
which means either you offer him up something else or you upgrade his from a mitomycin to at least a BCG.
Yes, sir.
Of course, he had a worse disease than what is apparent.
Yes.
And I suspect the upstreaming could also be. So when was a DJ stent placed? During one of the times when the
Sir,
ureteric
at the
orifice
time
was
we-
shaved?
Last recurrence, DJ stent was placed when he
Yeah.
had a right lower ureteric small growth. That was only a small one, around 1 centimeter, less than 1 centimeter growth.
So that could possibly, if one can only surmise that may have actually been the cedar, that a reflux of the disease up, and therefore once the PCN, it just provided another milieu for it to grow. Okay, any other questions?
Yeah, I think I have the same question that you have answered. Only thing is that I think this patient should be, when as Dr. Vadva said clearly, should be recurrent TCC straight away case for nephrectomy.
He should have either been, the fact that he failed and you're saying that he had multiple recurrences means that he needed something else beyond the intravesical induction which he received. That's about it. Right, I think we've run out of time. Thank you very much.
Thank you.
The next presentation is by Dr. Rohit Ranjan. Penile metastasis secondary to squamous cell carcinoma of the urinary bladder, presenting as priapism.
Good afternoon, everyone. I'm Dr. Rohit Ranjan from AIMS Rishikesh. So penile metastasis is an extremely rare entity, and the primary tumor most commonly arises from the genitourinary tracts, especially from the bladder or the prostate. So we present a case of carcinoma in bladder with the penile metastasis, which is mimicking as priapism. and very few cases has been reported. So there was a 55 years old gentleman who presented with a painless gross intermittent hematuria for the past 4 months and gradually increasing penile swelling for the past 2 months, which was painless and without any widening difficulty. On local examination, we can see there was a hard mass in the proximal part of the penis, and there was distal part of the penis, and glans was normal. It was flaccid. Penile Doppler was done, which was showing bilateral bulky corpora cavernosa and heterogoic lesion at the base of the penis, but the triphasic blood flow of the penis was maintained. MRI pelvis was done, which was showing 6 into 5 centimeter mass in the unibladder at the posterior wall. There was loss of fat plane with the rectum, but the fat plane with the prostate was maintained. And bilateral corpora cavernosa was bulky with 3 into 2 centimeter hetero-intense lesion in each corpora at the base with restriction on DWI. There was no continuity between the bladder mass and the corpora cavernosa mass. And CCT thorax revealed multiple metastatic lesion. So he underwent transurethral biopsy from the bladder tumor and 4-core needle biopsy from the penile penile mass. Resectoscope was negotiated with slight difficulty. Urethral mucosa was normal, but mass in the pinobulbar region was compressing the urethra. In the bladder, there was 6 into 5 centimeter solid cell mass at the posterior wall, proximal to the ureteric orifices. Histopathology revealed squamous cell carcinoma in both the biopsies. So with the squamous cell variant of the bladder carcinoma and the penile metastasis, we planned for cisplatin-based palliative chemotherapy, but patient died after 2 cycles of chemotherapy. So here we have 5 more accepted mechanisms for the spread, including the retrograde venous route, which is most common, retrograde lymphatic route, arterial spread, direct extension, or implantation following instrumentation. The prognosis for the bladder carcinoma with the penile metastasis is quite poor, only 3.9 months from the diagnosis. So optimal management requires multidisciplinary approach, which offers the best chance for survival, approximately 9 months. The treatment options are usually local tumor excision, radiotherapy, chemotherapy, or partial or total penectomy. So to conclude, penile metastasis secondary to bladder cancer is extremely rare, but they can manifest as priapism and represent a challenging problem. The most common mode of spread is retrograde venous route. The overall outcome is extremely poor, and most of the patients will die within 6 months despite best supportive care. Radical ablative surgery should justified only for the symptomatic relief. Thank you.
Were you able to give him any symptomatic relief for the priapism?
Yes, after surgery, there was swelling was decreased, but we did not resect the base of the tumor. We just took biopsy from there. But when we started chemotherapy, there was slightly decrease in the mass size.
Any other questions?
Extremely rare tumor. Any questions?
Is there anywhere else also metastasis except the penile one?
Multiple thoracic
metastasis.
Thoracic also.
They already had multiple.
Yes.
Also, then it's again not only the penile.
Are they actually penile metastases which respond very well to treatment and don't have such a deathly prognosis as that from genitourinary malignancy?
Not really. There is a very poor response from the chemotherapy.
And this was squamous anyway, not
Yes.
Lymphomas and leukemias also spread to the
Yes, sir.
penis, and they respond pretty well to chemotherapy.
Yes, sir. But here it was a
Not
squamous cell
from
carcinoma.
genitourinary
Yes.
malignancy, that of course.
Right. Thank you very much.
Thank you, sir.
Could we have Dr. Pavan Kumar Sharma from PGI Chandigarh with this presentation?
Good afternoon, colleagues and seniors.
Poster 7, please. Could we have the slides?
So I'll be presenting accuracy of pathological staging by thulium laser en bloc resection of bladder tumor versus conventional TURBT in non-muscle invasive bladder cancer. It was a prospective comparative study done at PGI Chandigarh. The detection of detrusor muscle within the tissue is most important parameter that is associated with recurrence-free survival. we started with the aim of assessing the accuracy of thulium laser enucleation, en bloc resection of the bladder tumor with the added advantages of non-piecemeal resection, that is removing the tumor in one go, so that the less number of cancer cells are liberated in the bladder tumor, as well as we don't lose 4 weeks or 6 weeks of restaging that might help the patient in individualizing treatment. Third thing, the charring effect that is caused by recurrent amount of monopolar or bipolar, we could have decreased by using this laser. So our study duration was from January 2020 to June 2021. Study design was a prospective comparative study. However, the patient population was, the patient sample size was quite a low because of COVID pandemic. There were 16 patients in the thulium arm and there were 18 patients in the TURBT arm. These are my results. Detrusor muscle sampling. With all the literature in urology says that laser enucleation is far better in detrusor muscle sampling. However, in my study, it became reverse. The laser were inferior with only 56% of the patients. The laser was able to sample detrusor as opposed to 89% in the TURBT group with a significant value favoring TURBT. The second slide on the right side, the TURBT arm is subgroup analysis. We have seen that in most of the cases where the detrusor was not included, those were the low-grade tumors. The second slide on the left-hand side, this was also contributed because of the mean size of tumor was small in the laser group as compared to the thulium laser group, which was statistically significant. And in the last arm, yes, laser were definitely superior in blood loss, although it is not clinically relevant, 0.11 gram percentage or 0.28 gram percentage, but it is statistically significant in favor of laser. So this is the diagram, sir. In the first picture, we can see a glistening papillary surface of the tumor, while in the second on the right side, we can see the crushing the cautery artifact in the laser. The literature says that there is less number of cautery artifact, but in our cases, it was the reverse. The laser was showing more cautery artifacts. The third diagram shows how clearly the bladder base is fulgurated by the laser. So absolutely, there is no blood loss in the laser group. And magnification view, we can see the muscle fibers which has been resected. So conclusion, as opposed to all existing literatures in our study, thulium laser was not superior to TURBT as far as detrusor muscle sampling is concerned. Reasons: learning curve of the surgeon, new technique at our center, and cautery artifact.
Right. So I would have actually thought that you would have done a enucleation with the standard technique versus an en bloc TURBT rather than a conventional TURBT versus the thulium that would have probably made a bit more comparative head to head, because now right now you've done a conventional TURBT to a en bloc thulium.
En bloc resections.
So it's not exactly apples and apples here. The other thing was that the thulium is got a significant amount of char, and as seen on, so if you've seen other thulium prostates, then you would notice that there is actually a char. Although you're right, histologically they say that it is not as much, but clinically it's more evident. And again, your comparative, you've taken smaller tumors for your enucleation. So that is why a head-to-head en bloc TURBT would have probably given you a bit more of clarity. Right now, you've just done as conventional.
So actually, it was a new technique of our center. So
Sure.
it might be a surgeon's favor of taking smaller tumors for the new technique.
So
because
it's
the
not
learning curve-
really a comparison as of now.
Yes.
In the patient in whom the biopsy in the deep muscle was not included, did they undergo the restage biopsy also?
For which group?
For both the groups.
Yeah.
And then by the same modality or the cross?
In my study, because of the shortage of time, we did a restage of all the patients. However, because I can only
by
show
which
5
modality?
slides.
By the same modality or the?
By the same modality, the patient who were in thulium group received thulium again, and the patient who in the conventional group received conventional treatment again.
Then the muscle was present in almost.
It was not statistically significant to either of the group.
So you didn't take a cold cup biopsy from in the thulium either
No.
after you resected that?
No, no, sir.
That would have probably made a difference.
We already went too deep in the laser group.
And yet
Completely
50
muscle was visible.
And yet 56% did not show.
Yes.
I think you need to relook your videos. Right. Thank you. Thank
Thank
you
you,
very
sir.
much. Dr. Samarth Patel from VMC Subject Hospital for his presentation, please.
Good morning, sir. Sir, I'm Dr. Soumya Iyer. Actually, I'll be presenting on behalf of Dr. Samarth Patel.
Your name is not there on the.
No, it is. I'm listed as the co-author.
Huh?
I'm listed as the co-author.
Dr. Soumya.
Dr. Soumya.
Right. Okay. Okay.
So good morning, everyone. I'm Dr. Soumya Iyer. I'll be talking on the prospective evaluation of outcomes of transperitoneal 3D laparoscopic radical prostatectomy. There are paucity of prospective studies that assess the outcomes of 3D laparoscopy in patients of localized or locally advanced CA prostate. No recorded prospective study has been reported from India, to the best of our knowledge, which evaluate the same. Ours was a prospective non-randomized single-arm study of 18 months duration. We included patients of age less than equal to 76 years with life expectancy of more than equal to 10 years, having a diagnosis of castrate-sensitive prostate cancer, completely resectable, of clinical stage T1 to T3, N0 to N1, and M0. The intervention arm comprised of patients who underwent transperitoneal 3D laparoscopic radical prostatectomy. We evaluated the outcomes as the pentafecta rates, which were defined as the absence of perioperative complications, negative surgical margins, continence defined as use of no pads in the past 1 month, potency as the ability to achieve and maintain satisfactory erection firm enough for sexual intercourse in more than 50% of the attempts, with or without the use of PDE5 inhibitors, and biochemical recurrence as 2 consecutive PSA levels of more than 0.2 nanogram per ml. We found that the mean age of the patient was 60 years and the mean PSA was 11.8, the mean prostate size being 42.9 and the Gleason score being 6.5. 40% of the patients belonged to the low risk and the intermediate risk group, and 20% were of the high risk group. The mean erectile function score was 19.18. So in evaluating the outcomes at 6 months, for 30 patients, we found that 27 of them were continent, 12 were potent, all of them were free of biochemical recurrence, 12 had achieved the trifecta, and 11 had achieved the pentafecta. We also had a subgroup of 14 patients who underwent a nerve sparing procedure, and on comparing the results with them, we found that the nerve sparing procedure led to a significant improvement in the trifecta and the pentafecta rates. That is 85.71% versus 40% and 78.5% versus 36%. One patient had a positive surgical margin for which he received adjuvant radiotherapy. We also performed a subgroup analysis of the factors that affect the trifecta and the pentafecta outcomes and found that age less than equal to 55 years and nerve sparing procedures were the most significant. So in conclusion, I can say that 3D laparoscopic radical prostatectomy is a safe and efficacious procedure and has comparable trifecta and pentafecta rates to the robotic approach if nerve sparing can be performed adequately with the 3D. Thank you.
Open for questions from the house.
Good study in Dr. Soumya. I think I have
Thank you.
one conclusion that either you should compare with the normal laparoscopy with 3D laparoscopy, though it's a comparable 3D with robotic also.
Yes.
But we give the advantage over 3D laparoscopy over conventional laparoscopy. Second, that in your study you have mentioned that you have taken the lesion up to T3 lesion.
Yes.
But in final biopsy, none of the patient you were having T3. Only one patient has a surgical margin positive. So do you have any comment on that?
So the surgical margin positive was at the level of the bladder neck. So that was primarily because that patient had a large median lobe. So that is the reason we think there was a chance of positive margins.
So that's purpose
Yes.
to say is that you have taken even the advanced cancer.
Yes.
So to get the trifecta or the pentafecta is really difficult.
Yes, they were clinically advanced cancer, but then the biopsy did not show involvement, as well as we did not have any nodal positive patient as well on the final biopsy.
Okay.
Any other question? Yeah.
Regarding this study, I'm not sure whether you have mentioned what was the minimum duration of follow-up. Regarding trifecta, and two important factors are sexual dysfunction and urinary incontinence. So what was the time at which this has been evaluated?
Yes, sir. The
For this-
study was a total duration of 18 months But then we had followed up the patients for 6 months.
So,
So our follow-up period was of 6 months.
so follow-up, I think, is not adequate for
Yes, sir, it is
for
a short-term follow-up.
defining
That is-
trifecta and pentafecta.
Yes, that
outcomes
is
per se.
one limitation of our study. We could not follow up for a longer period. But these patients are now being still followed up, but we have presented the study at 6 months of follow-up.
Right. Thank you.
Okay, thank you, sir.
Can we have Dr. Faisal Masood Pirzada from RML Hospital? Who's presenting a hybrid technique of lap perineal pelvic lymphadenectomy.
Hello, good morning to everybody. I, Dr. Faisal Masood, I will be presenting a case series of 8 patients. Where I will describe a hybrid technique of lap perineal pelvic lymphadenectomy after open radical perineal prostatectomy in localized carcinoma prostate, our initial experience. So the major disadvantage of RPP is the difficulty to perform pelvic lymphadenectomy via the same incision. So what we did an open RPP and it was followed by lap perineal pelvic lymphadenectomy via the same perineal incision. And that's a sort of hybrid technique which sandwich the open RPP and formation of anastomosis, and the sandwich is our lap procedure. Now, what we did here, we took the patients of low and intermediate risk of localized CA prostate with Partin score of more than 5%. And after completing the prostatectomy part of the RPP, the lap perineal prostatectomy was performed by the same incision using the Sills port. The parameters of interest were assessed and analyzed. Now, this is a technique in the figure 1. This is the open RPP specimen. Then after that, we put in the Sills port and suture the Sills port to the skin. Third, we perform the perivesical space dissection and create a perivesical space. Now, in the diagram 3, it is shown that the thick arrows, this is the perivesical space, and the thin white arrows, it is the resected bladder neck. Then after that, we perform the lymph node dissection along the major vessels till we reach the obturator nerve and take out the lymph nodal packet. Now in this diagram number 5, there's a lymph node retrieval packet which is shown in the blue arrow, and there's obturator nerve in the black arrow, and there's a pelvic side wall which is shown in the white arrows, small thin. Then after we complete our the procedure, we remove the lymph node specimen by removing the suture on the one side of the Sills port. Then after that, once the specimen is out, we perform the open, we take out the Sills port and perform the open, this uretrovesical anastomosis. And after that, we suture closer the perineal wound. So these are the results. The median age was 65 years, median BMI was 22.7, median prostatic volume was 42, median PSA 10.1, median Gleason score 7, and median IIEF was 19.5. So what we could do, we could remove 68 nodes total. Median was 8 nodes. Number of lymph nodes positive was none. Median operative time was 190 minutes. Median operative time for lymphadenectomy was 35 minutes. Wound infection was seen in 1 patient, and 1 had transfusion, and 1 patient had positive surgical margins. The patients which were continent at 12 months were 7, which is 87.5%. Median IIF score at 12 months was 8, and biochemical relapse at 12 months was seen in 1 patient. So this is a study comparison study, our study and situ. So conclusion, we can sandwiching lap perineal pelvic lymphadenectomy between prostatectomy part of RPP and anastomosis is safe, reproducible, and feasible technique.
It's interesting. I have a question. So once you've done the prostatectomy part, then you're dissecting the bladder away because you need to go to the operator. Did you have trouble doing the anastomosis now that the bladders actually got pushed away? Did it make a difference?
No, so actually, the performing uretrovesical anastomosis is more surgeon friendly once we perform open this perineal prostatectomy.
No, I'm not talking about not standard. In this case, after you've disconnected, you've retrieved the specimen, then you're doing a lab. And to do that, you have to create space to do your lymphadenectomy. So the bladder, I assume, at least that's what I can visualize, will get pushed away because you are working with the perineum and you're going towards the operator fossa. Some amount of bladder would have to get.
We use a Lowsley retractor in this type of surgery, so it's easy.
No. When you're doing the lap part, you don't have a retractor in when you're doing the laparoscopic part, right?
So in laparoscopy part, we only perform the lymphadenectomy. That's.
I know. So when you're doing the lymphadenectomy, you're going to have to push the bladder a bit laterally. Sorry, medially on either side,
Yes.
which will also make the bladder neck, which you've disconnected, move away. So did you have any trouble doing anastomosis after that?
No, sir. No,
You
no.
didn't?
no,
Okay,
sir.
it was just a question.
Doctor, what have you got against doing a laparoscopic pelvic lymphadenectomy first and then following it up with a RPP?
So actually.
Would it not be simpler?
So after performing RPP, we have a lot of space. We introduce a balloon and then create a space. So that space, it becomes easier to perform the lymphadenectomy part of this surgery. So first we do
I think
RPP.
the advantage of the extraperitoneal remains probably. Okay, any other questions, please? Right, thank you. Interesting.
Thank you, sir.
Dr. Vipul Bakshi from Akash Healthcare, representing, do we have him? Bilateral single session RIRS.
Good afternoon, judges and audience. Today I'll be talking about bilateral single session retrograde intrarenal surgeries for the treatment of bilateral renal stones. So bilateral RIRS procedure in one session provides the advantage for patient with one-time admission, shorter hospital stay, and overall cost effectiveness. So the aims and objectives were to evaluate the feasibility of bilateral RIRS as a treatment option for bilateral renal calculi for stone-free rates and its complications. So this study was done from January 2013 till 2020 December. 162 patients, all cases were done under GA. It's done by a single surgeon, and non-contrast CT was done to assess the stone number, location, and size. Individual stone size of up to 2 centimeter and total stone burden for bilateral kidneys included was 4 centimeter was considered the cutoff for bilateral RIRS. Standard Flex X2 was used with holmium laser 200 nanometer, and bilateral DJ stents were inserted in every case. So the results of our study was the mean age was 37.5. Male were dominant in the study with a 2.1:1 ratio. The mean stone burden was 22.11 mm. Coming to the outcomes, the mean operative time went up to 73.12 minutes. The incidence of complication, which we put it as an acute kidney injury with the raised creatinine levels, were 10 patients out of 162. And out of these 10, 6 patients had sepsis along with acute kidney injury. The mean hospital stay in our study was 1.67 days. Stone-free rates after first session was 86.9%. And out of these patients who underwent a second session, stone-free rates eventually came up to 97.8%. In the rest, we were not able to give a 100% clearance. So coming to the discussion, that synchronous bilateral PCNL is obviously the well-tolerated and safe and relatively rapid procedure with favorable cost-benefits ratio. Chon et al. First reported the efficacy of simultaneous bilateral RIRS, and Huang et al. Examined bilateral RIRS in 25 patients with bilateral renal stones, and they reported an overall stone-free rates of 70%, 92, and again 92 after first, second, and third procedure. So the conclusion we came up to a study was that RIRS can be considered as a valuable treatment option in patients with bilateral renal stones based on stone burden, pelvic calyceal anatomy, with satisfying stone-free rates with minimal complications. Thank you.
So what percentage of these patients were pre-stented or they were not pre-stented at all?
The majority in this study, sir, all were not pre-stented, sir.
But not pre-stented.
Were not pre-stented.
Okay, got away with a lot. And any idea for the Hounsfield units of these stones?
So we not actually put them up in this comparison, but it was ranging from anything between soft and hard. We were not including anything in this studies.
Okay, and you were dusting them, or were you also actively basketing the residue?
So we do dusting in our center. We are doing dusting, sir. Yeah.
Because not all stones can get dusted if depending on the HU.
Yes,
That's
yes,
why the question.
Exactly.
Very hard stones will probably get dusted less and get fragmented more.
Yes.
Any patient in whom the ureteroscope could not be passed
So
at the outset?
In the onset and the first setting, obviously, so these were not included in the studies, of course.
Okay.
Because we had to stent them and do it in the second setting, so it was not included in the setting.
Okay.
Yeah.
Any other?
How is the stone-free rate was decided and at what duration? How did you define the stone-free rate?
See, stone-free rates were actually based on the fact that on table, what we could see, the clearance, first of all, with the RIR sensitive. Secondly, we were looking at the C-arm intraoperatively. And thirdly, in some patients, if we had a doubt, obviously we do a post-op X-ray on day 1, the next morning, to see any radio-opaque shadow. And fourthly, if we still think that we are missing something and we had an idea, then we get an ultrasound done to confirm it.
Because you've not basketed anything. So you got a lot of dust inside,
Yeah,
which is all inside.
Yes, it is on.
So that's not stone-free rate. That's visually clear on fluoro.
Exactly.
Not stone-free rate. There's a clear distinction between the two. And ideally, you're supposed to see your stone-free rates at some point in time. Mostly, yes, CT would be if you're doing a study, but an X-ray ultrasound would be reasonable.
We will
if
not
you
do
don't have
CT
a
in
lab.
all the patients, to be very frank. It's an X-ray and an ultrasound the next morning. That might.
And I think if we were taking X-ray and ultrasound on the day 1, it cannot be 90%, as sir said. It should be at a period of usually what standard studies take. It usually at 3 months, and most in adults usually they can for study purpose they even use the NCCT. But if you are going with X-ray and KUV and ultrasound at day 1, it cannot be 90% just for one addition. That's it.
Ultrasound is not that effective to pick up all the small dust.
Yeah, absolutely. So that's what I'm saying. It's your definition of stone-free
Stone-free
rate is a bit dubious at day 1 and on table. That's what we're saying.
Exactly.
Right. Thank you.
Thank you.
We'll have the next speaker, please. Oh, the next speaker is online, and that's Dr. Sumit Mandal from SGPGI, who is presenting outcome of live-related kidney transplant with incidental nephrolithiasis in donor kidneys.
Good afternoon, sir. Yes, sir. Is my screen visible and is my audio?
Dr.
clear, sir?
Mandal, are you? But can you hear us?
Yes, yes, I can hear you very well, sir. Is my screen visible, sir?
Yes, we can hear you. You can go ahead.
And okay, sir. Outcome of live-related kidney transplant with incidental nephrolithiasis in donor kidney. Improved CT imaging has led to increased detection of stone diseases in the kidney donors. The aim of the study was to detect recipient outcome of the transplanted kidney with incidentally detected renal stones and any stone-related event in donor or recipient. The donors with incidental nephrolithiasis from 2005 to 2021 were divided in 2 groups. Group 1 consisted of the donors who had stones of up to 4 mm calculus and were accepted for transplant with stone in situ, whereas Group 2 were the patients with 5 to 50 mm of calculus and were accepted for transplant after treatment with the stones of the underlying stones. Stone-related events in the donor's solitary kidney and transplanted kidney in the recipient were noted, and all the management strategies, metabolic evaluation, and follow-up were reviewed. Donors with more than 50 mm stone, metabolic abnormalities, associated nephrocalcinosis, bilateral stones, or risk factors for recurrence were rejected. And recipient outcome was measured with serum creatinine, incidence of UTI, and any stone-related events. A total 2,200 donors were screened, out of whom 57 donors were detected with stones with a prevalence of 2.5%. Mean age of the donors were 42.5 years, and mean GFR of the donor kidney was around 38 mL per minute. So the Group 1, there were 25 patients who were directly taken for transplant. The Group 2 patients, there were 32, and they underwent various procedures like ESWL, mini-PCL, and IRS. And after which 28 kidneys were stone-free, whereas 4 kidneys had residual stones, and they were considered together with Group 1. When these 29 patients were followed up, spontaneous passage of almost 90% was seen in those kidneys. When the recipients were seen at 1 month, 3 month, and 12-month follow-up, the mean serum creatinine was 1.25, and 1.38 milligram per deciliter. There were total 4 UTI incidences and 1 stone-related event. There was a urinary calculus which got obstructed in the ureters, leading to AKI. He required an emergent PCN and then later on successful antigrade lithotripsy. There was nil recurrence in the donor solitary kidney. So we can conclude that donor kidneys with stones up to 15 mm can be treated and accepted safely for live-related kidney transplant. Such recipients have good long-term outcomes with up to 4 mm stone in situ. Kidney donors, when followed for long-term, had no recurrence in the remnant solitary kidney. Thank you.
Because we do a fair amount of that. If there's a small one, you can While the kidney is cold, you can just put in you've already disconnected everything, you can normally pick it out. The other thing was that how long are you waiting from treating the donor and then performing transplant? And are you ensuring a stone-free status with the CT before you take
CT.
them up again?
Yes,
Before
sir,
you take
with
them
the
up for
CT.
transplant?
Yes, sir, with a repeat CT.
And what is the time duration between stone?
3 months, after 3 months.
3 months, okay. Right.
Yes, sir.
Any other questions? Yes.
Am I audible?
Yeah,
Yes,
go
sir.
ahead.
Yeah. So how did you reach to that 15 mm cutoff?
Through CT, sir. Initially, we had done a CT angio for the donors, and then the CT would have given us a exact value.
Yes, it would have given you stone value, stone size, but how did you
Yes.
say that 15 mm? I mean, when you conclude, you say 15 mm can be treated. If it is 3 centimeter or 1 centimeter, do you think you won't treat it?
We did
Because
treat them, but-
your analysis was less than 4 millimeter and more than 4. But then when you conclude, you say 15 mm and less.
No. Initially, we had taken stones less than 1.5 centimeter, and we had discarded anyone with more than 1.5 centimeter for this study. So for our study, initially had cohort who had stones to start with 1.5 centimeter. Among them who had more than 4 millimeter, that is 5 to 15 millimeter, they were treated and their stones were brought down to less than 4 or 0. And then
It was a retrospective study, am I right?
For transplant.
It was a retrospective
Yes,
study?
definitely.
So
Yes,
you
yes, it
would-
is.
Yeah, I mean, you would have patients who had more than 15 millimeter where they're not.
They are not they were not compared here. There were definitely many.
But
patients
were
who
they
not-
fun? Did they become donors?
Yeah, that's the question.
Few
The
of them,
question
very
is
few
that.
of them. Very
Sorry?
few of them. Very few
No.
of them.
I mean, why
Very
is
few.
that being hidden? I mean, it's a retrospective study. You could have just analyzed one cutoff as a point. Thank you.
Right.
They were out of the 57 patients, hardly 2 or 3. So to narrow down the cohort, to bring more meaning to the conclusion.
Thank you. I think we've run out of time. Thank you.
Thank you, sir. Thank you, sir.
Iliac artery.
Yeah. Good afternoon, all present. Now I will present our technique of internal iliac transposition for the reconstruction of a post-renal transplant external iliac artery pseudoaneurysm excision. So this was a 24-year-old ESRD patient who underwent a renal transplant in March. And for 4 months, he was all right. And after that, he started having a little deterioration in the renal functions. He was consulting different consultants outside. And he presented to us 6 months later, and with an anuria of 2 to 3 days duration. So on imaging, it showed a dilatation of the external iliac artery. It was measuring 63 into 35 mm. So this was the CT picture, and this was the intraoperative. He was taken for exploration. And graft nephrectomy was done with aneurysmectomy. And after this area was cleared, there was a defect of around 3 centimeters. So we were lucky, and the internal iliac artery was not taken for the transplant that time. And we took and transposed it to the bridge that 3 because end-to-end anastomosis was not possible. And we took that internal iliac and we rotated and anastomosed to the redundant stem of the external iliac artery so as to maintain the continuity. So for discussion, anastomotic pseudoaneurysm is a rare complication following post-renal transplant, 0.3%. And the causative factors can be either injury to the vessel, or defective suture techniques, or infection, and also immunological factors. Thus, most of them are small pseudoaneurysms, and they are encountered early, and they can be managed conservatively and followed up on successive scans. And only few are infected or larger ones, more than 2.5 centimeters, which are liable to get ruptured, and thus they have to deal with either open repair or endovascular or other modalities like ultrasound guided thrombin injections. So to conclude, synthetic grafts obviously will have their own complications, and they should be avoided as far as possible. And tension-free reconstruction using the patient's own local tissue is the ideal, and we are reporting one such technique of using this internal iliac artery for up to 3 centimeter defects. Thank you.
I guess the transplant was done at your own center?
No, it's a different center.
Different
Actually,
center.
the patient came to us later on.
Okay.
So my question is, Dr. Akshay, this kidney become non-functional? You do the graft nephrectomy, there was slightly rising into the serum creatinine. So the
Yeah.
kidney become non-functional.
Sir, actually, we could not save the kidney because
The purpose of, was the aneurysm repair or was to save the kidney?
to save the kidney, basically.
So you did the graft nephrectomy and you
Yes.
repair that
And
by taking the internal iliac artery graft. So second transplant he will be required, or that kidney was completely non-functional. But look into your
Actually,
image, there was a
and it was
contrast
a-
excretion and good cortex or CMT was also seems to be maintained.
So it was for 3 days, sir, so moreover, we could not.
But my means to purpose
No,
that.
so I
Already
think the
3 days
question
had
is that it was a
passed.
functional kidney.
Could you have saved it?
Could you have jump grafted it or use something else
Sir,
to
very,
save
very
both?
difficult because aneurysm was
Yeah.
very large and actually this patient was not lucky. He lost time, and while taking his history, he had one scan before. It was 2 centimeter, and this was expanding aneurysm. So
And did you have a vascular team also, or this is on your own?
no, sir, we transplant, sir, we only, no.
I
vascular
would,
team.
well, just for the future, God forbid something like this happens, it makes sense to have multidisciplinary because you don't do this on a regular basis. You do the kidney part and but vascular
sir,
is their level.
the only
Their
thing-
range of thinking and doing things is a whole lot different than what we normally do. So
Yes, sir, but
probably
on
better
that
to
spot,
have,
that is what.
better to
happened.
have a multidisciplinary team,
Yes, sir.
just for the future. You could have salvaged a lot more.
Thank you.
Right. Any more? Yeah, yes, please.
For the biopsy, I think
Nephrectomy,
before doing
yeah.
the graft nephrectomy, we should have some biopsy so that we are medico-legally safe or that this kidney was working or not. And second thing, just for my knowledge, I'm asking that what causes the kidney to become non-functional? This is the compression effect or the decreased blood supply leading because of the short aneurysm?
So decrease blood supply only.
But
decrease the blood supply.
I think they, but personally,
No, so there was graft dysfunction, but it was not non-functioning. There's a difference between the two, right? And graft dysfunction can occur due to a variety of reasons. Poor flow, so because it's already functioning kidney. So therefore, the flow dynamics may have been different, which is why it was causing graft dysfunction. It was still a salvageable kidney because it was a precious kidney. It was a transplant kidney. That's why I said multidisciplinary would probably have given you a bit more leeway of salvage. But when
Maybe
you salvage the
we
limb, I
stress
think
more on saving the life than
the limb out here actually, from what I can
life.
understand.
Also, sir, it was expanding, so
Okay,
we had to
right.
take it out.
And no endovascular attempt was made.
So for such a large, there are no reports also, and I think cannot be done. We don't have any specialists
Yeah.
in our city also for that.
In our city, you're working in NCR.
No, Ludhiana, sir.
Oh, I'm so sorry. Okay.
Baseline creatinine, sir, before it was 3.1, sir. 3.1. But 24. Not diabetic.
Probably CGN or
Not
something like
diabetic.
that. Right. Thank you very much.
Thank you.
So that brings us to the end of this session. And thank you everybody for participating. Thank you for the speaking.
So
The
that
judge-
brings us to the end of the session. May I please request Dr. Ravi Mohan sir to present a memento to the chairpersons. Thank you, sir. Sir. So thank you to the chairpersons and to Ravi Mohan sir for such a nice session. This brings us to the end of this session. We have a lunch break now. Just a small announcement that all the faculties can collect their memento from the Inspire Hall, podium number 8. Thank you.
Sì, Serenini, della che ha l'episodio. Sì,
Hello, hello. Hello, hello, hello. Check, 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 check. Hello, hello. Check, 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 check. Hello.
जगह कम पड़ेगी सर.
Check what is it is.
check. Hello. Check. 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 Hello. Hello. Check. Check.
Check. One testing test. Check. One testing test. Check. Hello. Hello. So check. One testing test. ठीक है? Check. Hello. Check. Check. One testing test.
Check. Check. Hello.
एक साथ रहेगी ना, काम वाली एक साथ थोड़ा सेटअप गड़बड़ हो जाएगा ना हमारा, इसको यहाँ डाल।
इसको वहां डाल ऊपर नीचे कपड़ा मारने बस
Check, check, check. Sound test.
जब एक दबा देगा तो सबसे लेंगे
काम करो बजर ना बजर जो बचा हुआ है वो भी यहाँ रख दो में इसमें जरूरत नहीं पड़ेगी बट स्कोर्स डबल होता है ना अब कुछ आया तो बजर चेक होगा आप बाकी जगह पे बजर रखवा वो बचे हुए हैं ना तो टेबल है ही वो तो ठीक है बजर ऑल थ्री कैन एक्टिवेट टुगेदर ऐसे तो नहीं होता ना बजर एक ही होगा मतलब जब दबाएंगे तो बाकी सब इनएक्टिवेट हो जाएगा नहीं होगा ना मतलब भाई नहीं होगा वो बताएगा कहाँ है तो बंदा कहाँ है
हो रहे दोनों
दो नहीं होगा एक ही होगा कल तो मैंने चेक किया था यार मेरे सामने चेक किया था बंदा कहाँ है कल मैंने चेक किया था दिल्ली भाई आया अभी तो
बजर किसके हैं? तो ये पता है इसका फंक्शन कैसे होता है?
Hello, yeah. How many teams are available as of now? I think from PJ Chandigarh are here, na? So, display the screen. Yes. Team C would be PJ Amir Chandigarh. So you have to sit in the, I think C is this one, this chair. So come here and sit here. 3 residents, na? Dr. Krupa, Dr. Anuj, and Dr. Yashashvi. So what you do, the team leader who is supposed to be the team leader, he has to answer. So you both decide one of you guys and you sit in the center. The team leader should sit in the center or any. Did AIMS New Delhi people are here? AIMS New Delhi? Dr. Pratik. Next. Arre. Is there anybody from BHU? RML? Not at reach. Huh? Safdarjung Hospital? SGPJ and SMS Jaipur. From Safdarjung, who are the 3 guys? Yes, you belong to group E. So there on the table it is written there. You can sit in that. 3 people from Safdarjung, right? E is there. From SGPGI, SMS Jaipur, it is G, this one. So the team leader should sit in the center. Okay. SGPGI, yes. SGPGI, it is actually team number F. So this one, those 3 chairs. Can somebody call the AIMS guys? I mean, let me. Okay.
टाइमर को ऊपर ही रहने दो, टाइमर यहाँ दिखेगा नहीं, नहीं टाइमर यहाँ पे दिखेगा नहीं, हाँ वहाँ पे दिखेगा, हाँ इसको थोड़ा सा ऊपर दे दो, थोड़ा और ऊपर ले,
ठीक है सर, ये है ना, मैंने ऑर्डर रखा है।
डीजी थोड़ा और ऊपर ले ले,
ओके
पीआईपी थोड़ा और ऊपर ले ले।
जब नेक्स्ट राउंड पे चलेंगे This mic is off. So a very good afternoon to all of you. It's better since we have a very limited time of 1 hour and we have 7 teams. So it's better to just let me brief you about the process, how it is going to be this quiz. So I welcome you all for the North Zone ISICON inter-institutional quiz today. So as we all know, the total we have 7 teams here. So team A, B, C, D, E, F and G, which has been displayed here. I think the residents' names are here. You can cross check. So first team would be AIMS New Delhi, followed by BHU Varanasi. Then team C is PGIMER Chandigarh. Team D is RML New Delhi. And team E, Safdarjung Hospital from New Delhi, followed by SGPJ Lucknow, and then SMS Jaipur. So let us go briefly about the rules of this quiz. So what we have designed in this case, this quiz has been divided into 3 rounds. The first round would be the elimination round, where each team will be asked 4 questions. So these 4 questions would be asked in turns. Like if I start from team A, so first I will ask each and every team one question. Then the second question will come from there only. So in that way, so that you will have some time in between. The total of 4 questions will be asked. So the total questions would be 28 questions because we have only 1 hour time. So in half an hour, we have to finish that. And then the second round would in this round followed by the buzzer round. In the second round, obviously the buzzers will be there at you. So whosoever presses the buzzer first, so they has to answer. Okay, and then the final round. So in first round, after the end of the first round, 4 teams will go to the second round. The rest 3 will have to be eliminated at that point of time. And then the second round would be constituted by 4 teams, and the final round would be between two teams only. Then the general rules, of course, whatever the question I displayed on the screen, we will read the first question. Then there might be some multiple choice questions as well. So once the multiple choice questions options are displayed, then I will start the timer. The time would be for 20 seconds. So within 20 seconds, you have to answer. Then of course, as I already mentioned, the team leader who is sitting in the center of the team, he has to answer. The rest of the people can help him. All correct questions will be, answers would be given 10 marks. If it is a negative or if it is a wrong answer, or if you don't answer also, specifically in case of negative answering will be there if you answer a wrong answer. So if you don't answer, then it would be 0. What? You have any doubt? Negative 5 marks, minus 5. So positive marks, of course, the correct answer would carry 10 marks. In some rounds, there is an option for passing also, because in the first round, I am briefing it that here also. In the first round, as I already mentioned, total 28 questions, each team will get 4 questions. And these questions are designed in such a way that they are going to cover that uniformity will be there. Like in the first question would be predominantly from anatomy or physiology. So everyone will get such type of question only. Second questions would be like that. So all 4 questions would be in different modeling of the related to urology. So I said already this one anyway. The point in the first round is each team has to answer the question here. Suppose if you don't answer, obviously you will get a 0 marking there. And if it is negative answer, if you say, it is going to be minus 5. So then we will go on to the next round. Okay. Excuse me, just a second. Hello.
So regarding the first round, do you have any query? Right. So there will be 1 question to each team. That question will not pass on. You give the right answer, you get the 10 marks. You give the incorrect answer, you have a minus 5 marks. Right. And at the end of this round, the top 4 teams will move into the another round and the 3 will be eliminated.
So I think time is ready already, 2 o'clock, right? So I think we can start it. If you have any doubts as of now, you can ask me right now only, because then once we start it, then it's going to be a continuous round, because we don't have to waste time much. So are you ready then? So I'll be telling Dr. Gopal, be ready, right?
Okay, sir.
Okay. The first question to team A. Identify the structure pointed out here with an arrow in this radical cystectomy procedure. There is a cord-like structure which is pointed out there. So you have to answer that. Actually, I was specifically telling that cord-like structure. If you see, there is a cord-like structure. That's what I was asking you. Your time is already up. They will give 0 marks. Okay, it is actually the medial umbilical ligament.
Sir, it will be -5 because they have answered.
They answered it wrongly. Yes, -5. Yeah. It's not moving. Slide is not moving. There's something wrong with this laptop. It is not. टच स्क्रीन है इसमें, देखना ये रीसेट भी नहीं हो रहा है. या
जब भी रीसेट करेंगे तो एक बार फिर क्लिक करिएगा क्योंकि फिर ओवरलैप होता है.
The next question to team B. What do shock waves cause to corpora cavernosa? These are the 4 options. Time is out. So they didn't answer the question. So since we are not going to pass this question to the other team, so I will be telling this. Basically, shock waves are used for the management of even erectile dysfunction. So it's a low dose, low energy shock waves are helpful for as a part of management of erectile dysfunction, where it initiates neovascularization of the corpora cavernosa because of multiple trauma. So every time the shock waves go, there will be minor trauma. So that will lead to release of growth factors and then neovascularization as well. Coming to the next question. In cases of renal agenesis, the ipsilateral adrenal gland is. Sorry. Question to team C.
Sir, B. Non-normal position.
Found in normal position, B. Yes, it is correct. So obviously the if you see the embryology of adrenal gland, the medulla is formed from a different origin, has a different form of origin, that is from the ectoderm, whereas the kidney origin is something different, completely different. So the answer is the adrenal would be in normal position only. I don't know why. Which one of the following is true regarding anatomy of kidneys? Yeah, for team D. This question is for team D. No, it is wrong. Dromedary hump is actually more commonly seen on the left side. That is not the correct answer. So the correct answer is D. The main lymphatic drainage of left kidney is to the left para-aortic nodes. Next question is to team E. Neonatal kidney achieves glomerular filtration rate equivalent to the adult's kidney by what time? These are the options. Yes, it's correct. Answer is 2 years. So by 2 years, the GFR reaches the adult type, whereas by 1 year, actually the concentration capability of the kidney will be reaching up to the similar to the adults. Somehow this, okay. What is the conduction velocity of peristalsis of ureter? Normal conduction velocity of peristalsis of ureter. This is question is to team F.
Answer is D, 2 to 6 centimeter per second.
Yes, it's absolutely right. It is 2 to 6 centimeters per second. Males have bulbourethral glands. What is the female counterpart of it? That question is to you. G. What? No, it's wrong. It is Bartholin's glands. So this is done. I think the first round is the first question is over. Now we'll be going to the second question. So
The second round and the first question will be the team A. So identify the crystal which is seen in this electron micrograph staining.
So these are hexagonal crystals of cystine stones.
That's absolutely true. I just request the audience just have a clap when they give the right answer. At least we have some competitiveness. Unfortunately, we don't have some audio systems or music, so that we can just increase the excitement. So this is a X-ray of a 50-year-old female. Okay.
can you minimize that?
Can you just minimize that?
Score, there is no need to see the score right now. You can minimize it. Yeah.
So this is an X-ray of a 50-year-old female who has a long history of ankylosing spondylitis with recurrent lumbar pain. Spot the diagnosis which is seen in this IVO film.
Sir, answer is B, IgA nephropathy.
No, sorry, it's a wrong answer. It's a renal papillary necrosis, and this deformity is called egg in cup deformity. So this is a urodynamic film of a patient, and this question is to team C. Identify the abnormality in this tracing.
Sir, small capacity detrusor overactivity. Small capacity bladder with detrusor overactivity.
Absolutely right. You can see there are certain leakage also during the filling phase of this CMG. Now, what is the diagnosis in this middle-aged female with a recurrent loin pain resistant to antibiotics? And this question is to team D.
What?
This is a wrong answer. There is no air in this CT scan. There is a typical beer paw deformity which is seen in XPGN, that is genithogranulomatous pyelonephritis. So next question will be to team E, and identify the abnormality and the possible diagnosis in this IVP. Yes, it's a retrocable ureter. What this deformity called as? Sorry? What? Negative marking for the cross answer. Please.
Please don't give the answer.
So, but we take your answer. It's a retrocable ureter, and this is the fish hook deformity. So next question is to team F. What do you call this characteristic X-ray picture? Yes, absolutely true. This is a pie in the sky bladder, and this particular X-ray is showing a pelvic fracture, and there's a pelvic hematoma which is pushing the bladder up. in the sky.
Correct answer. Next question.
Following are the incidental finding in a 28-year-old male on a routine evaluation. What is the most likely diagnosis? No. Yeah, it's absolutely true. It is hypertrophied column of Bertini. It's a normal part of the kidney. It's not a tumor. It's just an anatomical aberration in the kidney. So this is the end of the round 2 in the first round. So now we move again to the team A. So these are some clinical scenarios. A 75-year-old male with a history of kidney cancer 2 years back found to have a 2.1 centimeter adrenal mass on surveillance CT scan. The next step in the management is you do a biopsy, you resect the tumor, you do metabolic workup, you carry out some systemic therapy for the kidney cancer, or you just observe it. Absolutely right. Any adrenal mass should be evaluated for metabolic workup, and then we decide what to do next. So next question is to the team B. A 47-year-old man has a 3 centimeter renal tumor, which is located in the posterior upper pole. He has a history of inflammatory bowel disease, and with a previous small and large bowel resection, temporary colostomy, the best surgical approach in this particular patient is you will go subcostal, mini flank, flank open, transperitoneal laparoscopic, or robotic assisted transperitoneal.
So C, flank open.
See, absolutely right, because he has underwent transperitoneal procedures earlier, so it's not a good idea to do a transperitoneal approach. Subcostal, again, it will be the anterior approach. Mini flank, you are going for a partial nephrectomy, so mini flank is not good option. So open flank is the right among these are all the options. So you can also do a retroperitoneoscopic if you are very much aware of that thing. There's a 4-year-old child who presented to the casualty with acute pain in the left side of the scrotum. Clinical examination was done, which showed the following finding. What is the further management?
Sir, answer B, immediate surgical exploration.
Yes, absolutely right. And what could be the probable diagnosis?
Sir, torsion of testes.
Okay, I just got this answer corrected by the answer is conservative management. This is not the testicular torsion. This is the torsion of the appendix of the testis, and this is called blue dot sign. So in this case, you have to do a conservative management rather than surgically exploring the patient. This answer is wrong. So next is to team D. After robotic cystectomy with bilateral lymph node dissection, your patient returned with fever, unilateral lower extremity edema. Imaging demonstrate a large left fluid collection with negative HU unit, a thickened and enhanced wall. What is your next step in the treatment?
So drain placement and antibiotics.
Absolutely right. Okay, this was team D. No, team D.
Negative.
Oh.
-5.
-5.
-5.
No, -5. Because when you are in any competitive thing, anything which you do wrong is something which is wrongdoing. So -5 for the team E.
What to do for them? They didn't have the question.
For them, we have another question. Don't worry. So now this question is again to team D because E has missed their chance and is -5. So a 53-year-old man undergoes an elective left open partial nephrectomy for a 4.1 centimeter upper whole renal mass. During the surgery, only the renal artery is clamped, and on the incision, when you do the incision of the tumor, brisk bleeding happens. The hilar palpation and the dissection does not reveal any additional arteries. What will be the best next maneuver among all these? This is for team D. So time is up. So the best thing which can be done in these cases is to manual compress and proceed with partial nephrectomy, because if you clamp the renal vein, the bleeding will more happen because it is an arterial bleed which is brisk. Intraoperative duplex ultrasound identify the additional artery. It is a long time taking procedure, and once you have clamped the arteries and cut the tumor, you don't have the time. Pedicle clamp is not a right idea. You just manually compress it, and if the bleeding can stop, you can just proceed ahead. Nephrectomy should always be the last option as a damage control. The next question will be to team F. Which of the following surgical steps should be avoided in order to minimize the long-term impact on the continence during robotic radical prostatectomy? Which things should be avoided? Time up. You have lost your time. So among all these things, you maintain the puboprostatic ligament for the good continence. You place the anterior anastomotic suture under direct vision. May have the maximal preservation of the urethral tissue. You don't want to do aggressive hemostasis of the venous wound in the periurethral tissue. So that should be avoided if you want that your patient remain continent after the radical prostatectomy. The next question is to team G. A 63-year-old man experienced fever 12 days after radical cystectomy and is found to have a 4 centimeter pelvic abscess. A percutaneous drain is placed by the IR team under the local anesthesia. This is a Clavin-Dindo grade complication. No, B option 3A is the answer. Absolutely correct. It's a 3A because you have a complication which can be managed under local anesthesia. If the patient has to go back into the OT, will be 3B. So that's we end up with the third round. Now I just hand over the mic to Dr. Sudhir for the fourth round. Sorry?
So these are actually clinical. So these are clinical based questions which we have completed so far. Now the next 7 questions would be we will be giving a picture of a renowned urologist or whatever it may be. Some photograph will be there. You have to tell the answer. So legendary people in urology. So starting with team A, right? Score at the end we will tell you. After this thing, the round 1 will be over, so we can tell you the scores there. So identify the gentleman in this picture who has introduced TURP and has also authored a book in reconstructive urology. Team A. Oh, sorry. No, your answer is wrong. He is John Blandy. So he is very good at his drawings also. You might be knowing people, you have books also related to him also. Blandy's erythroblasty book also is there. People routinely read it also. So he is John Blandy. He is a British. Now the next question to team B. Just a second. Yeah. James P. Allison and Tasuku Honjo. These 2 gentlemen were awarded Nobel Prize in Physiology or Medicine, basically in 2020. So based on what work they got the Nobel Prize? On question to team B. They shared his Nobel Prize actually.
They have contributed the urology in some indirect manner, but they have got the Nobel Prize just recently.
Time up. So that doesn't have any marks for this question. So basically, this is on immunotherapy. Now you have seen in each and every part of malignancy now, immunotherapy has been so rampant now. Even the first line therapy now immunotherapy have come up. So these are the people who have contributed to that. So they identified that by modulating the immunity, we can even arrest cancer, the spread of cancer. So that is what it is. So cancer immunotherapy basically. So going to question to team C. Identify the gentleman in this picture who has pioneered in endovision system. Question to team C.
There's omnipresence in all the urological OTs.
Time up. So he is Harold Hopkins. Okay, so you know the Hopkins 1 and Hopkins 2 system. Let's go to the next question. The question is to team D. Okay. Identify the gentleman here who has done major contribution for in relation to understanding the BPH and also prostate cancer. Oh, sorry, timer I have to start.
Charles Huggins.
Wrong. He is Walsh. We have a textbook also, Campbell Walsh textbook. So he is Walsh who has.
He is in the pioneer work in the anatomy of the cancer prostate and also the role of 5-alpha reductase inhibitors in the BPH.
Yes. So the question is to team E, right? Identify this gentleman in the picture. The instrument which is shown here also is under his name only.
It's very commonly used instrument in all the urological OTs.
Time up. Time up. So they carried on no marks. So it is actually even the retractor name is Turner Warwick retractor. Of course, for urethroplasty, you routinely use. He recently last year only passed away basically. So he is Turner Warwick.
He has given a very good statement about the residents. A good resident always remain a good doctor, and a bad resident can never become a good doctor. So be a good resident.
And the next question to team F, right? Identify the gentleman in the picture who was awarded Nobel Prize as well.
He got the Nobel Prize for his work in urology.
Your time is up actually. After that, you told. You told twice? You consider. So we'll consider it. Okay. So he is Charles Huggins, basically on hormonal therapy for prostate cancer. You all of us.
And next time when you answer, you just press the mic button and then say it. Loudly say it.
Okay.
Right?
So the last question to team G. So inventor of the instrument which is shown on the picture. So you have to tell the name of the person. Time's up. Gopal, no marks for it. No. Okay. So he is actually, this is a instrument is actually the initial cystoscope. So it was first invented by Nitsch, Friedrich Nitsch. So I think we have completed as of now. So 4 questions for each team we have completed.
So
Let
round
us
of
know
applause
the-
for the team, please. At least they have tried their best.
Can we have the scores, please, as of now after completing the first round? It's 2:30. I think we have okay time.
So the team A, which is Ames, have +10. The team B, the BHU, has +5. The team C, PGI, has +15. The team D, RML, has -15. The team E has +15. The team F has +20, and the team G has +15. So in this,
Excuse me, sir.
the least 3 are the -15 with the team B. It's eliminated. Then the +5 BHU and the +10 Ames. So sorry, you have tried good, but you have to be eliminated. You cannot go ahead in the another round.
Team F has?
वो last हमने आंसर दिया था. Okay.
Team F
Last
has-
हमने आंसर दिया था.
Acha, acha. So add 10 more marks there, right? Huh? Yes, we are
Last
given.
was given. No, it's given. It's given. They have answered. So
Actually,
we have given
mics,
them.
there is some problem. They pressed the mic that we didn't hear. That's all. So they got 30 marks, right? Then.
So the team A, the team B, and the team D. So Ames, BHU, and RML. Sorry for you. You have to just get yourself eliminated and be in the audience. And the team C, PGI, the team. So team PGI, team Safdarjung, team SGPGI, and team SMS. They should. You can come forward, I think. I think the best is that this team just move up to that team. So then we have all the 4 in one row. Yeah. They will be carried forward. So how the whatever performance you have given in the round 1 will have a weightage in the final assessment. Next.
That I will tell in the rules.
Right.
So, आप ही बताना.
So now the team A will be the PGI team. The team B will be Safdarjung, and the team C will be SGPGI and team SMS. Okay, that's great.
Position has not changed from the beginning. Yes. Yes.
So coming to the next round, basically this round is a buzzer round. So we will be displaying 14 questions total. So from the beginning, so the timing would be the same. What we have to do is whosoever presses the buzzer first, so they will be given a chance to answer. Supposing if you press the button and suppose this team got the chance to answer. If they answer it correctly, they will get points. If they answer it wrongly, they will get -5 anyway, same as usual. Suppose if the answer is, if they doesn't answer, if they pressed it but they didn't answer, they will carry a negative marking of -5. And the question, if it is either incorrect or if you don't answer, it would be transferred to the next team by your side. So the order would be like this. Suppose if this team has got selected, the question will go to them. And so next, we will not.
If they pass.
If they don't answer, or if they answer it wrongly, then that will come to you.
Okay, sir.
No, there is no sequencing because the buzzer is like that. Once you press one buzzer, the other will just sign off. So we cannot have
So
1, 2, 3. So if the team C presses the buzzer, they are not able to give the correct answer or no answer, then automatically this question will go to the next team. If you press the buzzer, then go to that team. So now this is the battle of the cities.
Yeah.
So we have Chandigarh, we have Delhi,
He has a question there.
we have Lucknow, and we have Jaipur. Right? Yeah.
Yeah.
In case of incorrect answer, they pass question incorrectly. Even
Yeah.
then we have
Five marks.
or we can attempt it.
No, that will be -5 marks. And if you give the right answer, it is +5
And if
marks.
you don't answer in the past, this question,
Right? Actually, the disadvantage of not answering the question will be given. Yeah, yes, definitely. Yes, definitely.
But if you don't answer, they will get minus. They will be negative mark.
If second team won't answer, that question will be passed to third.
Yes. Yes.
And second team will not.
Yeah. So passed question, you will get only 5 marks.
In case of incorrect answer, will it be passed to the?
Yes, obviously. So any passed question, if you answer, you will get 5 plus points. But if you don't, still again, if you also answer incorrectly, then again you will get -5.
If the passed question is not answered by the second team.
Then it will go to 30. So that would, the order would be like this.
That team will
Not get any negative also.
If
No.
they answer it incorrect. Now I summarize. Every question has 10 marks. We ask the question, you press the buzzer. Whoever press the buzzer first will have an opportunity to give an answer. If you press the buzzer, you have to give an answer. So if no answer or incorrect answer will have -5 marks. If there is no answer or incorrect answer, then automatically the question will be passes to the other, so that the advantage should be there with the other team also. You have an option to pass it or you can answer it. If you answer it correctly, you will get 5 marks. If you answer incorrectly, you will get -5 marks.
If you pass
on,
zero.
then it will go to the
Other
third
team.
team.
So you will not lose any marks. There you will be 0. So you have to say pass.
So we are team C or team F?
No, same coding. So they will be team C. But the rest of thing you have E, F, G. That will be same.
I'll just assist you. This is Chandigarh, Delhi, Lucknow, Jaipur.
So let's go on to the second round.
Just be on the buzzer, and remember, if you press the buzzer, you answer wrong or you not answer, there will be a -5 marks. Right?
So I will be
So all the
displaying
best.
the first question of the second round, right? A 34-year-old male presented with azoospermia. Hormonal evaluation was normal, and FNAC from both from the testes showed maturation up to spermatozoa. Identify the procedure shown in this picture. Yeah, team G.
Team Jaipur.
Vasoepidermostomy.
Vasoepididymostomy. Yes. Answer is correct. Gopal, you have entered it, right? So the marks to team G. Next question. Identify the instrument shown.
This is cystoscope with Alburin bridge.
Yes, correct. Perfectly right. 10 points to team F.
I like the speed on the buzzer.
So be ready. Next question. Name the technique or the procedure, operative procedure, which is shown in this picture. Yes,
Team Chandigarh.
Team Chandigarh.
Rectourethral fistula repair. Name of the technique.
You need to specifically tell the name of the procedure.
Yoke Mason.
Yes,
Absolutely.
absolutely right. Good. So team C, the Chandigarh carries 10 marks.
These are the procedures which in urology we seldomly do any procedure with the prone position except CNS.
Yes. Name the procedure shown here, which is used to treat stress urinary incontinence.
Team Chandigarh.
Birch Colpus suspension.
Wrong. -5 to team C. And the question will be passed on to you.
Team Delhi.
Team Delhi, F.
You have an option to give the answer or you can just pass on.
If you know the answer, tell, otherwise pass on.
Team Lucknow.
Team Lucknow.
Team
Pass.
Jaipur.
Team Jaipur. If you say it wrongly, it will be -5.
-5.
Pass. Anybody from the audience?
MMK. MMK.
Yes, absolutely right.
10 mark- 10 marks
who
to
has,
him.
Who has told 10 marks to him? Thank you.
अनु boss ने दी नहीं हमें.
Good. Going to the next question, be ready. Name at least 2 graft materials which can be used during the surgical procedure to correct the deformity which is shown
Team
here.
Chandigarh.
You need to tell 2.
Bovine pericardium and buccal mucosal graft.
Buccal mucosal graft.
Bovine pericardium and buccal mucosal graft. Temporal fascia.
Can be used. Basically, it can be considered basically, but buccal mucus is so not commonly used basically. I think answer is correct. What they have told, you can give 10 marks to them. Good. Name the indication of using this device in urology.
Overactive bladder, sir.
Overactive bladder.
Underactive bladder.
Indication. You have to be more specific.
What you
What
want to
type
do
of
in
overactive bladder?
This device do.
Sacral neuromodulation के लिए करते हैं sir.
Yes.
Yes.
Yes, it's absolutely right. This is interstim, which is actually used for sacral neuromodulation. Of course, the various indications are there, of which one of the thing is a refractory overactive bladder, because they are anyway on the line only. So you can give 10 marks to them. Identify the device shown here.
Endopilotomy stent, sir.
Yes, it's absolutely right. It is endopilotomy stent. So you have a proximal proximal wider lumen stent size will be there here. It would be ranging up to 14 to 15 French, whereas a distal would be somewhere around 6 to 7 French.
Other team don't give a walkover to Chandigarh. Just buck up some.
So you have to be ready in pressing the buzzer. Let's going to next question. Yeah. Identify the device which is shown here.
TOT tape. Sir.
Wrong.
Sorry. AMS.
No, you have given the wrong.
You have
answer.
given the wrong answer. The question goes to other team. What is this device which is shown in the picture?
Yes, sure. Only then you answer. Otherwise, you get minus
Artificial
5.
urinary sphincter.
What?
This is the artificial urinary
You have to be more specific.
AMS device.
Wrong. They carry -5. Pass. You have to speak on the mic. Pass or pass? Pass. So this is actually atoms. This is a device which is used for male urinary incontinence, particularly following radical prostatectomy or post-URP incontinence. The zonal anatomy of prostate was described by
McNeil.
Yes, it's correct. So 10 points to team F. Team Lucknow.
The Nawabs from Lucknow. Royals from Jaipur has to just buck up. And the Delhi
Identify the technique shown here.
Blue light cystoscopy, sir. Fluorescent cystoscopy using 5-amino-levulinic acid.
using
5-amino-levulinic acid.
No, it's not correct. Next team.
It is narrowband imaging.
Yes, it is narrowband imaging. Basically, you can see the vessels getting more prominent there. So, yeah, -5 to.
चंडीगढ़ वाले बहुत तेज चल रहे हैं, कहीं बीच में एक्सीडेंट हो सकता है.
So this is narrowband imaging. The wavelengths which are used for, I think you people know it, 415 and 540. So Let's go to the next question.
Punjabis from the Chandigarh are very rampant.
Name the procedure shown here, which is used for anterior urethral stricture repair.
Orandi flap.
You have to tell. Yeah.
Orandi flap.
Acha, you have already. Okay. Correct answer. It's a vertical penile skin based flap, which is used for anterior urethral stricture repair. It is Orandi flap.
I think you have your hand on the buzzer.
You keep the hand on your buzzer.
If you just delay by even the 1 millisecond, it will not work because somebody other have pressed the things.
Sir, this question. One more question.
Okay, we'll disqualify it, no problem. No, for the previous question.
No, sir, we know that, sir. They also know that.
They have also given at the same time.
We didn't hear them.
Actually, the problem is that
Or else we can
सर
delete.
हमारे पास रिव्यू एम्पायर नहीं है ना वीडियो दिखाना पड़ेगा.
Give 2 more questions extra. Questions about my controversy. Still we are going next question. I think they have already shown it. Now we have to disqualify it.
Yes, sir.
So next question I am deleting. We will give another question then. Huh? So this question is, of course, what is the technology? Just for casual, I am asking who can answer it. Yeah, Firefly technology. Okay. Let us go to next question. Be ready. Which chromosome are affected in the abnormality shown in the picture? You have to tell the chromosomes.
just have
Chromosome
15
16,
seconds.
sir.
Sorry?
16 chromosomes.
You have to tell 2 chromosomes because it's generally affected 2 chromosomes. The mutations will be in 2 chromosomes. You have
4
to
and
tell
16,
both.
sir.
4 and 16. That's right.
Absolutely right.
PKD1 and PKD2, autosomal dominant polycystic kidney disease.
The royals of the Jaipur are coming up.
Going
सर वो पूरा ही होता है सर आधी जीत नहीं होती पूरी जीत होती.
Going to next question. Name the structure that was looped here during RARP and its clinical significance. So you have to tell the structure and also its importance. Yes, you have to tell both the structure and its importance.
Sir, neurovascular bundle and its
Wrong.
preservation.
Absolutely
Answer.
wrong.
Absolutely wrong answer.
The question will pass.
Question will pass on to team F. I mean team what is it? Team Delhi.
Accessory parental artery and it helps in maintenance of the continence mechanism.
Time up is for the next one. Sir.
Yes, you are absolutely right. It is actually pudendal artery, and the importance is you should not injure this artery while doing RARP. Otherwise, the patient will end up with erectile dysfunction as well as problem in continence as well. So this is very important. Then going to next question. Be ready with your hands on your buzzer. So I think -5 points to PGI and then 10 points to them.
Five, sir. Five.
5 points. Sorry. Yeah. I think the round has finished it. I will show another question because one question we have deleted. इसका minimize करके ना next PowerPoint दिखाना है. नेक्स्ट राउंड आप कर एक एक्स्ट्रा क्वेश्चन अभी कर लेते हैं. दिखाओ रे पीपीटी एक्स्ट्रा क्वेश्चन फर्स्ट स्लाइड फिर इसको मिनिमाइज करना है, फिर वापस वो एक ही क्वेश्चन। ओके, so we are asking only single question as of now, है ना, the one which was cancelled.
Right, and team
So-
team Delhi has missed this question. Huh? So you have your hand over the buzzer.
So be ready. So I will be projecting a picture. You have to spot the diagnosis. I am telling from the beginning. Yes. This laptop.
They have just pushed the buzzer, then they think of the answer. Good. Royals from Jaipur. You just have
अगर ये
7,
time पे नहीं बोले तो minus
6,
5 देंगे इसको।
5, 4, 3, 2, 1.
Yes, they are right.
That's the last
few
call.
seconds of the-
Last call thing.
हम इसको back कर।
This is the real climax.
So I think
we're just getting the score. And after this round, 2 teams will be eliminated going back and 2 teams will be coming forward. Again, in this, because we will having the 2 teams. So obviously one will have the first chance to answer the question, whoever push the buzzer first, and automatically the question will be passed on to the second team. And if you correctly answer the question, you will get 10 marks. Incorrect, no answers will have -5. And past question, if answered correctly, will have +5 and -5. If answered incorrectly, if you just pass on it, you will be 0.
Repeat, sir. Repeat, sir.
So I will just tell. हाँ हाँ टाइप कराएंगे सर अभी. So
सर बजट स्लो है.
yeah.
So अब आप क्वेश्चन और पूछते रहिए, जब गलत हो जाएगा
We can have these things in the buzzer round itself. No, so we have 2 teams tying up. We will ask 2 questions, and then we ask if one team is giving 2 answers correctly, then he will definitely move ahead. So you have the -5 marks also. So we
इसको ऐसे रख दो।
So team SGPGI moved ahead into the final round, and we have tie-ups among the team Chandigarh and the team Jaipur. And
दो टीम है ना, दो टीम है। ठीक है। So since आप अभी बता दो।
so the team Chandigarh and the team Jaipur, we will be asked 2 questions to each of you, and among these 2 questions, if you give answers of 2 or 1, then we decide if there is. And if in case still you are on the same things, then we have into the tiebreaker thing. Whoever the answer the question first, another team not able to answer, that answer team will move ahead. So this will not be a buzzer round. There will be no buzzer. We will asking direct question to team Chandigarh, 1 question, and team Jaipur, the second question. So your question is.
बजर नहीं है ना, पहला उसको किसको दे रहा हूँ क्वेश्चन?
The first question is to team Chandigarh.
सर ये हो तो गया. Just
ये हो
नहीं
गया।
सर, next question है सर, ये कंप्यूटर ना बहुत धीरे चल रहा है.
सॉरी, हाँ वो वाला।
Identify the abnormality in this X-ray. Team Chandigarh.
ये क्वेश्चन पास नहीं होगा।
ये क्वेश्चन पास नहीं करना। एक क्वेश्चन पूछा, next question.
Time up.
Time up. We will not pass this question. We'll ask another question with the team Jaipur.
The answer is, you can see there is a calcified lesion which is seen in the pelvis, bilateral vas. So this is actually a case of bilateral vasal calcification, which is commonly seen in diabetics. Of course, very rare to find it, but the abnormality which you are seeing here is in the pelvis actually.
So team Jaipur, your question will be next.
Name the index which is with its components also, which is used to predict the need for elaborative perineal or abdominoperineal approach during pelvic fracture urethral distraction repair. What is that index called? And you have to tell the components of it.
How you predict that the urethroplasty will be more elaborative or a simple one?
Gapometry index.
Sorry?
Gapometry index.
Yes, you are correct. Can you tell the components how it is calculated?
The length of the stricture divided by the bulbar urethral length.
Yes, you are right.
Absolutely right.
Absolutely right.
In this tiebreaker, 1-0. The next question with you,
उनको
the team
गोपाल
Chandigarh.
को बता दो 10 मार्क्स to him ना ओके नहीं फाइनली जब हम ऐड करेंगे पूरा स्कोर ओके so going to the next question to PGI Chandigarh huh? What is the size of Muir-Meyer stone punch forceps?
Do and die, and this is
Sir, 21 French.
21. Absolutely wrong.
It is wrong. It is 25 French.
So automatically the Jaipur team move ahead.
Even then, as we decided, we have to ask.
The tiebreaker question. So Jaipur team will move ahead. Now we have two teams, the team Jaipur and the team Lucknow. So the Nawabs of Lucknow fighting against the Royals of Jaipur.
गोपाल को I think we have to clear to गोपाल that इसका points ऐड नहीं करना है.
The team
वो पूछ रहा है ना.
Lucknow, just move on this
ये
side.
clear कर दो. These points will not be added.
These points which we have asked in tiebreaker, these questions will not be added to the last score. This is just for to find out who is the best among these two teams. ये लैपटॉप तो हमारा ही क्विज ले रहा है।
नहीं ये बताइए
हाँ बजर
एक्सक्यूज मी आप आ जाओ पर इसको होने इसको मिनिमाइज करके प्रीवियस पावरपॉइंट को कर so we have 5 minutes left so in the final round total of 8 questions will be asked.
Before that, just give some backup boots to the Chandigarh, no, Lucknow and Jaipur. This is the buzzer round. And again, the same thing, the correct answer will have 10 marks. The incorrect or no answer will be have -5 marks. The past question, if answered correctly, 5 marks. If you don't answer correctly, -5 marks. Right? And in this particular round, we will have 8 questions. And if the score is labeled, then we have the tiebreaker as we have in the last round. So be on the buzzer. But what is the drug which act here as pointed by an arrow? Team Lucknow.
Sunitinib.
Sorry?
Sunitinib. It is wrong. You see the one which is pointed out at an arrow there is actually inhibiting MET, AXL, AXL and VEGFR. All these three receptors should be. So the question would be, the answer is wrong, which is what they have told. The question is passed to other team.
You just get 10 seconds for that, out of which 5 you already taken up. So this question is done. Anybody in the audience can give the answer?
Yes. It is cabozantinib. So it is cabozantinib being used for the treatment of advanced renal
I'm
cell
sorry, we don't
carcinoma.
have the chocolates.
Okay. So going to the next question.
What is LV-MOPAM and where it is used in urology? Correct. And what is the use in urology?
Sir, radical cystectomy, in radical cystectomy.
For what? Doing the radical
Gut
cystectomy?
mortality.
Sorry?
For gut mortality.
Yes, absolutely correct. In enhanced recovery protocol, we use this drug to regain the gut activity ASAP. The next question, the hand on the buzzer. Name the phase 3 RCT done comparing the MVEC and the GC perioperative chemotherapy for muscle invasive bladder cancer.
You are absolutely right. It is VESPER trial.
Good. And can you tell what is exactly the outcome of this trial? It's just for the information. Right. So we just move ahead to the next question.
Complete response rate was better with
GC.
DDMA.
Which of the following pulse shape best describe thulium fiber laser, the new one in the armamentarium?
You have to answer A, B, C, D. You have to select the best one.
Answer.
D. You are absolutely right.
And what it signifies?
So can you tell the other A, B, and C? Pulse laser. But see, if you see the A picture, this is a short duration pulse, whereas the B picture, it is a long duration pulse. So it has laser has evolved like that only. First short duration came up, then the pulse duration is increased because it reduces retropulsion. The C is actually the Moses technology, where you have the peak in, you get a smaller peak initially, and then the larger energy will be delivered later on. D is actually the thulium fiber laser, where the retropulsion is significantly lesser. So it's a correct answer. Coming to the next one.
Name the oral GnRH antagonist approved for the treatment of advanced cancer prostate in 2020.
Relugolix. That's correct. You are absolutely right. It is Relugolix. What is the trial related to that? Can you tell the trial?
Aero trial, sir.
Yes, good. Absolutely right.
Good. Somebody has. Name the flow rate nomogram used for assessing voiding function in man more than 55 years. Yeah, press the buzzer before asking the question and seeing the options.
The time.
It's Liverpool, Bristol, Suffolk, Syracuse. Your 8 seconds already passed. This timer is slow.
It's wrong. Bristol nomogram is the answer. So for men more than 55 years, Bristol nomogram is the one. Whereas Syracuse is for less than 55-year age group men, and Liverpool is for women.
So this is an MCQ.
So this is MCQ generally we
because
can
then
pass
we
it.
have 3 options available. So always listen the question first and then try to answer.
Going to next question.
What is the mechanism action of Tudolons? Absolutely correct. Good team Jaipur. Among holmium, thulium, diode, KTP, which one have the least depth of penetration? Absolutely wrong.
Sir, one request, please. Can we have whether the question is going to have options or not?
More options are there.
The option is already there.
Yeah, just a request.
It is passed to you out now. Now you can answer now. Don't waste time.
Holmium.
Holmium, yes, absolutely correct. Now your question, because every time when I ask the question, before ending the question, they have pushed the buzzer.
Yeah.
So they know that there is an answer which is known to them.
Okay.
So that's in a buzzer round, whoever is first to respond, we have the upper hand.
Yeah.
So if you know an answer before putting my MCQs, you have to press the buzzer.
Okay.
That's it. We have 8 questions. And now we have the final score. Just display the final score. So team Jaipur and team Lucknow, you played very well. Right? And rest of the team, I think if they are here, everybody is up to the marks. And उससे ज़्यादा quiz हमारा और होता है इस लैपटॉप के साथ में. कौन सा बटन दबाना है? MCQs यहाँ से. So it's a hard job with whatever availability we have.
Display the scores.
Display the score. So Royals from Jaipur, they have won this interinstitutional. And they have somebody in the audience who is just making the, what do you say, third player or the second team, bucking them up. The second prize goes to team Lucknow, the Nawabs of Lucknow. All the team members can come up to the dais. We will have a photograph together. Stage पे आ जाओ यार.
So, congratulations to all the teams, I would say, because they have participated very well. And finally, congratulations to the team which has got the first prize, SMS Jaipur.
सर हाँ टाइमली
रिक्वेस्ट था, जैसे SGPGI में जो डॉक्टर मधुर थे उनकी जगह मैं आया था, डॉक्टर अभिषेक, तो वो
चेंज कर लेते हैं वो तो चेंज करके सेव कर लेंगे ना, that would be better.
जी सर.
अच्छा ये वाला, ये तो अभी बंद करना है मुझे. एक ऐसा इसका मैं 1 मिनट उसी में चेंज करता हूँ, मेरा लैपटॉप पे कर लेता हूँ। ये हटाना है वाला माइक।
Hi, the thing. Can we get going?
Sorry, sir. Sir. So good afternoon. Can we have some silence, please? Good afternoon. Now let us start the next session, that is the CMC Best Poster Session 2. I'd like to request our chairpersons, Dr. Sudhir Khanna sir, Dr. R.L. Nayak sir, Dr. Samir Trivedi sir, and Dr. Subhash Yadav sir to take their places on the dais. And please start the session. Thank you.
Good afternoon, everybody. So can we start? Now, this is the CMC Best Poster Session, Session 2. And the first presentation is by Amit Bansal, Comparative Analysis of Perioperative Complications in Kidney Transplant Patient with Coronary Artery Disease. Dr. Bansal, please.
Sir, may I start?
Yes, please do that, Bansal.
Good afternoon, sir. Thank you for the opportunity. The topic of my presentation is comparative analysis of perioperative complications in kidney transplant patients with CAD on dual antiplatelet drugs. Patients with end-stage renal disease with coronary artery disease are often on antiplatelet drugs, and these often need to be stopped before the surgery in fear of perioperative blood loss and anticipated constipations. However, the papers in 2014 and 2021, these papers contradict this assumption. So we set out to retrospectively analyze the perioperative complications in such patients. It was a retrospective analysis of prospectively maintained data from January 2014 to December 21. The patient subset was ESRD with CAT patients taking dual antiplatelet drugs. Preoperative cardiac evaluation was done by a senior cardiologist, and the patients were stratified into high risk, moderate risk, and low risk group as per the cardiologist evaluation. So all the patients who were in low to moderate risk group as per the cardiologist, those were categorized in group A, and antiplatelet drugs could be discontinued prior to surgery. The patients with high risk of perioperative cardiac events, antiplatelet drugs were continued. Perioperative parameters were noted as mentioned ahead. Now these groups were comparable in terms of age, gender, BMI, history of maintenance hemodialysis, pre and post-operative hemoglobin levels, blood loss, and need for blood transfusion. We did not observe any adverse cardiovascular event, and no patient needed any intervention for bleeding, and no graft-related complication was noted. These are the summative findings. The only factor we found different between the two groups was the drain output. That was significantly higher in group B as compared to group A. By the time we submitted this abstract, we did not have a complete analysis of the follow-up of up to 1 year after the surgery. And we have recently conducted that also. So by the end of 1 year, we have seen that there is no difference in the graft function between the two groups. Now, the strength of the study is we set out to since this was this being a retrospective study is a weakness of the study, since we could not get a permission for prospectively analysis of this assumption based on 2 papers. But the strength lies is that we took out the data which we already had and the situations that we faced and analyzes, and so far we have come to this conclusion that with proper attention to intraoperative hemostasis, renal transplants can be safely performed in patients with ESRD and CAD without stopping these antiplatelet drugs.
Question from the house. There should not be any comments. Only questions.
When you say drain, so what do you mean by drain? It was urine or blood?
Sir, it was the perigraft drain, serohemorrhagic output.
What was that? Was the?
It was the perigraft serohemorrhagic output. That was not urine.
Did you use any bridging therapy?
No, sir. No. In the post-operative period, on the post-operative day 1 onwards, when the patients were orally allowed, the antiplatelet drugs were continued. The obvious 1-day break was there when the patient was NPO. Only that day, patient did not take either clopidogrel or aspirin. From post-operative day 1, the patient was started on both the drugs again. Since as per the cardiologist evaluation, there was high risk of adverse cardiovascular events if these drugs were discontinued, sir. And especially most of these patients were the ones who were neither tolerating hemodialysis and they had repeated failures of CABT catheter placement also. Hence, the number of the patients in that particular subset is very less.
Your anesthetist is comfortable without bridging?
Yes.
Right.
How do you explain the increased drain output in a particular group, which was significant statistically, I believe?
Yes, sir. Increased drain output was significant. That drain output does not only comprise the blood, it also comprises the lymphatic fluid.
That's okay. But why in that particular group it was high? Because the groups were matched otherwise, except for this difference.
So it could be because the dissection technique since all these cases were not performed by a single surgeon, the technique of dissection in the iliac fossa to prepare the renal bed may differ, and that may affect how the drain output happens.
Any difference during perioperative?
In the what we analyzed in the patients in which these antiplatelet drugs were continued, in those patients specifically, we saw that in all the patients, Surgicel had to be put around the vascular anastomotic site. But of late, this has been our practice in all the patients who are undergoing transplant.
Thank you, Doctor.
Thank you.
Thank you.
The next speaker is Dr. Prateek Garg, and he will be speaking on comparison of right renal vein stump retrieval with additional IVC cuff using endo TA stapler versus Hem-o-lok clip.
Good evening, everyone.
Thank you for the opportunity. Today I will be speaking on the comparison of the right laparoscopic donor nephrectomy with additional cuff retrieval done using the endo-TS stapler versus the Hemalock clip. First introduction, as we know, we are performing laparoscopic donor nephrectomy since 1995, and it is the standard of care at present. There have been concerns regarding the adequate length of the right renal vein. So most of the lap donor nephrectomy is done on the left side. The preservation of adequate renal vein on the right side poses challenges for the transplant purpose. There has been concern regarding the quality of work and the vessels after laparoscopic harvest, especially with the right side due to the short and the thin right renal vein. The control of the renal pedicle is the main step, critical step in the lap donor nephrectomy. The devices that are available for controlling the renal pedicle in lap donor nephrectomy has been found to be divided into clips and staplers. So here we share our experience with the use of the endo-TS stapler versus the Hemalock. During the period of 2007 to 2021, up to the October of this year, we did 248 right donor nephrectomy, out of which in the 54 cases we use endo-TS stapler, in 194 we use the Hemalock clip. The length of the right renal vein was measured using the vascular imaging with the renal angiography with the 3D reconstruction. On using the endo-TS stapler, it was applied on the IVC, while hemoglobin we were able to apply on the right renal vein. We did the measurement of the right renal vein on the during the time of the benching on the table, and the difference in the renal vein which was compared with the CT findings, and the difference between the Hemalock clip and the TS stapler was measured. As we can see in the diagram, on the left side first, we can see we have applied the endo-TS stapler. In that we were able to get the IVC cuff, while on the right side there is a Hemalock clip. We were not able to get an additional any IVC cuff. So during our study, we found that in the endo-TS stapler, we were able to get the IVC cuff along with the whole of the length of the right vein. While there was a loss of approx 4 mm, we saw 4 mm loss with the use of the Hemalock clip. And in the table, we have mentioned the mean renal vein length on the CT angio in the patients who went with the endo-TS stapler and the Hemalock clip. There was the renal vein was comparative in the both group. And on the right side on the images, we can see we were able to take the IVC cuff on the right renal vein with the endo stapler. That has been image shown on the during the time of the benching. So we conclude that using the endo-TS stapler, we can harvest the maximum length of the right renal vein along with the IVC cuff. The IVC cuff provide good anastomosis in the recipient, and there was no compromise in the warm ischemia time between the endo-TS stapler and the IVC Hemalock clip.
How was the decision taken on which patient to use Hemalock and which patient to use stapler?
So during the initial period, we were using this Hemalock clip. Now we have changed our method of, nowadays we are using, for last 5 years, we are using endo-TS stapler only.
So these are two consecutive groups of patients. In one
Yes.
group,
Yes, sir.
consecutively Hemalock was used.
Yeah.
And the other group in the later years,
Yeah.
you used only
Yes, sir.
stapler.
Retrospectively, we measured the CT length, and then on the benching, we were taking the length of all the patients from the Hemalock clip.
It was not a randomized trial.
No, sir, not a randomized.
But was there any specific length during the CT scan study? This much of length we should get minimum. That's why we'll go for the endo stapler, or we'll go for the.
No, sir. As such, we have not divided any patients. We try to get endo-TS stapler at present.
And did you find at any point of time some difficulty firing the endo stapler?
No, sir.
What is the cost difference?
Sorry?
Cost difference?
Difference in cost.
Costing.
Sir, I have to check it.
Did you analyze at any point of time?
No, sir. I'm not analyzing.
Was there any statistical significance? You mentioned the absolute figures in the table, but there was no p-value in that in terms of length of renal vein stump.
I have not done that.
Any questions from the audience? Yes.
Which type of endo stapler you have been using, curved or straight one?
So straight one we are using.
So straight one
30.
will reduce the diameter of the IVC also. If you are taking the IVC cuff along with the renal vein, then it will reduce the IVC diameter. For some turbulence at that point, is it in your
But
series?
most of the in all the cases we are able to take that IVC curve, sir.
No. By the I mean to say that by using the straight stapler, then you have to, if you want to remove the IVC cuff along with it, then you have to divide something, some of the diameter of the IVC also. While from the circular stapler, it can be minimized, but from the straight, the lumen will be reduced of IVC. So for that point of view, you have any studied or not?
No, we have not studied that point.
Okay, I think we'll have to stop here. Time is over.
Okay, thank you.
Thank you, sir.
Sir, next one.
The next speaker is Dr. Devanshu. Use of proctored and preceptorship model to initiate AV fistula surgery program, initial experience and technical learnings.
Good afternoon, everyone. I'll be presenting our experience with initiating the arteriovenous fistula surgery program using the proctored preceptorship model at our center and our technical learnings. Arteriovenous fistula surgery is an advanced microsurgical transplant associated procedure, and there is no consensus on the optimal anastomotic technique in AVF surgery. Proctored preceptorship model, in which the trainee first assists a mentor, followed by the mentor assisting the trainee, and then the trainee individually performing the procedure, has been shown to overcome the learning curve of new procedures. So our aim was to evaluate the perioperative outcomes of AVF surgery program established by this model at our center, and to detail our technical learnings from the initial 50 AVF surgeries. The primary objective was the patency rate, defined as the clinically thrill present on first postoperative day. Secondary objectives included operative time, anastomotic time, postoperative complications, re-exploration rate, maturation rate defined as AV fistula, which was suitable for hemodialysis at 1 month postoperatively, and follow-up patency rate for those patients who completed 6 months. Technical learning points of the first 50 surgeries were detailed, and 2 surgeons performed the procedures. We used the extended arteriotomy technique for the surgery. The study duration was January to December 2021, and a total of 47 patients underwent 50 AV fistula surgeries, out of which 37 were radiocephalic and 13 were brachiocephalic AV fistulas, and 42 patients were male. Our mean anastomotic time was 20 minutes. The patency rate was 42 out of 47 patients, that is 89%, and 85% of the patients went on to have a matured AV fistula at 1 month follow-up. 20 patients completed 6 months of follow-up, and out of them, only 1 failed, so that was 95% follow-up patency rate. Our technical learnings included a proper patient selection and adequate preoperative arm preparation using softball exercises and avoidance of IV injections and cannulae in the selected arm before surgery, use of magnification loops to aid in the anastomosis, putting a feeding tube in the vein to ensure a proper orientation of the vein during spatulation. We first put both corner stitches followed by the posterior layer, then the anterior layer to make sure that the corners are secure. We use arterial vascular slings to stop the bleeding from the artery, and that also brings the artery more superficial into the incision and helps in the anastomosis. Use an extended arteriotomy technique in which around a 1 centimeter arteriotomy and extended venotomy is made, which reduces the arteriovenous angle to less than 30 degrees. And this reduces the risk of juxta-anastomotic stenosis. So this study adds that proctored preceptorship model helps in establishing an AVF program at a new center. Extended arteriotomy technique as shown in this figure, in which in the first figure shows a completed anastomosis, and the second figure we see the vein on top and artery on the bottom with the angle between them around 30 degrees, which reduces the risk of juxta-anastomotic stenosis because of reduction in the turbulence of blood flow. And our technical learning points help in attaining a high patency rate in AV fistula surgery. Thank you.
What is proctored whatever you are calling it? Proctored preceptorship model. What is this?
So this is a model in which first one is an experienced surgeon and one is a trainee surgeon. So the trainee surgeon first assists the experienced surgeon for a few cases. Then the experienced surgeon assists the training surgeon for a few cases. And then
Out of these 50 cases, how many were done first by the experienced surgeon and how many later on by the trainee?
initial 5 to 10 cases were done by the experienced surgeon and the training surgeon was assisting.
And how can you say that this is superior to conventional methods? Have you compared the conventional?
We have
AV
not
system?
compared it to other methods, but we have previously performed laparoscopic donor nephrectomy program initiation using this model, and we have published a paper on it. So we have evaluated this model previously, and we use the same model to initiate this surgery program at a different center.
No, that's okay. Your conclusions are slightly fallacious in terms of your content. You cannot say that this program is superior to other programs because you have simply not compared the two.
Yeah, we have not compared it to other models. They're saying that this model helps
Same
in-
applies to your second conclusion regarding the length of arteriotomy. If you had a group in which the arteriotomy length was smaller and one this group and you had compared the two and shown the superiority, your conclusion would have made sense. Yes, any question?
In the house? What are the time difference if the experience is doing and if the experience is the assisting?
So we have not specifically evaluated, but the initial cases operative time was around 90 minutes. And now by the end of it, we are able to do it around 60 minutes total operative time.
If there are no more questions, you can move. Thank you.
Thank you.
Next paper is by Dr. Premjit Singh on robot-assisted laparoscopic appendiceal onlay flap ureteroplasty for complex right upper ureteric stricture.
Good evening, everyone. The topic of my discussion is robot-assisted laparoscopic appendiceal onlay flap ureteroplasty for complex right upper ureteric stricture, a report of 2 cases. Management of complex ureteric strictures requires judicious decision-making based upon the site, length, and etiology of the stricture. The longer segment ureteric stricture need advanced surgical techniques, and the procedures have their own set of complications. Using appendix as onlay flap reconstruction has lesser metabolic complications, lesser chances of restricture, and moreover, it is a vestigial organ. And the index patient 1, a 50-year-old male, presented with complaint of episodic right flank pain since the last 1 year, and CT urography showed an upper ureteric stone with gross hydroretronephrosis and narrowing of a long segment of right upper ureter with delayed excision of contrast. Retrograde pylography and ureteroscopy showed around 5 centimeter long right upper ureteric stricture, and the patient underwent robot-assisted laparoscopic ureterolithotomy with appendiceal onlay flap ureteroplasty. The second patient was a 41-year-old lady, a known case of right upper ureteric stricture following iatrogenic injury following URSL done outside, came with PCN in situ. Combined antegrade and retrograde pylourethrography showed around 5 centimeter upper ureteric stricture. She also underwent a robot-assisted augmented anastomotic appendiceal onlay flap ureteroplasty. Now, the operative procedure, these were the ports as shown in the diagram. Da Vinci Xi system were used. Appendix was divided after transfixation, keeping the mesoappendix intact. It was detubularized along the anti-mesenteric border. Both ends of the ureter were sutured, and then the appendix was sutured as an augmented onlay flap. Right degestant was removed after 4 weeks, and retrograde pylograph showed no contrast leak and unobstructed drainage. There was no holdup. Appendix can be used as either an interposition graft or an onlay flap. In the interposition, the adjacent ureter needs to be well vascularized, and there might be increased chances of stricture formation due to the narrow lumen of the appendix. There is increased risk of failure in patients with radiation-induced strictures using the interposition technique. Dash et al. In a series of 10 cases with a median age of 2.5 years used appendix as a substitute. The median follow-up was 16 months, and 9 patients were without any obstruction at the last follow-up. Take-home message: using appendix instead of ileum leads to many advantages like decreasing the risk of acidosis, no risk of anastomotic bowel stricture or leak. If it fails, then we can go ahead with an ileal transposition and auto transplantation can be done. There are certain disadvantages such as appendix may be short for length for repair in some patients, and some patients might have already undergone an appendectomy. In those patients, appendix might not be available. Thank you.
In your first patient, there was no parenchyma what was seen on CT scan. So did you get all DTP scan?
Sir, the patient was actually a CKD patient, so DTPA was done before planning the surgery.
What was the GFR like?
Sir, GFR for that kidney was 15 ml. Yes, sir. Sir, a long segment stricture and long segment.
Why do you call it complex?
Like these were 5 centimeter. The strictures which cannot be We cannot repair it by end-to-end anastomotic uretroplasty. Those strictures we identified as complex.
Now, where is this definition given?
The definition is not as such because the data on this is not much available.
In the second case, you did an anti-grade study. So how
Yes.
did you fill up the contrast in the kidney? There was
So
a PCN tube,
PCN tube was placed.
but we don't see the PCN tube anywhere.
Sir, it was placed, and for that only antigrade and retrograde, both the studies was performed.
So, okay. Did you assess it prior how much length you could get from the appendix before surgery?
No, sir, actually intraoperatively only the decision was taken that the appendix will be used for the
If you
graft.
feel that it is short, then what do you go for?
Then, sir, if the appendix length was not available, then we would go ahead with an ideal interposition in those patients.
At any point of time, did you notice if whatever you have planned by opening up the appendix and you fall short of that, then you have to interpose with ileum or something like
Sir,
that?
before only we identified the stricture length using the ureteric catheter and the appendix length, then only we went ahead with the procedure.
Anything from house? Please.
What was the cause of stricture in these patients?
The first patient was stone was the cause, and the second patient, in the first patient probably a passed out stone, and there was also a stone. In second patient, she underwent URSL outside, following which she had an injury. It was an iatrogenic stricture.
Whether you have biopsied the ureteric stricture segment or not in these cases prior to the
No,
augmentation?
we did not do any biopsy.
No biopsy done.
You take the appendix with the blood supply.
Yes, sir, the mesoappendix intact.
So in suppose it is low down in the right iliac fossa and the stricture is higher up and you cannot reach there, then what do you do?
That's why intraoperatively decision was taken based upon the length of the medial appendix and the length of the appendix and the length of the stricture. Thank you.
Thank you, doctor. Sir.
Now we have Amit Bansal presenting a novel 3-point technique of buccal mucosal graft urethroplasty. So can we have the interim result?
Good afternoon, sir. Sir, I want all my seniors to have a look at this picture. This is often the picture of the recurrence following buccal mucosal dorsi-only graft urethroplasty. Now, this is the annular stricture which we often find at the anastomotic ends. Now, the points to think about is that we suture the end towards the, while doing the dorsal only graft, we make a urethrotomy and we pass that urethrotomy well into the healthy portion of the urethra. And we fix the graft over there. So we are fixing those ends to a healthy urethra. Now we often get recurrences at those particular ends. So this was the doubt. Why was this happening? So we went on to search the literature. We went through many papers. We found a paper by Dr. Barbagli and the classical paper by Dr. Kulkarni describing his technique. Everywhere it was mentioned that the recurrences happen, and most of the recurrences are annular recurrences at the anastomotic side, but nowhere it was mentioned why they were happening. So what we thought was, if we go back to our textbooks in the Brandeis urethral surgery, Dr. Barbagli describes in his book, in that particular chapter written by him, trimming of the graft into an elliptical shape. Later on, we have studied that often the graft which is taken out is more of rectangular in shape, but we end up fixing that rectangular piece of graft into an elliptical urethrotomy. So what we thought was probably crumpling of those particular rectangular ends into an elliptical urethrotomy was causing some sort of ischemia, leading to fibrosis and hence leading to anastomotic site annular strictures. This was our idea. We set out to test that. We sought the ethical board approval. We were granted permission only to do a pilot study for 5 patients with a follow-up of 2 years. So if we have a look at this image, now figure A is what a typical urethrotomy end looks like. It is elliptical. What we did was, if we can have a look at those arrows, just to show the orientation with the graft, we fixed the graft over the corpora, splayed out. And we brought the urethrotomy ends in a wider configurations to make that urethrotomy more rounded, to give it a less of angular appearance. We tried to make it more round, and we test out, this is the hypothesis right now. We stepped out to see whether this is going to reduce the annular stricture rates. This was the idea. So we were granted permission, and as per our initial protocol with the ethical board, 2 years follow-up is mandatory. Till now, I'm presenting the interim results with you. So far we have 5 patients with us. 1 patient is a redo case. 1 patient is post URP. 2 patients had lichen sclerosis, and 1 was having first surgery.
I think
As
we'll
we
have to
can
stop
see-
now. The time is up. This is a prize session.
You have not shown the endoscopic view after this, your technique. Can we have a view of that endoscopic view after your technique?
No, sir. Endoscopy was needed only if the patient had any recurrence or any. So far, till in 6 months, none of the patients have reported any worsening in LUTS, or using the Jackson criteria, the Euroflowmetry score has not gone down by 10, or there is no deterioration in the PROM scoring, sir.
See, if you analyze, there is nothing wrong with your graft which goes to the recurrence. Recurrence is because the proximal and the distal limit of identification of the urethra is wrong and deceptive. You think the portion you are cutting is healthy, but actually it is not healthy. That is why the stricture develops. So you have to cut 5 millimeter more. So that identification on the table is very crucial.
Dr. Amit, any urethrotomy will land up with a elliptical incision.
Yes, sir.
If you stretch it, then it looks like round, that's a different issue. But if you want to really make it round, both the tip ends, then you have to excise some part of the urethra, then only you can do.
Sir, what we
only just pulling out, it will be a false sense of, making it round. And how do you do that?
Sir, the sutures that we take, one suture from urethrotomy, from corporal graft, and then we tie it later.
What were the difference in the results between using this technique and your earlier conventional techniques?
Sir, earlier conventional technique, we have a long follow-up, but it is known that the urethral stricture recurrences end up happening. Most of the recurrences happen in the first 2 years. Till now, with keeping COVID in mind, we have only 6 months of data as of now. So we just had, and ethical board gave us permission with this hypothesis. They gave us permission only to test this method in 5 patients and submit 1 year of data to them. So we are in the process of that. 6 months data was available with analysis, and that is why what I came to this.
Isn't it too premature to present this data now? Only 6 months.
So my idea was just to share this idea with
I get
people
your
who
point. You
are doing this
presenting
day in and day out and have an expert opinion, so that I can improve my study, sir.
Yes, but ultimately the final say would be the outcomes which you have.
Thank you, Dr. Amit. Thank you.
Yeah. And then the next speaker is Dr. Sunny Goel, recurrent vesico-acetobulocutaneous fistula, host from Christmas.
Good afternoon. I'm Dr. Sunny Goel. I am presenting my case report on recurrent vesico-acetobulocutaneous fistula, a ghost from Christmas past. Our unique patient was a 40-year-old policeman who underwent 2 operative procedures following a road traffic accident in June 2006. The first operative procedure was exploratory laparotomy and cystostomy, followed by primary perineal anastomotic uteroplasty, which unfortunately failed. He presented to us at Medanta in 2007, and he was diagnosed as post-traumatic neurogenic bladder upper motor neuron type, partial corticoinal lesion with left foot drop, stable fracture pelvis involving left acetabulum with pubic diastasis, and also left pseudo-diverticular bladder secondary to prior unrepaired extraperitoneal bladder injury with erectile dysfunction. We treated him initially with anticholinergics and performed a redo anastomotic uteroplasty in March 2007. And after healing 4 months later, he underwent left total hip replacement in July 2007. Later on, due to severe irritative LUTs, we performed a urodynamic study which showed declusor hyperreflexia and low compliant bladder, for which he received intravesical botulinum toxin twice, after which he defaulted for the 3rd dose. After defaulting, he presented with a fluid drainage from heel scar on his left hip in Feb 2009. His fluid creatinine was high, and CT cystogram confirmed left vesico-acetabular cutaneous fistula. We performed a patch ileal cystoplasty considering his defaulted Botox status in August 2009, and due to presence of dense adhesions with near frozen pelvis, it precluded fistula excision. He was trained to do CIC regularly, and he underwent revision of his left hip replacement after fistula site had healed. After a decade, he has presented again with recurrence of left vesicoacetabular cutaneous fistula, having stopped performing CIC regularly. This time, MRI pelvis revealed the presence of fistula in the same site as the previous one. We performed a transvesical fistula excision with omental interposition in 2020. And results at 1 year follow-up, there is no recurrence of fistula and explantation of left hip prosthesis is planned. Most vesicoacetabular cutaneous fistula occur post-hip arthroplasty, either due to penetrating mechanical injury, chronic prostatic infection, or displacement of PMMA cement. In our case, in the first instance, defaulting on the buttocks probably caused high bladder pressure, which weakened the bladder pseudodiverticulum to give way. And the cystoplasty we performed with regular CIC decreased the bladder pressures and prevented the pseudodiverticulum from venting the pressure. And a decade later, CIC non-compliance probably gave the same scar site to give way. This concludes that it highlights the challenges in lower urinary tract rehabilitation following complex pelvic injury. It reiterates the need to repair large extraperitoneal bladder injuries, and it also exemplifies the need to impress upon the patient continued need for CIC in neurogenic bladders. Thank you.
Any question from house? How many in the literature vesicoacetabular cutaneous?
Sir, there are few cases. We could find around 12 cases, and most of them were after post-hip arthroplasty, as I suggested. In this case, we found different reasons for it to occur, and that too recur a decade later again.
So you could not, it was not possible to excise the tract?
So in the first setting, yes, it was not possible due to dense frozen pelvis. And in the second setting, we went through a modified Gibson incision, and we went through the augmented patch. We did the transvesical approach, and we could see the fistula from inside the bladder, and we excised it. I think.
Did you ever consider diversion in this patient, considering his lack of compliance with CIC, rather than performing repeated procedures on the bladder? Did you ever consider a diversion?
So in the first case or in the second case? So he was doing CIC continuously for 10 years. And for which maybe he felt that after 10 years, nothing would happen. Maybe, we can't say. And he was regular for 10 years, after which he defaulted.
He's talking about the diversion either before surgery.
Sir, before, when he presented to us in 2007, he already had a SPC done after failed anastomotic arthroplasty.
Anything beyond that, SPC? Upper tract diversion?
No, sir, we have not diverted.
Thank nothing more than. Okay, thank you.
Thank you, sir.
Thank you. Next presenter is Dr. Ankur Singhal. He will be speaking on congenital cutis laxa syndrome with bladder diverticulum.
Good evening, everyone. Myself, Dr. Rakesh Singh. I will be speaking on congenital cutis laxa syndrome with bladder diverticula, a report of 2 cases. Cutis laxa or elastolysis is a rare connective tissue disorder in which skin becomes inelastic and hangs loosely in folds. Cutis laxa, it may be inherited or acquired. The clinical presentation and the mode of inheritance show considerable heterogeneity. Patients develop a prematurely aged appearance. It is a heterogeneous group of congenital and rarely acquired disorders. It may be preceded by inflammatory rash or may develop spontaneously. The most striking clinical feature is loose and pendulous skin, sagging of cheeks. Disease is characterized by generalized reduction in amount and size of elastic fibers, fragmentation and disruption of their normal arrangement. We have 2 cases. In the first one, a case of 9-year-old male boy with congenital cutis laxa. The diagnosis was made on clinical assessment of typical skin features and associated internal organs. He was the first child of healthy parents. He was referred to us for his persistent voiding complaints. On abdominal ultrasonography and voiding cystourethrogram shows multiple diverticula. He was put on CIC, and thereafter he was asymptomatic. As in second case, a 15-year-old girl child presented with palpable edema, redundant papery thin skin, reduced elasticity and generalized abdominal distension. She was referred for skin abnormality and a palpable mass in lower abdomen with retention of urine. USG showed multiple bladder diverticula. The following figures, the first one showing the skin laxity with sagging of facial fold, and the patient second figure showing right inguinal hernia, and third one showing multiple bladder diverticula with varying sizes, predominantly in the right in the dome and the right anterior wall. Figure 4 showing ultrasonography showing bladder diverticula. Conclusion: patient with clinical feature of cutis laxa and lower tract symptom, they should be evaluated for bladder diverticula. They need multidisciplinary management.
What do you think is the association between the two?
Sir, it's a multi-organ system involvement with the first case presented with persistent voiding symptoms, and on investigation sonography showed multiple diverticula, and voiding cystourethrogram also showed diverticula, and patient was put on, and he was having recurrent UTIs as well. Thereafter we put the patient.
How did you rule out outlet obstruction?
What was the Euroflow report like?
So patient was having PVR, significant PVR.
So that again goes in favor of outlet obstruction. How did you rule it out? Did you do any genetic testing on these patients?
Sir, first patient, we advise him skin biopsy. On the second patient, skin biopsy was done, and on skin biopsy, cutis laxa was confirmed, sir.
What is autosomal recessive or dominant?
So we did not evaluate.
It is congenital or acquired?
Sir, it is congenital.
One is 9-year-old, another is 15-year-old.
Yes, 15 days old.
But you didn't ascertain whether it is dominant or acquired. Didn't do any genetic testing.
The second patient expired after 1 month, and the first patient lost follow-up.
So this cutis laxa can happen also after multiple myeloma. It can occur after gamma glomerulopathy. So did you rule out any other secondary causes?
Yes, sir. It can be acquired.
Acquired. So what are the other causes did you rule out?
Pseudoxanthosis,
Right.
or
But the first and foremost is in a urology, at least you should have done a uroflowmetry to rule out an outflow obstruction like Dr. Triwadi said. Another thing, is he may be having diverticula in the bowel also, which is more common than in the bladder. So what, any dye study, right, was ruling out a bowel diverticulum?
sir, he did not have any GIT symptom. Therefore, we did not. He did not went to gastroenterologist.
Which type is more serious in nature, whether it is recessive or it is dominant?
Sir, dominant.
Okay.
Just a
Anything
question
from
from
our-
Okay, thank you.
Thank you, sir.
Next. Sir.
The next speaker, Dr. Sumit, will be presenting varied presentation of Jenner syndrome, report of 3 cases.
Good afternoon, sir. Topic for my presentation is varied presentations of Jenner syndrome, a report of 3 cases. Jenner syndrome, it is considered the male counterpart of Mayer-Rokitansky-Kuster-Hauser syndrome. It is a triad of unilateral renal agenesis, ipsilateral seminal vesicle cyst, and ipsilateral ejaculatory duct obstruction. Patients have varied presentations, with some presenting with flank pain, with features of epididymitis, prostatitis, or lower urinary tract symptoms, or non-specific perineal pain. Due to the diagnostic dilemma here, the patients are often misdiagnosed or remain undiagnosed, and the diagnosis is usually established in such cases by TRUS or an MRI. The treatment is only required if the patient are symptomatic. Herein we present 3 cases. The first patient was a 19-year male who presented with lower urinary tract symptoms, both storage and voiding, with recurrent episodes of urinary retention and constipation. DRE revealed a cystic swelling where the superior margin was not reached and the prostate was not separately palpable. On evaluation, there was a large cyst in the pelvis, about 14 by 12 by 10 centimeter, which was compressing the bladder, pushing the bladder anteriorly and compressing the rectum posterolaterally. And the right kidney was absent. patient underwent laparoscopic cyst aspiration with deroofing and omental packing, and at present is asymptomatic. Our second patient was a 16-year male who presented with intermittent scrotal pain for 1 year. Patient was evaluated and found to have left-sided absent kidney with a cyst in the pelvis about 5 by 4 centimeter. Patient was managed conservatively and he is on regular follow-up. Our third patient was a 25-year male who presented with recurrent left flank pain. On evaluation was found to have an absent right kidney with a cyst in the pelvis on the right side about 6 by 4 centimeter, which was crossing the midline and impinging on the left vesico-ureteric junction with consequent left hydroureteronephrosis. Patient underwent transurethral resection of ejaculatory duct with cyst decompression and is presently asymptomatic. To conclude, as we have seen from our 3 cases, Zinner syndrome can present with varied presentation. Patients may present with LUTs with features relating to obstruction of bladder and rectum. Patient may present with flank pain, or there may be intermittent scrotal pain. Zinner syndrome should be suspected in young patients with renal agenesis and non-specific pelvic symptoms, and early intervention should be done in such patients to prevent the irreversible sequelae from chronic compression, which has already occurred in an already jeopardized genitourinary tract. Thank you.
You did laparoscopically deroofing?
Sir, laparoscopic cyst aspiration was done first and then deroofing. Actually, the cyst was densely adhered with the bladder and the vas. So the complete wall couldn't be taken out. The vesiculectomy was not possible. So the cyst was aspirated and then the omental packing was done, sir. And the vas was also taken together. Biopsy specimen it revealed a seminal vesical cyst with adherent vas.
In the first case and the second case, what was the evidence of ejaculatory duct obstruction? How did you confirm that?
Sir, it is interpreted that on the basis of MRI, if there is a one-sided renal agenesis with seminal vesical dilatation, seminal vesical cyst, then it is taken that the ejaculatory duct might be obstructed.
Oh, in the history, was the patient ejaculating?
Sir, both were young male who haven't were evaluated for infertility. Just as part of workup, semen analysis was done for both the patients, which revealed azoospermia, sir.
No, unless you document that, you cannot label this as a Zinner syndrome based on assumption. Either you do a seminal vesiculography, inject dye into the vas and demonstrate that there is block in the ejaculatory duct, or show that the semen doesn't contain fructose.
So, semen analysis was done. Fructose was present in the semen analysis, but there was azoospermia in both the patients, sir.
So what? So if the fructose was present, then you cannot label it as a Zinner syndrome at all.
Sir, the opposite side ejaculatory duct is still patent, sir.
But for this side, you do SVG.
Yes, a seminal vesiculography was not done, sir.
You should also look. Sorry.
In the first case, could have been transrectal guided aspiration on some sort of,
So the cyst was very large and it was causing features because of obstruction, sir. There was recurrent episodes of urinary retention. Patient was having constipation since long time. So the laparoscopic approach was chosen, sir. That would be the best for the patient. Such a large cyst in the pelvis, that's why, sir.
And one patient is under observation.
The second patient is under observation, sir, who presented with intermittent scrotal pain. He's a 19-year male, sir. We have just we have just kept him on follow-up and asked him to do a semen analysis every 6 months so that when he is about to conceive, sir, if there are any fertility issues, then that should be taken care of prior, sir.
Anything from the house? Thank you.
Thank you, sir.
We come to now the next presentation by Dr. Siddharth Jain. He's going to tell us about inferior vena cava and iliofemoral thrombosis with hypertrophic collateral circulation causing a uteral compression. Siddharth, please.
I'm sorry, sir, Siddharth. I will be presenting. My name is Dr. Shritosh. Very good afternoon to all the respected esteemed judges and the delegates. Today I'll be presenting a case report. This case is regarding inferior vena cava and iliofemoral thrombosis with hypertrophic collateral circulation causing urethral compression. And this is a case report of a single case. Now, we know that deep venous thrombosis of inferior vena cava may be secondary to a lot of causes, mainly mostly due to intra-abdominal cause, maybe a carcinoma. And this DVT of the IVC, when simultaneously presenting with an iliofemoral thrombosis, is seen in less than 1% of all the cases. Now, these patients, because they do have problems related to this thrombosis, such as lower limb swelling, they require anticoagulation for a long period of time. And now there is a problem that the ureter is in relation to the gonadal veins, and when these gonadal veins become thrombosed, or when there is an extensive collateral circulation which causes compression of this ureter, the patient might end up in hydroureter nephrosis and result in acute kidney injury. This case is regarding a 19-year-old male who presented actually in medicine OPD in our hospital first with left lower limb swelling. On further evaluation on an ultrasonography, he was found to have left mild hydronephrosis without any other definite calculus. And there was also thrombus in the common iliac vein and distal part of the IVC with multiple large vascular collaterals on the left side. The patient was referred to hematology first, evaluated for varying causes, but the cause could not be established. Then for this mild left hydronephrosis, he was referred in neurology. We did a CT scan, which revealed that there was extensive venous thrombosis of the pelvic veins, infrarenal IVC, and the left renal vein, with compression of the left proximal ureter on the left side with surrounding large collaterals, and this was causing this upstream. I'm sorry, this is not moderate. This is mild hydroureter nephrosis. He was not in any AKI. His creatinine was normal, 0.89. This was the CT image showing hydronephrosis on the left side. We did a renal dynamic scan, which showed that this left kidney was the good functioning kidney. He was not started on any treatment from our side. He was only on anticoagulation therapy from hematology. And over a period of around 3 to 4 months, his symptoms improved, the hydronephrosis resolved, and his lower limb swelling also reduced. So this case report, although we have not done anything actively, this reports that there are varying options to treat these kind of patients. A simple anticoagulation might help when the patient is not having any acute kidney injury. Or in patients who have moderate to gross hydronephrosis, ureteral stenting may be another option for a longer period of time. Thank you.
So what was the cause of this massive thrombosis in the IVC in the common area?
The cause could not be established till now, sir. He has been evaluated for varying causes from hematology, but we don't have a cause.
The thrombosis of the renal vein also.
Yes, sir. The left renal vein was also involved.
And you did not send him either.
Sir?
Did you send him?
We did not stent him, sir. Actually, we were thinking in that terms, but again, because of the lockdown which happened the last time, we could not follow. And he was on.
Could you elaborate what hematological workup was done to rule out cause of thrombosis?
Sir, he was evaluated for paroxysmal nocturnal hemoglobinuria. He was also evaluated for factor 5 latent deficiency. These are the two I know of right now. He was for.
So it did not reflect in your presentation one.
Yes, sir.
So that because I was more interested to know the cause, as
Yes,
everyone is. Second, we had similar case just to share, although it has no relevance, where it was hyperhomocystinemia. So all the workup was negative except for homocystinuria, which was high. And that patient was treated with pyridoxine, and patient had a good outcome along with anticoagulation.
Thank you.
So we are really not sure what happened in this patient.
The cause we don't know, but from our perspective, from the point of hydronephrosis, and if the patient would have had an acute kidney injury, my goal was just to stress upon the varying options that we might have as a urologist on an OPD basis. That's
all right.
Thank you, sir. Thank you.
The next presentation is by Dr. Akshay, and this is titled as the first ever case report of a vertical penile fracture with concomitant urethral injury. Yes, Dr. Akshay.
A very good afternoon. I want to present a first ever case of vertical penile fracture, and with that too with a urethral injury. So the case was the patient was mid-40s. He presented to us with a sudden swelling and loss of erection after a sexual activity. And he was taken up for emergency surgery because it's surgical emergency. And to our surprise, we noted that there were vertical type of tears. They were noted in the right side corpora as well as the urethra. And see, this was the clinical presentation, which is usual only. And these were the tears. This was the tear of the corpora, and this was the urethral tear. So both the urethra was repaired in 2 layers, mucosa and the other spongiosum separately, and the corporal tear was repeated in 1 layer. And when we searched the literature and we saw all PubMed articles, which actually describe the nature, they're all most transverse type of fractures, and we would like to propose the possibility of compression injury, which would have happened and cause this vertical type of fracture. And vertical, and also we would like to hypothesize that urethral involvement would be more likelihood due to fixity of the urethra to the corpora. But due to the rarity of this entity, it raises questions regarding the long-term outcome. That is, patient will have either erectile problems or any curvatures, or so further studies will be required. Yes.
So what was the mechanism of fracture?
Sir, actually the history, patient did not give very clear history, but we think that it might have been a very compression type of injury, and patient would have against the surface or the partner's body. That's what.
How did you repair the urethra?
Sir, in 2 layers, mucosa separately by 50.
No, vertically or horizontally?
Vertically only, like same.
So both suture were overlapping.
Yes. Sir. So
you could have repaired transverse urethra.
Yes.
So is there any difference between the transverse fracture and vertical fracture clinically?
Clinically, sir, presentations were same.
Which one the clinician can miss easily?
Which one?
Although there is a fracture,
Which can-
transverse or vertical?
So transverse is obviously till now whatever we have encountered was transverse only. This was the first one which we was vertical.
What are the signs clinically we call in a fracture penis? Clinical
Sites either proximal or distal.
There are specific names, clinical signs.
Signs, eggplant deformities, eggplant deformities, and ecchymosis, eggplant deformities and all.
Ecchymosis lead to eggplant.
Yes, sir.
So, is there any presentation in a vertical and in a transverse? Which is more serious? Which is more serious usually? Vertical or transverse?
Sir, we don't have any data for. Whatever data we have was more transverse only. So we think it might have. This might lead to curvatures later on. We don't
There are
know.
also data for vertical fracture, but you have a vertical fracture along with the urethral injury. So
Yes.
that is the rarity. I could
Yes,
get
sir.
it. But did you search the literature, which is more serious in nature, the transverse or?
Sir.
Thank you.
Thank you.
Next presenter is Dr. Rohit Ranjan.
Good afternoon, everyone. I'm Dr. Rohit Ranjan from AIIMS Rishikesh. Benign prostatic enlargement is one of the most common problems of aging males, and it produces a variety of low-tech symptoms which can even restrict day-to-day activities. TURP is considered as gold standard surgical treatment, but in final histopathological report, it is not rare to see carcinoma prostate, and further management and prognosis depend on early diagnosis and initiation of treatment. But the tissue artifacts due to cautery make it difficult for the pathologist to detect early case or small foci of carcinoma prostate. And thus, we conducted this study to critically evaluate the artifacts of the resected prostatic tissue in monopolar and bipolar TURP. So it was a randomized controlled trial, and 60 subjects were enrolled and randomized into 2 groups, monopolar group and bipolar group. And histopathological specimen was examined for the depth of stromal artifact and degree of gallbladder artifact, and categorized into mild, moderate, and severe. Both the groups were comparable, and depth of the stromal artifact in monopolar group was 407 micron, And in bipolar group, it was 170 micron. Gallon artifact was more in monopolar group, and moderate and severe grade of artifact was seen in 73% of the cases, whereas in bipolar group, it was only 36%. 2 patients showed foci of adenocarcinoma prostate in bipolar group, and no patients in monopolar group. So this was, we can see the depth of the stromal artifact here. And in this picture, we can see the glandular artifacts measurement. So monopolar TURP is already established gold standard procedure against which all other modalities has been compared. And bipolar TURP is now increasingly done procedure for benign prostate enlargement with an added advantage to reduce its most prominent shortcomings like bleeding or dilutional hyponatremia. But there is minimal concern about the histopathological artifacts. In this study, depth of stromal artifact and glandular artifact is much higher in monopolar group, which is statistically significant. And it was consistent with the previous studies, which showed that bipolar TURP generates less significantly heat and histopathological evidence is less thermal damage in compared to the monopolar TURP. So to conclude, lesser artifacts with bipolar TURP will help to diagnose early cases or small foci of prostatic malignancy as early as in the stage of carcinoma in situ. And pathologists will not miss any foci to examine. And this will also help to make less scar on the resected prostatic tissue and less risk of bladder neck contracture later on. Thank you.
So what you are proposing is that monopolar TRP should be replaced by bipolar TRP.
Yeah, there are comparable results with lesser side effect or lesser complications with the bipolar group. So along with the other advantage, we also have one more advantage with the lesser tissue artifacts, which can change the management further if there is a carcinoma prostate.
No, that's okay. I mean, these are histological changes and they have been well proven in the earlier studies as well. But what is the clinical implication? In your study, in one of the groups, you found 2 patients, but I think that is too short a number to comment on anything. That does not have any importance per se.
Maybe
so unless you have a larger number of patients followed up for a longer period of time, and then we'll detect the cases which were missed because of monopolar TURP in subsequent follow-up. So then there can be a meaningful outcome.
And what additional treatment you offered to those patients in which you found that microscopic foci of adenocarcinoma?
We just kept them out for the surveillance.
So then
they opted for such treatments.
I mean, I can understand if the same thing was done in a TURBT specimen, where the artifacts are probably more significant as compared to, say, TURP.
Yes.
One major problem is that whether histopathologist is doing biopsy for all the chips or not, or if he is doing only for selected few chips and then giving his report. Because this is not possible if there are more than 1,000 chips and he is doing biopsy for every chip. This is not all the time possible. So whatever practically possible, whenever we find that there is some hard tissue, some doubtful, we send separate biopsy for that.
So, but for here, for the study purpose, they examine each and every prosthetic chip.
Yeah.
Any questions from the audience?
So again, I have a problem when you say randomized trial, because you did not show your sample size calculation, your primary objective, right? And secondly, your conclusions are too strong that it will help in detecting of prostate cancer, where it was never your primary objective. Your conclusion could have been only that bipolar causes less cautery artifact. That's it. You cannot conclude beyond it. So these 2 comments, just be careful when you send it for publication.
Yes, sir. So there were so many components of this study, sir. This was the one of the part for that, sir. Yes, sir.
Okay, thank you.
Okay, thank you.
Thank you, sir.
And Dr. Yajvendra Pratap Singh Rana. Dr. Rana, are you there? I think he's not there.
Not there. Why is this Rana?
So it's over.
Next me.
Okay.
Okay.
With that, we come to the end of the session. Thank you.
Thank you. Thank you.
So this brings us to the end of this prestigious session, CMC Best Poster Session 2. May I request Professor Apul Goel, sir, to please come on the dais and present memento to the dignitaries first. Thank you, sir.
पता ही नहीं मिल रहा।
कहाँ मिल रहे हैं? बाकी तो अपना हुआ उससे ले लो जाके अपना
अच्छा
सेक्रेटरीट से। भैया अपने फोटो खींचो आप, चलो प्लीज।
ये तो नकली है ना, ये नकली है। इंटरनेशनल स्पीकर से छीन लिया।
So now I'd like to request Professor Apul Goel sir to please come on the dais and start the next session. Thank you, sir.
Good evening. I'll welcome you all, and I'll invite the speakers as well as the experts. This session is the best articles review session. We have 1 hour and we have 5 presentations. It's not a journal club, and it's not a Euroscan that we read in the Indian Journal of Urology. The intention is that we have picked some good articles published this year in 2021, and we have kept we have tried to pick up articles from some malignancy articles, certain BPH and stricture urethra articles, to keep it, a mixed type of presentations. So I'll invite Dr. Ankur Mittal, who's heading the Department of All India Institute, Rishikesh. Dr. Gautam Chaudhary, again from All India Institute, Jodhpur. Kamaljeet Singh, who's from All India Institute, Bhatinda, but because of some personal reason, he couldn't join. So I'll be presenting on his behalf. So we have that presentation as well. Dr. Somendra Bansal, he's from SMS Jaipur. And Dr. Y.M. Prashant from Safdarjung Hospital. So, and then we have 5 experts. Dr. Brisbanu Nayak from All India Institute, New Delhi. I think the experts can join us here. Dr. Sameer Trivedi from BHU Varanasi. Dr. Ravi Mohan from PGI Chandigarh. And Dr. Ishwar Dayal from RML Institute, Lucknow. So Dr. Siddharth has done the homework. He has chosen all these articles. So we have we'll have a 7-minute presentation and about 2 minutes of expert commentary. And although the audience is very less, but yes, of course, we have kept about 10 minutes for interaction. We can have questions. I'll invite Ankur first. Ankur.
Can you please make it full screen? Yes. So good afternoon, everyone. Greetings from Rishikesh. Thank you, Northern UCI, for this opportunity. So the article which we are discussing is a systematic review and meta-analysis of adjuncts to minimally invasive treatment of urethral stricture disease in men. So this was published in European Urology 2021, and from it's Dr. Chris Chappell and group from Sheffield, UK. So as we all know, stricture disease has an incidence of 0.6% of male population. Anterior is the most common frequently affected part. Regardless of etiology, the pathological finding is ischemic fibrosis, and the management of these disease depends upon the site, length, etiology, and whether it is primary or recurrent. The long-term success rate in this article by the authors of initial DVIU, as we are talking about minimally invasive treatment, is 32%. And the success they have suggested it decreases with repeated treatment. The objective of this review was to assess the efficacy and safety of adjuncts to minimally invasive treatment of urethral stricture disease. So if we talk about the evidence acquisition, it is, they have followed the, it was registered in Prospero, definitely yes, PICO followed, and the studies were mainly RCTs and non-randomized control studies with some retrospective and prospective studies too. The database which they have searched as per PRISMA guidelines was PubMed and Cochrane Library, and the studies published between January 1, 1990 to November 22, 2020. So 26 studies they were included, 13 were RCT and 13 were non-randomized studies, 972 participants in adjunct group and 581 in control group. Follow-up was 3 to 47 months. And 13 adjuncts they were identified in this review, which were used as adjunct to minimally invasive treatment, that is DVIU. So these are the studies with the details, and good to see. And when I reviewed that, 4 studies are from India in these studies, and 3 studies are from PGI and 1 from AIIMS. So the average length of stricture ranged between 1 to 4 centimeter, which they have taken care of. And these were the adjuncts which were reviewed, like intralesional injections were used, in which triamcinolone, prednisolone, mitomycin C, combination of triamcinolone, mitomycin, hyaluronidase, N-acetylcysteine, and autologous PRPs. Intraluminal instillation of mitomycin, hyaluronic acid, captopril, and brachy. Application while lubricated catheters with using triamcinolone. Application while coated balloons, which was paclitaxel chemotherapy coated. And antral preparations like tamoxifen and deflazacort, which were given for a period of tamoxifen for a period of around 6 months. And deflazacort, they have used 6 milligram BD for 2 weeks, then 6 milligram OD for next 2 weeks. I'm just specifying something new for me to learn from this review. Injection dose was between 5 and 320 milligram for triamcinolone and between 0.1 and 4 milligram for mitomycin. Specifically, I am mentioning this after review because these were 2 most commonly used agents. Definition of recurrence was quite varied. Recurrent symptoms, Qmax less than 10, less than 12, less than 15, stricture on RGU, inability to pass a catheter. The recurrence rate was 4.9 to 100% adjunct group and 15 to 81% in control group, while the reintervention rate was 7 to 70.6 in adjunct group and 44.1 to 61.9% in control group. So the most common, when we reviewed this, only 4 studies have specified complications, only 4, and which was with steroid, with captopril, with oral tamoxifen. Complication in the control arms were not reported. So when we see the forest plot comparing the recurrence failure rate between adjunct and control group, we see that any form of adjunct was associated with a lower rate of urethral stricture disease recurrence as compared to no adjunct. Mitomycin C was associated with the lowest rate of urethral stricture disease recurrence in this review. So if we come to discussion part, as most well studies adjuncts are local steroids and mitomycin C. Apart from these 14 adjuncts which have been specified, only mitomycin C and steroid have been studied in more than 1 RCT. Wide variation in recurrence rate in control group may be attributed to variability. So the article of efficacy of mitomycin C on DVIU have ultimately concluded that there is a reduction in recurrence as compared to DVIU alone. If you use mitomycin, the dose may be variable. An article on efficacy and safety of local steroids on urethral stricture disease, again a systematic review meta-analysis, have specified and concluded that the uses of steroid can prolong the time of recurrence, but did not reduce the recurrence rate after DVIU. Most accurate follow-up after stricture disease is that visualization by endoscopy. Both symptomatic improvement and flow rate can be sometimes misleading. As with normal detrusor contractility, the flow rate doesn't minimize till the caliber goes below 10 or 11 French. The recurrence rate of 12 months was around 40% with stricture less than 2 centimeter. 2 to 4 centimeter is 50% and more than 4 centimeter is 80%. Recurrence rate after second DVIU 50 to 70% at 12 months and 60 to 100% 48 months. And urethroplasty is recommended intervention for recurrent stricture disease. The principle of DVIU, what they have mentioned, to incise the scarred epithelium and allow the wound to heal via secondary intention. Catheter kept for 3 to 5 days means to splint the wound open while the reapplication occurs. And aim of adjunct is to modulate the wound healing process by reducing the collagen deposition. The principles on which it worked, they have specified the mode of drug delivery, the local concentration achievable, the reliability of the dose, mechanism of action, drug pharmacokinetics. Very dense strictures in which severe local ischemia respond unlikely to this adjuncts. Probable favorable preoperative factors are important, and that this learning from this article for me too, that a drug coated balloon treatment they have used in 2 studies of urethral stricture disease, which was a basically paclitaxel based chemotherapeutic agent, which was kept around for 5 minutes in that, and they have shown 70% results of patient remaining free of stricture disease with no serious adverse effects at 2 years follow-up. The limitations in the review which we have seen, the first studies were very generally small and variable quality. Inclusion criteria were variable, heterogeneity in definition of recurrence, and only 4 studies have observed, they have shown the complications, and none with the control group has been documented. The future research which we see, the population should include man with short bulbar strictures, would seem appropriate to study this group with recurrent bulbar strictures, and should include both subjective and objective outcome measures and robust assessment of adverse event in both intervention and control arm. The take-home message from this review, any form of adjunct to DVIU or stricture appears to have a lower recurrence or time to recurrence. Interlesional mitomycin C appears to be the most effective adjunct if we see in totality, followed by steroids. Adjunct available appears to be safe and associated with low adjunct specific complication, although the complication were not mentioned. Only in 4 studies have mentioned complication rates. Further studies should be powered to detect clinically meaningful differences, ideally assess the recurrent bulbar strictures. Thank you.
So what we can do is after each presentation, after the comments as well, we can take the questions. Okay. So Ankur, you can sit. I'll give some certain. So the reason why this article was chosen, although this was a systematic review, not an original article, was because DVIU is the most common surgery that we perform for urethral stricture disease. That was one reason why this article was chosen. A very interesting thing is that still all these adjuncts, although DVIU is the commonest surgery that is performed, but the use of adjuncts is primarily surgeon driven. If he likes, he does it. If he doesn't like, he doesn't do it. Why is that so? Even after reading this article, if you see the data, actually the studies that were included were heterogeneous. The number of patients in each study that they have chosen are very, very small. The length of a stricture varied. Some were primary strictures, some were secondary strictures, some were single DVIUs, some were failed DVIUs prior to this. So everything was fairly heterogeneous. So one thing that they brought out was that yes, all these adjuncts do help. But as Ankur rightly mentioned, we need to have more robust and homogeneous groups. At least we know in which group of patients, whether it's short strictures, whether it's idiopathic strictures, or which type of strictures it works. In fact, the author suggested actually this is the team which has written the EAU guidelines 2021 for urethral stricture. This Osman is the main person, is the corresponding author, and he's the person in the European guidelines as well. So although these adjuncts, so many of them, 14 adjuncts were studied, included in this review, but still it's not a standard. So I think after reading this review where they have shown advantage, I think we can plan certain niche studies, where you have a specific subset, especially failed strictures, in those patients with short strictures. I think these adjuncts can be used. Thank you. So if there are any questions we take after each paper that we complete, we can have certain questions.
If you have a query to Ankur. Since you reviewed, the authors included 13 RCTs and 13 non-RCTs. I mean, to have a more robust, they could have only just included 13 RCTs and that would have given a clear-cut answer on one side. So I'm not sure why they intend to include 13 non-RCTs also, because having 13 RCTs itself would have qualified it for one level evidence. Yeah. Except for the fact that it would be heterogeneous, as you mentioned.
I think it is a very valid point, and even I was wondering about it because 13 RCTs is a very good number to do a systematic review meta-analysis. It's not a small number, and probably a more robust conclusion would have been drawn from that 13 RCT with just a RCT and level of evidence increase. I think that I just want to share one point, sir. Actually, when I reviewed this, when I came across 3 studies in this, fortunately, I was not a part actually, but I was as a resident in a training period when these studies were going on those institutes. So there was like Unimix means using only triamcinolone. There was a Bimix, we're adding a steroid intralesional with the mitomycin in the second phase. Then there was a study with a tetramix, like using a steroid, then mitomycin, then hyaluronidase and N-acetylcysteine. So we have actually given those, we have done these cases in our training. We don't have a follow-up for that because training is too short. Only one thing which I want to say is they're safe. So safety, efficacy, we don't know, but still I think, as you said, if we have a robust, well-planned study in this, because safety is not a concern, it can be planned to have a more robust conclusion.
In fact, there's another issue with this review, which the authors have mentioned. There's a risk of bias, high risk of bias in each study that was included. So although, as you said, 13 RCTs, but the numbers included in each RCT is very small. And the patients that were included were again heterogeneous. So apparently that was one reason why they wanted to have more and more studies actually. So that way they could include 14 adjuncts actually. So the only interesting thing that I found was that number one, they have proven, that it works. The results were better. You use anything, but the best results were, as Ankur mentioned, were with mitomycin C. And again, we can, boil down to, a small group, recurrent strictures or short strictures, and really plan a new study. Because we do a lot of urethral strictures.
I was just, sorry, Ankur.
Please, please.
I was just wondering whether using a laser in place of cold knife would make any difference, because there are studies which have compared the two.
Yes.
So whether using a laser with injectables would make further difference to recurrence.
Yes, that could be another idea, Actually, but they have looking at only cold knife.
Yeah, actually 2 studies in this, they have used laser only. There were 2 studies they were using laser in this. Yeah, so there are 2 studies with laser OIU. I just want to share that I think so we can, USI has a very good initiative right now for collaborative projects. So, just it can be to have a big number. This can be a good idea for after this presentation.
One thing about safety, I was there when the studies were being done in PGI. I'm there, right? So there were at least 2-3 patients who had very bad ulcerations and necrosis. So especially when we added hyaluronic acid. So it is not very safe. We need little more robust. Regarding mitomycin, triamcinolone, it's still okay. I've not seen any complications. But then when we started that trimix, there were 2 patients, and from that day we stopped it. So I just wanted to share off the dais. Yeah.
Okay, so I think we move to the next presentation. I invite Dr. Gautam Chaudhary, and Dr. Nayak will give the comments. You can change the presentation.
Good evening, everyone. So my paper is omission of the systematic prostate biopsy for the high-grade pyrite 5 lesion in the MRI and the PSA density of more than 15%. And this was published in the Journal of Urology, and the original title was the systematic biopsy of the prostate can be omitted in men with the pyrite 5 and the PSA density more than 15%. It was the multi-institutional study. So before directly going to the article itself, just want to discuss that what the aim of the biopsy is to diagnose the prostate cancer. At the same time, in present time, we don't want to overdiagnose the prostate cancer, and we don't want to miss the clinically significant prostate cancer. And for that, all 3, like examination, radiology, and other parameters like PSA derivatives, and some urinary markers, and then scores, they help us in choosing the right patient which should not be missed by the biopsy. So author aims to evaluate the detection of the prostate cancer and the clinically significant prostate cancer on the systematic biopsy, targeted biopsy, and the combination of the systematic biopsy and the targeted biopsy in men with the pyrite 5 lesion and impact of the systematic biopsy on the study population. So in their material and method, this is the retrospective study where the biopsy was taken with 18 gauge needle, and the targeted biopsy was at least 2 core were taken from the lesion, which was largest lesion in the MPMRI, and it was the Pirate 5 lesion. And the systematic biopsy was the 12 core biopsy. And there was the homogeneity in the form of the reporting was by in the International Society of the Urological Pathology grade group, and the statistical calculations were done in the SAS software 9.4, and the methods applied was the Wilkinson rank sum test for the continuous variables, and the Pearson's chi-square or the Fisher exact test for the categorical variables. Logistic regressions analysis was done to identify the clinical factor associated with the clinically significant prostate cancer. So in their results, out of the 124 patients, 112 patients in whom the MPMRI shown the grade Pirates 5 lesion, and all were submitted for the 12 core systematic biopsy and targeted biopsy. So in the systematic biopsy, the detection of the prostate cancer was 89%, and the clinically significant prostate cancer detection was the 72%. Whereas in the targeted biopsy from the lesion was the prostate cancer detection was the 93%, and the clinically significant prostate cancer detection was the 81%. And when combined, so the when the systematic biopsy and the targeted biopsy was combined, then the 2% increase yield from the targeted biopsy as a whole from the prostate cancer detection, and 4% increase detection of the clinically significant prostate cancer was the finding. In the 78 patients, they could find out the PSA density, and that was more than 0.15 nanogram per ml square. Here the results were in the systematic patient biopsy, the 92% were detected prostate cancer, and the 79% detected clinically significant prostate cancer. Whereas in targeted biopsy, the 97% could be detected on the targeted biopsy, and the clinically significant prostate cancer were detected in 91%. And here, even after combining the systematic biopsy and the targeted biopsy, the prostate cancer detection was the same, whereas the clinically significant prostate cancer were 4% higher when the targeted biopsy combined with the systematic biopsy. So in their discussion, they mentioned that previously MRI avoid systematic biopsy for the prostate cancer diagnosis by avoiding the prostate biopsy in those with the low suspicion MRI and the performing only targeted biopsy of the MRI suspicious lesion. Several other studies shown that the PSA density and the high grade MRI lesion can only targeted biopsy can be done. However, the systematic biopsy cannot avoid in all scenario. This was the message. And according to author, what is the benefit of avoiding or omitting the systematic biopsy was the reduced adverse event and the complications of the biopsy, time to the biopsy and the specimen processing, reduce the workload for the urologist and pathologist, improve the cost effectiveness, patients' satisfactions, increase the number of the procedure performed daily, and shorter time for the diagnosis. Author attempted to study the can systematic biopsy avoided in man with the high-grade Pirates lesion with the PSA density more than 0.15 nanogram per ml square without compromising prostate cancer detection. In present study, 2% of the prostate cancer was missed by targeted biopsy alone versus combination of the targeted and the systematic biopsy, whereas the results were similar in the Pirates 5 lesion when it was combined with a PSA density. Whereas in both study, 4% of the clinical significant prostate cancer were more in the combination with the targeted biopsy with the systematic biopsy. Similar studies, they mentioned in their discussion that MRI first study was done and done in the biopsy naive patient. A trust-guided biopsy, systematic biopsy by an operator who was blinded to the MPMRI finding and the MRI guided the targeted biopsy by another operator in the same patients, the detection rate of the clinically significant prostate cancer and on the targeted biopsy was higher than the systematic biopsy. When considering the PIRATE 5 population, the detection rate of the clinically significant prostate cancer was 68% for the systematic biopsy and 78% for the targeted biopsy. However, when the combination was done again in this study also, the total reached to the 83%. So in the limitations, they mentioned it is the retrospective study, a relatively small sample size, and performed in a tertiary center where all images were reviewed by the expert radiologist, urologist, and pathologist. Results may not be extrapolated to the non-tertiary centers. So in take-home message, we can't afford missing 4% of the clinically significant prostate cancer, and use of other adjunct other than the PSA density alone, like PSA, free PSA, total PSA velocity, PSA, PHI score, 4K score might help in detecting or knowing the not missing the clinically significant prostate cancer. Thanks.
Thank you, Gautam. Actually, prostate biopsy and the MR fusion biopsy, there has been lots of debate and controversies whether after the introduction of MP-MRI and MR fusion biopsy, whether one can actually avoid systematic biopsy altogether and only do targeted lesions. So address that question, this is actually not a fast study to address that. There has been lots of other papers on this because this is a controversial issue. But to do that, the first thing actually one should understand whether MRI is 100% accurate in predicting prostate cancer. So for that, there has been actually a landmark paper that was published from UK. The trial was PICTURE trial to see how accurate MRI in detecting prostate cancer, the lesions. So when they actually found out in MRI, if the lesion is more than PIRATE scoring, if they consider it is 3 or more are considered positive, in those cases also, if you avoid a systematic biopsy, the chances of missing out prostate cancer, the clinically significant cancer will be to the tune of 7%. But if you take more than 4 PIRATE score as positive, in those cases, the chances also missing out a prostate cancer will be 17%. So for that, from that study, one cannot actually do only a targeted biopsy and then just altogether leave the systematic biopsy. But then the more important question was then the precision trial came. The precision trial actually said, if you do a targeted biopsy, the chances of picking up clinical significant cancer are much more higher, like 38%, whereas in systematic biopsy, it was only 26%. And in other words, in another way also, in doing a targeted biopsy, the chances of picking up clinically insignificant cancer is very less. It's 9%, whereas it was 22% in patients, those who are undergoing systematic biopsy. So from precision trial, there was lots of debate came into picture whether one should do only a targeted biopsy. But after that, there has been lots of randomized trial also published in European Urology to compare both targeted and systematic biopsy. In all those trials, it has been shown if you do only targeted biopsy, the chances of missing out clinically significant cancer can be varies from 4% to 14%. The study Gautam mentioned is MRI FAST study. That was actually one of the robust and very scientifically designed trial in which actually the patients initially had an MRI, and from the MRI targeted lesion, there will be 2 persons, those who will be doing biopsy. The person who knows the lesion, he will do only targeted biopsy, and the other person who will have no knowledge regarding the lesions in the prostate, so that he cannot actually, while doing a systematic biopsy, he should not do a cognitive fusion because he doesn't have any idea where the lesions are. Even in that study, there was not any significant difference between clinically significant prostate cancer in both arms. However, what they found actually, if you combine both systematic and targeted biopsy, the chances of, if you do only systematic biopsy, the chances of meeting out significant cancer will be 14%. If you do only 20%, if you do only targeted biopsy, the chances of meeting out significant cancer will be 14%. So both systematic and targeted biopsy are actually adding. Systematic biopsy adding to the tune of 14% and targeted biopsy adding to the 20%. So as of today, this is an innovative idea because they have only targeted PIRATE 5 lesions. But as of today, the message should be, if a patient is having a by biopsy naive patients, if you do an MP-MRI fast, even if we found a lesion, the recommendation should be patient should have a targeted biopsy and systematic biopsy. If the patient is already a prior negative systematic biopsy and you did an MRI and you find a lesion, in those cases, you can actually avoid a systematic biopsy because he already had a systematic biopsy before. So you can only target the lesions. So that should be the message out of this. Biopsy naive patient, it should be both targeted and systematic. Prior negative biopsy, MRI, then only targeted biopsy.
Yes, sir, exactly. But the use of the other like PSA derivative, they can tell us that this patient is having the clinically significant prostate
There are
cancer.
other factors which actually can contribute to actually decide if those risk factors are not there, the chances of how accurately you can predict, because MRI itself, even if the MRI is negative, it cannot predict there will be no cancer. So they're trying to add some other additional risk factors. If those factors are present, not present, then you can actually avoid a systematic biopsy. But even in this particular study also, in concurrence to the other studies, they are still missing out actually 4% of clinical significant
4%
cancers.
clinically significant.
So whether actually we should just depend upon this particular study and completely forego the systematic biopsy, that's a big question. And if you talk about the Indian scenarios, MRI fusion biopsy is not available in most of the centers. So just to one study and to completely forego systematic biopsy, we are still not reached that stage.
Yes, sir. No.
Dr. Naik, can I make a comment?
Yes, sure, sir.
Sure.
Okay, we have studied actually this concept in Indian patients. I have put this topic to a student for his thesis. I have data retrospective, 75 patients I have analyzed over last 3 years, 75 patients. The aim of the study actually was slightly varied from this, but the end results are going to actually help in this same concept. What we have tried to see is, does the MRI PIRAD score corroborate with the grade? As expected, it does. A 4 and 5 corroborate to the extent of more than 95% with the grade. So when you find a PIRAD 5 and you're biopsying only that, most often you will at least land up in a grade group 4 disease, if not 5 disease. This is what we have found. In fact, in these 75 patients, all our biopsies were systematic and targeted. Targeted is cognitive fusion. Out of 75, 74 were positive at both sites. With both, that means if you're taking targeted and systematic as a group, I'm not talking at core level, but at a group level, patient level. Both were positive in 75 out of 75. In only one patient, the targeted missed to pick up what was picked up in the systematic. Okay, this is Indian patient data which we have picked up, and we have not been selective in only PIRAD 5. We have taken 3 to 5. And yet we found that if you have done a proper fusion, a cognitive fusion, and you take that particular core properly, most often you will be correct in targeting the biopsy. You will miss only one. We have lost one patient in this cohort of 75. So I find that the corroboration is there. It's very strong.
Thank you for the excellent presentation and analysis, sir. So I'm Ashwin Malia from Delhi. So we have, just like sir alluded to, we have also studied this. I have been part of a study where we have studied if we can totally avoid doing systematic biopsies, if we have enough information from, whether we can have enough information from targeted biopsies. So we studied around 120 patients. And we found that by avoiding systematic biopsies, we are still missing about 8 to 10% of clinically significant cancers. So I think our data, even in India, it's along the same lines. We found, so I have worked in 2 centers where in one center I had MR fusion platform. And in one place where I'm currently, I'm doing cognitive fusions. So what I have found is more or less, I've studied the baseline characteristics in both sets of patients and found that cognitive fusion is, I would say, almost as good as
the literature does say there is not much difference.
Not much of difference.
MR trust fusion, cognitive fusion, and also in-bore.
Yeah, in fact, the MRI first study, which was done in the UK, also used cognitive fusion in most centers, as NHS doesn't have fusion platforms everywhere. What I would like to ask the experts here is whether they find the utility of doing fusion biopsies in selected patients, like patients where there are anterior lesions, because those are very often, because most people are not doing MR fusion biopsies, even cognitive or platform biopsies. So do you suggest that when they find a lesion like that, they should probably refer it to a center where they have the expertise of doing cognitive fusion or MR platform fusions?
I think especially for the anterior lesion, I think rather than the going the transrectal transperineal
Yes,
would be
correct. Yes.
rather than the fusion, the approach should be the different. Then
Yes,
you will.
correct.
Yeah.
So it's not been much in India, but actually, as he said, if it is an anterior region, the chances of missing out through a cross-guided biopsy will be much higher.
Yeah,
If you
there would
actually
be
do.
high.
Okay, thank you. I
Tha-
think we are
Thanks.
short of time also.
Thank you, sir.
Yeah, so can you show this? So Kamaljeet has not come because of some reasons. So I'll be presenting on his behalf. So this article is dutasteride improves nocturia, but does not lead to better sleep. Results from the reduced clinical trial. So the rationale is that, as we all know, nocturia is caused by a large number of conditions. Some conditions include restless legs syndrome and obstructive sleep apnea and depression. And the usual thing is that we treat these patients who come to us with nocturia by giving BPH treatment. And there's data to show that BPH medications do improve nocturia. So, but it is unclear if BPH treatments for nocturia also improve patient sleep. So that was the issue. So we know that treating BPH with the alpha blockers and 5-alpha reductase does improve nocturia symptom. So what they have done, they have analyzed the data they have for the reduced trial, and they have analyzed whether treating LUTs with dutasteride altered the nocturia or sleep complaints compared to the placebo group. So as we all know, REDUCE is a 4-year multi-center randomized trial comparing dutasteride 0.5 per day versus placebo for chemo prevention of prostate cancer. So it's the primary trial is for something else, but they have analyzed this data, and the subjects in this trial were between 50 and 75 years, and they had a PSA range between 2.5 and 10. A prostate volume of less than 80 ml, no previous prostate surgery, IPSS less than 25, and if the patients were on alpha blockers, IPSS less than 20. So what they have done, they have analyzed IPSS at baseline, then at 2 years and at 4 years. I'll not go into too much details because there's lots of statistics that they have done. And IPSS values following prostate surgery and men diagnosed with prostate cancer during the study were censored. They were removed from the study. And what they have done, they have measured the MOS medical outcomes study, sleep scale survey they have done. And again, they have done this at the baseline and again at 2 and 4 years. And the patients were asked to recall sleep quality from the previous 4 weeks, as we do for IPSS, and respond to a 6-tiered scale ranging from none of the time to all of the time. So this is the scale that they have used. And all participants had a negative prostate biopsy within 6 months of study enrollment, and participants were excluded based on various exclusion, the data that was deficient in the database. And finally, they analyzed about 7,000 patients. They were evenly distributed, about 3,500 in each arm. They were primarily white individuals, and with a baseline BMI of 26.8 about. And the PSA median was 5.6. The prostate volume was 42 ml, and they were primarily having mild symptoms. The IPSS scores in both groups were 7, and the baseline sleep score was 17. The maximum is 60, so it's 17. And the baseline nocturia episode was, the median was 1. So if you see the results, there were 2 endpoints, one at 2 year and another at 4 year. Dutasteride had a significant effect on nocturia. Okay, so the interrupted line is dutasteride, and this line is the placebo arm. So dutasteride did show some improvement in nocturia. But if you see the sleep in both groups, both the placebo arm as well as the dutasteride arm, it remained the same over a period of time. So this did not change. So dutasteride had no effect on sleep problem index during the study. And there was no statistically significant change in sleep problem index from baseline to 2 years or from baseline to 4 years. And when each domain of the sleep problem index was examined as a separate outcome, dutasteride was not associated with improvement in any of the sleep outcomes over the course of the study. Although, as I had shown in the previous slide, dutasteride did improve on the nocturia. So coming to the discussion, so nocturia leads to poor sleep. Leading to poor sleep is a symptom commonly reported by men with BPH, but the effect of BPH treatment's improvement in frequency of nocturia on overall sleep quality is unclear. So one thing is clear, that it does improve nocturia, but what impact does it have on sleep quality is unclear. So this study explored the relationships between medical treatment of BPH, patient-reported nocturia, and subjective quality of sleep. So there were three things. So the authors found that BPH treatment with dutasteride improved men's frequency of nocturia, but had no effect on their perceived quality of sleep. Even among men who were more symptomatic based upon LUTs, nocturia, sleep, and combinations thereof. So they combined various information, like they graded the LUTs severity, mild, moderate, and severe, and they combined various nocturias, more than 2 times, more than 3 times, more than 4 times. So various combinations were analyzed, and they found that dutasteride had no effect on sleep quality in either combination. These data suggest that treating nocturia with oral BPH therapy is unlikely to improve sleep quality among a general population of men. So one thing they again found is very, very clear, as reported in the previous literature as well, and that is that dutasteride does decrease nocturia. So they found that there is indeed a correlation between sleep and nocturia. So this is another thing that we need to remember, that there is a correlation, and the link was highly significant, supporting the premise that treating men with poor sleep and nocturia with BPH medication is a reasonable strategy. So what we are doing is correct, that we are treating these patients with BPH medications. The treatment effect of dutasteride decreased the frequency by 0.15 and 0.24 episodes per night compared to placebo at 2 and 4 years follow-up respectively. So why does this happen? Dutasteride is improving nocturia, but it is not improving sleep. So the decrease in nocturia did not translate into improvement in sleep quality. So why is that? I think so. Dr. Sameer, I think you'll add these comments, or shall I? Okay,
You can finish it.
So it is possible that the magnitude of reduction in nocturia episodes with dutasteride treatment were statistically significant, but not clinically relevant. So again, we need to remember these two things. One is the statistical significance, and another is clinical relevance, or clinical significance, you can say. A more significant reduction in the number of nocturia episodes may be more impactful for sleep quality. So the amount of reduction, although it was statistically significant, was not clinically relevant actually. So that is one reason. So this data cannot disprove the hypothesis that treating nocturia improves sleep, but does argue that oral BPH medications, especially alpha reductase inhibitors, are insufficient for this purpose. And so as I had mentioned, various subgroups they analyzed depending on the severity of symptoms, and they did find again the same thing that I mentioned previously, that the sleep quality did not improve, although there was an improvement in number of nocturia episodes. So I think I'll stop because I have already overshooten, and I'll invite Dr. Sameer Trivedi to give expert comments.
Yeah, thank you, doctor. Now, this study has its own strengths and limitations. The key strengths are that it's a well-designed, randomized, placebo-controlled study with a fairly large sample size of nearly 7,000 patients. The follow-up is quite long, up to 4 years, and they have used very validated questionnaires, both IPSS and MOS. So these are the key strengths. However, this data is actually taken out of context from REDUCE trial. So the study population, this study was neither designed nor powered to find out the effect of dutasteride in reducing nocturia per se. So they are kind of extrapolating the results of dutasteride used for some other purpose in a well-defined subset of patients to correlate its effect on nocturia and sleep quality in the general population. That's what they are saying. Now, they have used various alpha blockers which have not been specified. So we know that there are few studies which mention that some particular alpha blockers like say silodosin have got marginally better effect on nocturia as compared to say alfuzosin. So these kind of confounding variables are missing from this study because the population was used for some other purposes. Similarly, for nocturnal polyuria, I presume that since the recruitment was done for studying the chemo prevention effects of dutasteride, so there might have been few patients who may be having true nocturnal polyuria, but since avoiding dairy kind of assessment was not done in these patients, so whether that added further to the confounding variables. The third thing is dutasteride per se. A lot of studies have shown that causes significant cognitive impairment, mainly anxiety, dementia, depression, and all of these by themselves can have an impact on the sleep quality of the patient. But nevertheless, even if we take all these things out of the equation, the message is quite clear, and we are all aware of that both nocturia as well as the sleep quality in elderly people is multifactorial in origin, and therefore simply targeting one arm of the etiological pattern may not be enough to give the desired relief that is required in these patients. So probably we need to have a more comprehensive look at the overall sleep quality pattern and the factors which may affect the sleep of these patients, and not rely only on our BPH medications to relieve the nocturia as well as improve the sleep quality.
Thank you, Dr. Sameer. I think this is our personal experience also in our patients. We give alpha blockers, they are happy, but you know, the sleep quality, the number of times, the nocturia improves a little bit, but the number of times they are waking up doesn't improve actually. And sometimes the primary issue is poor sleep, but they correlate that poor sleep due to nocturia. They feel that it's because of nocturia that they are not sleeping well, but that is not true many times. Thank you. So we move on to the next presentation. I'll invite Dr. Somendra Bansal from SMS Jaipur.
A very good evening, everyone. So topic is a multiparametric MRI should we prefer over DRE for prostate cancer local staging and disc disease classification. This study was published by Soetrik et al. From the Netherlands in Journal of Urology in 2021. As we all know, MP-MRI of prostate is emerging diagnostic modality. It has important role in detection of clinical significant disease and local tumor staging. As per literature, MP-MRI lead to substantial upstaging of patient to a high risk group and may lead to alteration in the treatment. But it remains unclear whether MP-MRI in non-organ confined disease is equivalent to the DRE. So aim of this study is to assess the impact of MP-MRI in local tumor staging on prostate cancer risk stratification and choice of the treatment. And second is to evaluate the accuracy of both DRE and MP-MRI for detection of non-organ confined disease in a subset of patients undergoing RARP. This study was conducted within the Centurion Consortium. This consists of 7 teaching hospitals in Netherlands, and data was extracted from prospectively maintained Centurion database containing baseline tumor characteristic, clinical TNM stage, and MP-MRI stage. Patient with newly diagnosed localized or locally advanced prostate cancer who underwent MP-MRI from 2017 to 2018 were included in this study. And DRE was performed by senior resident and urologist. MP-MRI image was retrieved from radiology reports, and reporting was done according to PIRATE version 2. Patient classified into the risk group according to EAU classification system into low risk, intermediate, high risk, and locally advanced high risk. In patient who underwent external beam radiotherapy, consequences of upstaging by MP-MRI was defined as addition of androgen deprivation therapy to EBRT. Sensitivity, specificity, negative predictive value and positive predictive value assessed for DRE, both for DRE and the MP-MRI. And analysis were done in subset of patients who underwent RARP as primary treatment using histopathology of prostate specimen as a gold standard. Potential prognostic impact of non-organ confined disease on MRI was assessed in patient undergoing RARP since between January 1 to 2017 to July 2018. Patient treated from July onward was excluded because of limited follow-up time, and BCR after RARP was defined as PSA more than 0.2 nanogram per ml. So in this study, there is total 83 patients, 1740 patients underwent MP MRI, and only 1683 patient has a complete baseline data. So on the basis of this table, according to the risk group, locally advanced disease present in 228 patient on DRE and 579 patient in the multiparametric MRI. So risk group migration based on the MP MRI finding occur in 32% of the patient, 29% patient underwent migrate to the higher risk group, and 3% patient to lower risk group. Presence of non-organ confined disease on MP MRI was reason for upstaging in 77% of the patient. Upstaging occur in 21% patient in low risk on DRE, 37% patient in intermediate risk, and the 40% patient in the high risk of which is on the DRE. But migration to the locally advanced disease occur in 10% patient in low risk group and 27% in intermediate and 45% patient in localized high risk on the DRE. So a total of 506 patients with complete study data treated with RARP were included for the analysis, and cumulative rate of true positive and true negative stage for non-organ confined disease was higher in MP MRI compared to the DRE. Sensitivity is higher in case of the MRI as compared to the DRE, which is statistically significant, but specificity is low in case of the MRI for the non-organ confined disease with high false positive rate. 193 patients of the low and intermediate risk group treated with EVRT, on which 53% migrate to the higher risk group after the MP MRI. So upstaging was associated with higher percentage of patient with treatment intensification, 52% in patient with upstaging compared to 25% without upstaging. Association of DRE and MRI with the biochemical recurrence after RARP, a total 300% underwent RARP. Of this, PSA follow-up data available for 98% patient, and biochemical recurrence occur in the 46% of this patient. On this Kaplan-Meier long rank test, which shows statistically significant difference of both risk group in DRE and MRI in the risk stratification system, but there is a relative difference regarding progression-free survival between the risk group decrease if multiparametric MRI is used. So this study is demonstrated that there is a state migration of the higher disease stage occurring 1/3 of the patient with 3 times higher or for the treatment intensification. And with the multiparametric MRI, more cases of the non-organ confined disease were detected with high rate of false positive. Since MP MRI outperformed DRE in terms of cumulative rate of true negative and positive rate for the non-organ confined disease, it should be preferred over DRE for the local staging. In the literature, results are the same, but the limitation of these studies are there. These are the single institutional design and a small sample of the patient undergoing RARP with relatively low number of patients with low risk disease. Present study validate the previously reported finding with multi-institutional in nature and large number of the low risk patient. Positive predictive value of the MRI for non-organ confined disease increase when it accompanied by the higher PSA and the ISUP biopsy grade more than 3, with reaching 82% positive predictive value in patient with PSA more than 20 and the ISUP grade more than 3. The result confirmed that MP MRI outperformed DRE with regard of local staging and reduced the risk of the understaging and potential under treating those who harbor the non-palpable non-organ confined disease. But the lower specificity of the multiparametric MRI for detection of the non-organ confined disease increased the risk of the overstaging. So this technique is still not perfect, but combining multiparametric MRI information with other baseline parameter like the biopsy information, PSA, can improve the prediction of the unfavorable histopathology. So nomogram can be developed on the basis of the MRI and the biopsy report on the PSA report. So presence of the non-organ confined disease on MRI can potentially be valuable prognostic factor indicating the potential need for treatment intensification by either by non-nerve sparing prostatectomy or additional pelvic lymph node dissection. But the limitation of the study is the they don't account for potential impact of the MP-MRI target biopsy for the stage migration. Pre-biopsy MRI was not performed standardized in all patients. Upstaging occur less in hospital who use the pre-biopsy MRI. And the heterogeneity of the MRI protocol, wide variety of the urologist and resident performing DRE and the radiologist performing the MP-MRI reading. Apart these limitations, there is a other limitation like they don't measure the diagnostic accuracy of the non-organ confined disease in the T1 and T2 stage, and that there is no dedicated uropathologist for reading the biopsy report. So this conclusion of this study is that their upstaging occur in the 1/3 of the patient, and MP-MRI result in higher overall diagnostic accuracy for detection of non-organ confined disease and should be preferred over DRE for determining clinical tumor stage, but it has higher false positive rate. So we should avoid, we should aware for the overstaging and over treatment of patient who harbor genuine lower risk disease. Thank you.
Thank you. Thank you, Dr. Bansal, for a nice presentation. I mean, this article is relevant because till now the guideline T-staging is based on clinical staging. So now what the authors are propagating is that you should use a MP-MRI based staging so that you are more accurately stage them. But then you clearly mentioned that it has limited specificity. So we are unnecessary. We might overstage patients and actually overtreat them for no benefit. So it should be MP-MRI with addition of nomogram. That might help us to actually classify them in a better way. Having said that, we are in India, so MRI it is not available at every places. It is too expensive, so we cannot get away from DRE. So we have for our scenario, DRE is a must. And in fact, ICMR recommends that DRE is mandatory for CA prostate detection. And I think audience would also agree that at this stage we cannot get away with DRE for staging. So that would be my comment.
Thank you. So thank you, Dr. Somendra. So we move on to the last presentation of this session, which is, and I'll invite Dr. Y.M. Prashant from Safdarjung.
Good evening, respected chairpersons, my colleagues and seniors. I would like to review the article named Outcomes of Active Surveillance for Young Patients with Small Renal Masses, prospective data from the DISS RM registry. This is actually a subset of the well-known popular study, date back to 2015, where all the age groups were included. In this specifically young age group have been evaluated. So these are the normal abbreviations what have been used. A is for active surveillance, DI for delayed intervention, and PA for primary intervention. So incidence of RCC increasing, as we know, maybe due to increase in imaging, obesity, and hypertension. Stage migration is also seen with increased stage 1 disease and decreased size of the tumors at diagnosis. And there is a huge paradigm shift in the management of SRM away from the radical nephrectomy towards and more towards a nephron sparing surgery, including active surveillance nowadays. So accumulated data till now has established active surveillance as an appropriate initial management of newly diagnosed SRM. However, the many were retrospective studies and few prospective studies with limited power. So the initial DISS-RM registry is a prospective multi-institutional clinical study with following the patients with SRM, comparing outcomes of active surveillance to primary intervention. So the present analysis specifically focuses on the patient's age less than 60 years of age at the diagnosis to examine the outcomes, whether it is durable in this subset of population. So this has been taken from the original study. The patient was allowed to, after selecting clinical T1 tumors on axial imaging, the patient was allowed to choose whether he wants to go for a biopsy or not. Then whether patient wants to go for surveillance or primary intervention or after explaining and counseling.
So once enrolled, the surveillance will be done using ultrasound, preferentially every 6 months for the 2 years, initial 2 years, and then every 12 months for the next 3 years. And the patient can undergo to delay intervention at any point of time from the surveillance at his will. And when the patient undergoes intervention after a certain time, then it is called the delayed intervention. And patient will move to delayed intervention over the course of time if the growth rate is greater than 0.5 centimeter per year, or size greater than 4 centimeters at any point of time, or symptoms. Inclusion criteria: at least patient should be greater than 18 years of age, a clinically localized solid enhancing T1A renal tumor, axial imaging. And exclusion criteria: personal history of RCC, familial RCC syndrome, or suspicion of metastasis to the kidney or excluded. Intervention is recommended upon evidence of tumor progression, as I already mentioned, great growth rate and tumor diameter and development of metastatic disease. Progression-free survival was defined as absence of any AS discontinuation, secondary tumor progression, or elective crossover to intervention were also included in the progression. In patients undergo intervention, recurrence-free survival was defined as a freedom from local or distance tumor recurrence or death due to kidney cancer. So data analysis: the primary outcomes for overall survival and cancer-specific survival. Secondary outcomes included growth rates, progression-free survival for AS patients, and recurrence-free survival who underwent intervention. So results in this, basically in this slide, we can see mainly the age of the patients is significant difference between the primary intervention and active surveillance. And the number of prior abdominal surgeries is also significantly different. And the comorbidity index is also significantly different, more in the comorbidities, more in the active surveillance group, and history of other solid tumors also more in the active surveillance group. And the mean tumor diameter at enrollment is also significantly different in the active surveillance group. Coming to the growth rates, progression, and delayed intervention in AS group, the overall negative growth rate was 16.7%. Out of 66 patients who enrolled in the AS, and overall zero growth rate was seen in 10.6% of patients. Overall positive growth rate was seen in 72% of the patients. And 20 patients experienced a progression event, 16 due to the elevated growth rate, and 4 due to, that is 20% due to the elective crossover. However, no patient developed metastatic disease. Only 9 of the 16 patients with elevated growth rate crossed over to the delayed intervention. And progression-free survival in active surveillance was 7.1% at 5 years and 61% at 7 years. And none of the patient or tumor characteristics were predictive of the progression while on AS. So this is the same curve which depicts the progression-free survival in active surveillance patients. Overall, 13 patients underwent delayed intervention. So median time to crossover was 12 months. Initial tumor size with the initial tumor size of 2 centimeters, 88, that is 15% crossover to delayed intervention. In tumor size of 2 to 4 centimeters, 33% of the patients crossed over to delayed intervention. Intervention-free survival at 2 years was 87% in active surveillance and 65 in 2 centimeters group, and 65% in those with the initial tumor size of 2 to 4 centimeters. Overall survival and cancer-specific survival outcomes. The overall survival was similar in both patients undergoing primary intervention as well as active surveillance at 2 years, that is, and 5 years, and at 5 years and 7 years, not significant. And no death was attributable to RCC. Cancer-specific survival was remained 100% in both the groups. So this is the same graph depicting there is no significant difference between both the groups, and the recurrence-free survival is also not different in both the groups. So coming to other characteristics, compared active surveillance versus delayed intervention, none of the age factor of prior abdominal surgeries or comorbidity index or other diameter is not significant. Whereas in primary intervention versus delayed intervention, the comorbidity index is significantly different in the delayed intervention group, and also the history of solid tumor. However, at the time of enrollment, there was a difference between the size with the delayed intervention and primary intervention. However, at the time of intervention, it is not different. So discussion compared to when coming to the previous studies, this is the original study where there is no difference in the active overall survival, and also growth rate is in the similar rate, that is 0.5 centimeters per year. These are the other study, the systematic review and pooled analysis, where the growth rate matched with the present study, and none of the patient exhibited progress to metastasis. This is another study in Canada Urological Association journal that also signifies the similar growth kinetics. So however, this study is not without limitations. There is a lack of randomization. The tumor diameter and linear growth were used. However, volumetric measurements would have been more accurate to represent the growth. The sample size is smaller. The data derived from the registry mainly from the academic referral centers only. So there might be bias in the enrollment. The lack of biopsy mandate. The patient was allowed to choose for whether he want to go for the biopsy. So this may affect the estimation of the cancer-specific survival in this. However, in this cohort, as there was no death, it was nullified. The possibility of the benign mass strengthens the support for an initial period of active surveillance being safe. However, it could be delineated only when it is followed over a longer period of time with a longer population, and specifically if with the randomized control trial. So to conclude and take home message, in this cohort of patients aged 60 years or younger at the diagnosis of small renal masses, management of active surveillance does not negatively affect either pathologically, oncologically, or clinical outcome, and is durable at least in the intermediate and short term. So no patient developed metastasis on active surveillance or develop recurrence after delayed intervention. At the crux of active surveillance is appropriate patient selection and monitoring. This study confirms that these principles can effectively apply to even to the younger population based on this study, validating the safety and durability of active surveillance in younger cohort. However, the further longer studies, study with the larger population is required. Thank you.
Thank you, Dr. Shant. Actually, in this your article, the age group included is 18 years to 60 years.
Yes. At least greater than
18 to 60 years, and the follow-up modality is 6 monthly ultrasound.
Yes.
So my only concern is that if you suppose we have a 20-year patient with a 1.5 centimeter tumor, and we are giving him active surveillance, and as you know, in a 20-year-old patient, ultimately it will definitely going to. The only concern is that you are not concerned about the pathology. You are not sure about the histopathology.
Yes, yes.
So the only crux of active surveillance is that it may be a benign tumor.
Yes.
But I think ultrasound
and also based on the growth rate also, the patient might be intervened at a certain period of time when there is an increasing growth rate.
Growth 0.5 centimeter per year.
Malignancy precedes the preferential growth rate before the development of the actual malignancy or metastasis. So we have a window period before going to.
So ultimately, 1/3 patients went for delayed intervention in this group.
Yes, sir.
1/3 of
30%,
patients,
yes.
but no patients developed.
No, none of them developed metastasis.
So quite interesting article, but we have to be sure whether quite younger population we are not missing that window of nephron sparing surgery if the patient is harboring any malignant.
Yes, a subset analysis has not been done with the different age groups. That would have been better in this. So to
yeah, that is the only concern.
Yes.
Okay, thank you so much. I'd like to thank all the speakers for taking out time and preparing their presentations, all the experts for giving very meaningful comments. We are only 10 minutes. We got the stage late, 15 minutes late. So that is the reason why we have overshot. So thank you so much. Thank you.
अच्छा हाँ आओ 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 ना आओ हाँ
All the faculties, please collect their memento from Spire just next to this hall from the memento distribution stall. After this session, yes. So now we're starting a very important session, and I want to invite the esteemed chairperson of the desk, Dr. Mahesh Desai, sir, Dr. Rajiv TP, And Dr. Santosh Kumar from PJ Chandigarh will join online. He's already on online as a chairperson. So over to chairpersons.
मेरे को मालूम नहीं क्या है क्या बेटा
I think we should start, right? Everybody's having a tea, I think. Well, it is, we all desire that in this hall, we should have the invited lecture session. And first and foremost, none other than Dr. Ajay Kumar, I invite you to speak on a very important topic of medical ethics in urology, present and the future. Now, Ajay Kumar does not need any introduction. I mean, his speech itself will be his introduction. Ajay.
Get the slides. Thank you. Good afternoon, friends. When I came to the hall, little before the start of this session, and last session was going on, I thought it will be only the speakers at the end. I mean, this is not for the first time. We have done it before. I remember one of the international conferences, only those people were sitting in the hall who had to present the paper. And the most interesting was one who was presenting the paper who was going out. Ultimately, one of my friends from India was left, but we were there, two of us, to support him. So two in the audience, one speaker. That we are quite used to it. Anyway, let's come to the topic of this afternoon. It's very important. So far, we have been talking about all sorts of procedures we have been doing, what we will do in future, this and that. But if we don't survive in the profession, then we don't do any procedures. So to survive in the profession, number one, we should be doing the ethical things, because if we are not going at, everybody is looking towards the medical profession to find fault in us. So if we are not ethical, then there is going to be problem. And first of all, I sort of salute the pioneers of the science and art of medicine who laid down the foundation of ethics in medical practice. Well, what is ethics? Ethics, also known as moral philosophy, is a branch of philosophy that involves systematizing, defending, and recommending concept of right and wrong conduct. The term comes from the Greek word ethos, which means character. In philosophy, ethics studies the moral behavior in humans and how one should act. Some would say it is the study of morals. Well, there is a frequently asked question, why medical practice needs such stringent ethical standard? नेता साला बेईमानी करता है, दरोगा घूस लेता है, वो ये करता है, वो करता है, यार हमारे ऊपर क्यों? Mostly the young urologists ask me this question. My dear friend, remember, we are the only professionals in the world who can undress any woman and charge the fee for undressing her from her husband. If we breach such impeccable faith of the society, there is zero tolerance. They will not tolerate it at all. Who are the regulators of the ethics? Because it's a very big subject and I have been given 15 minutes. So I'll just go through very quickly and touch the points. If somebody wants to discuss it more, I have enough time in the evening to discuss. So the World Medical Association, National Medical Association, State Medical Council, ICMR, Local medical authorities are the regulators, and the most important regulator is your own mind. Self-regulation. What are the basic principles of ethics? You remember, because in my talk, I'll keep on mentioning this. Autonomy. Determine the wishes of patients to protect their autonomy. Justice. Follow the due process of determining the limits on health care and treat patients alike. सब में एमआरआई, एमपी एमआरआई कहाँ भाई, मरीज को तो है ही, तो जस्टिस उसके साथ नहीं हो रहा है. Beneficence. Seek the patient's best interest and assess what counts as goods to be pursued. Non-maleficence. Determine what counts as harm and avoid it. Friends, doctor-patient confidentiality is very important. A health practitioner could be suspended or may be fired for posting information about cases on social media. आज मैंने रोबोटिक में ये निकाल दिया, वो कर दिया, ये तमाशा कर दिया, एक दिन फंसोगे भाई तो जादव साहब बहुत दिन रहे हैं एथिक्स कमेटी में, कोई नहीं बचा सकेगा. तो जरा do it in our own circle, the scientific circle and all, but don't boast your achievements on the social media. Is unethical. Now let us see what the conflict of interest in urology practice. Autonomy versus beneficence. Patient in retention of urine refuses to get catheterized. It is his autonomy and you want his beneficence. Patient with urinary tract malignancy refuses the treatment advised by the urologist. It is his autonomy. He wants to go to Ramdev Baba. He wants to go this Baba. He wants to go homeopathy. What are you going to do? Patient wants open surgery for urinary stone disease against the advice of MIS by the urologist. Patients with CRF refuses dialysis and renal transplantation, so and so forth. So many times we get this conflict. Mind you, my friends, never go for the beneficence of the patient. You only go for their autonomy after you have explained enough. You have made them understand everything, even if the patient, and sometimes if the patient is not in a position to give his consent, surrogate consent, one can take, but after a lot of formalities, surrogate consent can be taken. Otherwise, उसे कि क्या करेंगे भाई, हम कोई जज हैं जो पकड़ के ले आएंगे, पुलिस हैं कि वारंट दे के ले आएंगे, जो चाहिए कीजिए. Ethical issues in organ transplantation, non-maleficence. On this basis, living organ donation, which requires healthy donors to be harmed by surgery, and the loss of an organ seems morally contestable. Can't argue that every donor of an organ commits partial suicide. Broznik proposed the hypothesis for paid donor program. Now see how we are having problem. He argues, who questions its ethics should consider that a sperm, egg, and plasma donors are already being paid for their services. If we are doing those things, what is wrong in paying for the organs? Now in allocation, there is again the dilemma of autonomy versus justice. Allocation dilemmas can be far more complex than any challenge posed by the immune system. Should chronic alcoholics receive a liver transplant? Should smokers receive a lung transplant? Should criminals serving life term receive dialysis or transplant? Should drug abusers receive a transplant? Or should children get a priority over the adults? These are the dilemmas we are in. Now let's take the ethical and moral issues concerning surrogacy. Now it is coming very fast. Exploitation of the surrogates. Surrogacy is process where womb of non-valuable women are used as breeders for the embryos of the valuable women. Surrogacy raises fundamental issues regarding the nature of personhood, the attributes of human dignity, individual autonomy, and the perimeters of choice. This includes the criticism that surrogacy leads to commoditization of the child, It breaks the bond between the mother and child. It interferes with nature, and it leads to the exploitation of poor women in underdeveloped countries who sell their bodies for money. Ethical concerns of genome editing, we are part of it. The urologists, the whole urology world. The term genome editing to describe techniques used to modify DNA in the genome. Other groups also use the term gene editing. Mostly it centers around human germline because editing changes made in the germline would be passed down to the future generations. 7 governance principles of human genome editing are here. I'm not going into the details. I have very short time. The ethical consideration of genome editing, safety, informed consent. Some people worry that it is impossible to obtain informed consent for germline therapy because the patients affected by the edits are the embryo and future generations. Mind you, it is the embryo from whom you should take the consent. Justice and equity. As with many new technologies, there is concern that genome editing will only be accessible to the wealthy and will increase existing disparities in access to healthcare, that is called justice. Genome editing research involving embryos, many people have moral and religious objections to the use of human embryos for research. Friends, there has been not long ago, only 15 days back, I think, woman sued mom's doctor for allowing her to be born with spina bifida. Recent judgment of UK High Court to award millions of pounds to 20-year-old Evie Toombs, a show jumper who challenged the doctor of her mother, Dr. Philip Mitchell, to allow her to be born with spina bifida, makes informed consent situation even worse. Surrogate and genome sequence babies may challenge their birth because it was without their consent. Transplant surrogacy and genome editing is important because the ethical, moral, and social dilemmas are going to dominate the first part of the century. Friends, ethics in medical research. I don't know how many minutes have I got? Ethics is an essential dimension of human research. It's considered both a discipline and practice. A medical practitioner may participate in work in research projects funded by pharmaceutical and allied healthcare industry. He should ensure that the source and amount of funding is publicly disclosed at the beginning itself. While accepting such an assignment, a medical practitioner shall have the freedom to publish the results of the research in the greater interest of the society by inserting such a clause in MOU or any other document agreement for any such assignment. If I explain this, it will take me 2 hours. But you understand what we are doing and what we are expected to do. An ethically valid informed consent has 4 components: disclosure, understanding, voluntariness, and competence. This creates challenges for researchers in pediatrics, psychiatry, emergency, and clinical care medicine. Surrogate or waived consent makes large population of handicapped vulnerable. Large, diverse, and treatment-naive population with 6 out of 7 genetic varieties of human race are there in India. Studies have proved that malpractices are rampant in clinical trials in India. Recent cases include unethical testing of contraceptives, fertility drugs, cardiac treatment, and cancer medicines. The triangle of research has investigator, sponsor, and regulator, and the volunteer is in the middle of the triangle. Some unseen concerns and challenges of the investigator: failure to obtain informed consent, falsified data, ethics unawareness, inadequate source documentation, protocol non-compliance, delinquent or inaccurate data submission. In the field of rare diseases, sometimes the number of patients might be the limiting factor for a clinical trial. Physicians are not as familiar with the clinical trial process as they are in the West. Regulators, there is loose control of on the trial. I will just talk here. I will mention about ethics committee shopping. What is it? You know, all the institutions have got their ethics committees. So this ethics committee in PGI Chandigarh is very, very tough. Somebody wants to do multi-center trial, they have to take permission from one ethics committee. They go and Babu S.K. Singh is sitting there with his friend. Yaar nahi, tumhara chalega nahi, garbad. This, I'm not going to accept this trial. Then he finds X place which has got ethics committee. वहां जरा ढीले ढाले लोग हैं, थोड़ा खिलाओ पिलाओ मौज कराओ और पास करा लो. जब पास वहां से करा लिया तो पूरे देश में ट्रायल करेगा. So that is what we call ethics committee shopping. A sponsors whose trials are rejected from one ethics committee approach a different center for approval. Clinical trials are conducted by contract research organizations which are developing the infrastructure for trials by making inroads into small towns, identifying trial sites in small private hospitals, and developing database of potential trial participants. Medical professionals are given substantial incentives to recruit their own patients into clinical trials, which is totally unethical. You can't have your own patients and do the trial. Creates a major conflict of interest that threatens the well-being of the patient. Sorry. Now, and that subject is a very big subject which I have discussed, and it is terribly difficult to explain in such a small, but if somebody has any doubt, I saw some muttering, then you can talk to me and I'll explain to you what is all about this clinical stuff. Robotic era in healthcare issues. We have been talking about robotics. We have been talking about telemedicine. Only these two subjects I will touch in my talk. Once consider the subject of our imagination, best left in the realm of scientific fiction. Robots are now a growing technology that is rapidly changing our world. BioCenter and other sources have suggested that robots could help meet practical care needs, provide round-the-clock monitoring and support for patients, and much needed respite for caregivers. Robotics can also be applied in diagnostic system, robotic-assisted surgery, rehabilitation system for patient groups such as amputees and all. There are some ethical issues we should consider, and they are all very important. Possible loss of personalized care, loss of human contact, autonomy, control, and accountability, patient safety concerns, and possible exacerbation of healthcare and other inequalities. आप तो दनादन रोबोट बात कर रहे हो, मेरा मरीज तो 5,000 लेके आता है, कहता है कर दो भैया ये ऑपरेशन. अब उसमें रोबोट करें कि उसका MPMRI करावे, उसका क्या कराएं, 25,000 रुपया आउट ऑफ पॉकेट. जितना भी आयुष्मान का चक्कर है, ये in principle it is fantastic, in practice it is a failure so far. Now telemedicine, this is the last one, which is very important, and we are all confused about it. The delivery of healthcare services where distance is critical factor by all healthcare professionals using information and communication technology for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evaluation, and for the continuing education of healthcare providers, all in interest of advancing the health of individuals and their communities. The Government of India, along with the Board of Governors in supervision of Medical Council of India, amended the Indian Medical Council Act 56 and published the telemedicine practice guidelines in 2020 to lay down a framework for telemedicine practice in the country in the wake of that COVID, what had happened. But it has not been, legalized yet. Stakeholders in telemedicine, there are 12 stakeholders are there. They are separate entities but yet connected and interdependent. There are legal issues, ethical issues, and administrative issues. For patients, privacy, confidentiality, right to avail required treatment expertise, informed consent. For doctors, responsibility to treatment, data use for treatment and research, privacy, confidentiality, maintenance, commitment to meet the patient directly if needed, local condition adoption, and for service providers, the most important is cross-border cultural language difference consideration, responsibility for right transmission of conferencing, the data storage, consider doctor's expertise availability. And here I will tell you, if you take, say, telemedicine and robotic surgery, अब आप फिट कर दिया कि अमेरिका से भाई साहब सर्जरी कर रहे हैं, अब आपके मरीज पर यहाँ दिल्ली में सब टेली चल रहा है, और जब गड़बड़ हुआ मरीज का, who will be responsible? That is a different country, this is a different country. Operator is different, or patient is different. Oh, again, I'm putting you into confusion, but it's going to be a very, very serious issue in future. Information and privacy related issues. Let the patient also choose. The health information in India is not integrated with technology as is in the Western countries. Well, take home message, friends. Patient care due to rapid advancement in medical innovations, increasing gaps between haves and have-nots, changing moral and ethical values of the society are going to make the ethical practice of medicine more complex and confusing. Mistrust created in doctor-patient relationship due to internet-driven high expectation of patients, that is idiot syndrome. You know what is idiot syndrome? Internet-derived information obstructing treatment. Makes the 4 basic principles of ethics difficult to practice. The healthcare workers of future should negotiate the narrow and binding path of ethical practice with knowledge, skill, patience, and humility. Friends, this lecture I have prepared with 100% recycled electrons, and medical ethics will also keep on recycling in future. So you recycle yourself according to what is going to happen. Thank you very much for your patience.
Ajay, that has been wonderful. And we know a little bit, but to put it in a nutshell and concise so that we can understand is very, very important.
I have just given food for thought.
Yeah, food for thought. But I do agree that it needs more attention. And I'm sure USI will take the notice that this should be, people should be aware of what we are getting into it and where ethics stands and where the, between our lives and the practice. So that is very, very important. Any
बस एक ही
question?
चीज कहूंगा महेश भाई, चलते चलते कि हम लोग यहाँ बैठ के तो बड़े बड़े शेर बब्बर बनते हैं, ऐसे करेंगे वैसे करेंगे, अरे क्या होगा, अरे मरी ये लगा देंगे, वो कर देंगे। जब कोर्ट में खड़ा होना होता है तब सारे शेर चूहे बन जाते हैं, और तब हम लोग खोजते हैं कौन कहाँ। वो जो जज बैठा रहता है, I can talk here in the air, he is biased against the medical profession, और वो आप में सिर्फ फॉल्ट खोजेगा। ये सब टेलीमेडिसिन की, यार क्या डॉक्टर साहब टेलीमेडिसिन। अभी बॉम्बे में एक केस हुआ था, तुमको याद होगा, हस्बैंड वाइफ ने फोन पे एडवाइस किया और मर गया मरीज। 6 महीने का उनका सस्पेंशन ये हुआ और पैसा देना पड़ा गया, जेल गए, कुछ हुआ। तो ये रोज देश में हो रहा है। इसलिए फर्स्ट प्रोटेक्ट योरसेल्फ and then protect the patient. Thank you very much.
Thank you, sir.
Thank you.
Now I would like to invite Dr. C. Mallikarjuna, the President of Urological Society of India. He doesn't need any introduction. All of you are. Now he will be speaking on robotic VVF repair in challenging
I think
case.
it's a corporatization. It's a wrong. Corporatization of healthcare in the future.
Sorry.
It's okay. It's a very difficult task. Thank you, Chairman.
Understood, sir.
Thank you, sir. Very difficult to talk after Dr. Ajay Kumar. He has given food for thought. I think I'll give a snack for thought, if not food.
Corporatization of healthcare.
Well, thank you. Best wishes to the Nauzen Isakon and enjoyable meeting after a long time, after 2 years. Let us go to the, how do I move it? Hello? Okay. Somebody? Okay. Greetings from Urological Society of India. And my talk is on corporatization of healthcare and future of young urologists. I think I've spoken in some other meetings also, but I thought it is worth listening and worth being said to the younger urologists. It's a process of, we think that corporatization, we call about private hospitals, said corporate hospitals and corporate hospitals. They're not truly corporate hospitals. Corporations are government agencies run by in a private form, that is NMDC, etc., or corporations. Whereas what we talk about corporate hospitals are nothing but privatized hospitals. They're all privatizations because costs of demand or need and the lobbying for share. The private hospitals lobby for the share of giving the healthcare services. Why it happened? Because we failed to execute this committee's permissions, what has been said in 1943, where there was a plan which was made for India, like a primary healthcare and then a secondary and a tertiary healthcare, which was supposed to be executed in the next 10 to 15 years, which never happened in India. That's the reason why there had to be an investment coming from the private sector to take care of this health. The Indian government restricted itself to the primary healthcare, never went beyond into the secondary and tertiary healthcare systems. If you go into the board committee recommendations, you know how much lacuna what we have in spite of being 75 years now. And that lead to a national health policy requiring promoting private sector for curative care. And that is a starting of Apollo hospitals in Chennai at that point of time. And it opened up in 2000s when foreign direct investment was, FDI was lifted and the foreign direct investment has come into private healthcare. And that is how the money flowed into private healthcare where there was an investment and the profit which is seen. What happened with corporatization? Partnering, there was corporate hospitals which were invested, new private hospitals which have come in, but non-profit organizations with the management companies, and they have acted as a privatized hospitals, FDI and healthcare sector, and the erosion of small-sized private hospitals and clinics which started on. Why smaller hospitals cannot exist? It's a very known fact. It cannot meet the regulatory requirements. It's an individual based and uncertainty with the individual's life and his uncertainty of his health, and changing patient expectations over a period of time, and insurance sector and a low purchasing power of corporate hospital smaller sized hospitals make them not existing in near future. Advantage corporate, many advantages: advanced technology, human resources, administration by professionals, and a better protection for professionals or working people inside the corporate hospitals. But the disadvantage, as we claim, are abilities and training versus the turnover what is given by the consultant, uncertainty of employment which can be taken out, disparity in payments and performance targets, and sometimes unethical practices which have been said across. But what doctors think of corporate? Let us look into 2 slides. They feel that they pay less, destabilized, and they're never allowed to grow. No discounts to the patients, don't invest in the equipment, and should not believe them. This is the truth, what a doctor feels about a corporate hospital. The reverse, what corporates think about the doctors. Cannot believe, they don't have loyalty. Given a lakh more, they go to the next hospital. Don't look into the ROI. There is no ownership. They claim 100-watt machines are there in India, which have been purchased by private hospitals, which haven't even done 100 HOLEPs in these hospitals. So what happened to that investment made by these hospitals in buying those equipment? Are the consultants responsible for the earning which has to come out of that investment? They are not. They presume that they are indispensable. Number 2, and cannot be productive more than 8 to 10, 9 hours. They become senior, but they cannot be productive. They can't work for 30 hours a day. They still work between 8 to 10 hours a day. So why do we need to give, as the time passes by, more money to them? That's what the corporate thinks about. Fee for service and credit cases, the way of approach to them is entirely dependent. So their value of healthcare is dependent upon what they get out of the patient. So this is what corporate thinks about the doctors, and I think we all agree. So ultimately what we have is perhaps the most subtle loss of autonomy for the profession. We don't have an autonomy of our own, and everything revolves around some materialistic gains, etc. So it's a double-edged sword. Of course, corporatization has brought investment into the private sector that led to buying new equipment, brought quality healthcare to the Indian population. Latest technology has been made available. There's no doubt about it, but there are some unethical practices added to it. I have a disclosure to make. I was a roaming urologist for a decade and a corporate urologist for a decade later, working with a corporate hospital, and then an entrepreneur urologist past 10 years, and I don't know what next the 10 years is there. These are the three gentlemen who taught me how. Number one is the first man, half of the people may not be knowing, is S. Vaidyanathan. He made me how to learn urology in my PGI days. The next man you all know, he taught me how to practice urology. I was a Ekalavya for him. And the third man is Nagesh Nagi Reddy, is a gastroenterologist who taught me how to look beyond urology. But nobody was taught at this thing, why I am doing it. Have we all become a urologist? Can we answer why we wanted to become a urologist at that point of time? What are the results might be after you becoming a urologist before you became? Will I be successful? Did you ever question yourself? You followed the bandwagon, you followed a flow which was happening. It was the most demanding field. We presume that we've become successful, more than driven by the commercial way rather than the passion what we have inside ourselves. Because this is the way we went through in our lives. We don't realize it. We realize it late in our life at 50 years down. Let us look at healthcare economics. There's no consistent, we all agree on this one point, no consistent relation between cost and quality. Do you mean to say a guy who's charged 10 lakhs for a robotic prostatectomy will give a better result? You all agree, it doesn't match with the cost or the result. So quality versus cost effectiveness doesn't mean that you do a radical prostatectomy in 1 lakh and make an incontinent patient, you feel that it's a value for healthcare? No, it is not. So if you original costing of a value was nothing but quality by cost. But now it has changed over a period of time. It is outcomes, patients' expectations and experience by direct and indirect costs of the treatment. You don't consider, you do a URS and send the patient back. He develops two episodes of urinary tract infection. He has a loss of money. He has a loss of work for next 10 days. We don't consider that cost into the whole thing. So the value depends upon the overall thing, what happens at the end of the day, not what you have costed for that single procedure. Look at it in this direction. A single solitary kidney fellow who was on a stent for 2 years, I do a fantastic robotic vasectomy. He becomes without a stent and he drains very well. I thought I've done a great surgery. He rates me as the lowest, poorest guy because one of the sisters working in my hospital offered him coconut juice, though without knowing that his creatinine is 2, where he is very well aware that with CKD he should not do coconut water. So a single touch point of that sort nullifies or possibly completely disperse your whole attempt to do a great service to this patient. So what happens over a period of time? There's so many touch points for a single individual through a hospital. It goes from a security guy who allows you inside to a billing clerk who is the last man to handle that fellow. So you are only a part of the system and you don't think that you are the man who is creating value of the healthcare. You are only a part of the system and the rest of the system creates that value to this whole healthcare business, what has been created around this patient. So we are only a part of it. So what influences the customer? He is, you see, we always say that I do a great PCNL. Damn it, he knows that you do a great PCNL. What else you can do to me? He is coming to you, is lying down on the table means he expects you to the best possible surgery. It is assured. We presume that we are assuring him. He is already assured of those results. You are not going to say that I do better than somebody else. You don't need to assure what you're doing. He's already assured, so he's lying down. What else is the experience, what he gets out of getting treatment from you? So it's a commoditized service. These guys, perfect treatment is already assured. Don't tell that I do the perfect treatment, so you are going to come to me. No, he is already assured of the perfect treatment. What else is the experience, what he gets out of it? So it is basically patient-based outcomes. Gone are those days where you can say the surgeon-based outcome. I give the best stone-free clearance. No, it is a patient-based outcomes. He has to believe that he has done a great treatment. Whether it is stone-free treatment, it is not the thing. We always calculate about how much is the stone-free rate in our hands. It is the least concern for the patient. How do you prepare the patient? What is his expectations? What is his thinking in his mind will make the outcomes to be defined, not your outcome, which we are reading it even today. We still read based on surgeon-based outcomes, not on patient-based outcomes. So this is one economist who said about Michael Porter, you have to look into it. He says it is not patient surgeon-based outcomes. It is the patient-based outcomes which is going to be creating the value for the healthcare. And tomorrow, the whole thing is going to be, oh, I'll take another 2 minutes. Can you push this off? Okay, it is going to be driven around patient-based outcomes and encourages the quality, safety, and patient participation in decision-making, which is the least in this present era. So it's a changing landscape. It is a fee-for-service model to a full-time model wherein we are in this juncture where we are crossing over a period of time, like value-based than volume-based. Unfortunately, Indian healthcare, instead of giving a universal healthcare to everybody, we have insisted on a universal health coverage, which is being funded by insurance companies and being given by the privatized hospitals. So this is unfortunate state of Indian healthcare, which was thought to be an universal healthcare to start with immediately after independence, ultimately resulted in a universal health coverage. How do we adapt to this? Are we trained for this modern healthcare? Chairman, I will take 2 minutes more. And how are we really trained? We are all, you see, we are not trained. Unlikely, we are not trained for our future. We are trained in academics. When you passed out of MCH and MS, you are trained in our academics. You know how to diagnose and treat a disease, nothing beyond it. But when you look at the choosing the doctors for future, you need to have scientific principles which are already imbibed as a doctor. And you need to have an art of attending, observational skills, making a team, working as a team, and team-enabled and team-based care. What is going to be the need? Are we trained in this during our MBBS days or MCH? Never. We were never trained into it. We are trained as an academician. So doctors have to be trained as a part of the team. So what we need in future is, if you look at future of training, we need emotionally intelligent physicians, not as scientifically intelligent physicians, but emotionally intelligent physicians who have self-awareness, empathy, motivation, self-regulation, and social skills. All these things, and embrace the change and adapt. If you don't have these things, you are not going to be for future. So emotional intelligence is self-recognition, social recognition, social regulation, and self-regulation. That is perceiving emotions, using emotions, understanding emotions, and managing the emotions. All these things together. So it's a time for a leadership to understand this. We are also can be leaders. We have to realize that we can be leaders. If you look at doing an entrepreneurship, it is not making money, it's making a difference. If you want to make entrepreneurship, it is making a difference, not making money. So if you have, it is a financial return, and the wealth creation is a byproduct of entrepreneurship to make a difference, not the aim of entrepreneurship. Oh, sorry, we need to get back. Okay. So if you look at future of doctorpreneurship, the golden age of medical practice, which was there 30 years ago, is no more there. The golden age now is, if you want to be as a leader and become an entrepreneurship, the golden age of entrepreneurship is there. Leadership is the art of creating greatness in other people, not yourself. If you look at the future, what is the future for us? Be prepared. The employer knows what you are. Your browsing history, your credit cards and transactions, reviews by peers and patients can predict your loyalty and efficiency. And sometimes trillion-dollar companies have done their genomic analysis on the CEOs who are being selected to understand what is their lifespan that can be unpredictable diseases in the next 10 years for these people before they're given a CEO post. Tomorrow, genomic analysis will come at 1,500 rupees or 5,000 rupees. Everybody will have their genomic analysis 20 years down the lane, and your position will be placed according to your loyalties and your attitudes and your these things. Artificial intelligence will tell you what sort of a person you're going to be. Artificial intelligence is going to play a big role, not only in telemedicine, but in every part of healthcare. Previously, it is art of intuitive medicine. You see a patient, examine a patient, look into the patient, spend some time with the patient, call him 3-4 times, and then make a diagnosis. No, it is basically data analytics. Everything is the data is driven into the analytical thing, and the AI will tell you what may be the possible diagnosis in near future. The future was protective medicine. We are protecting from disease, treating from the disease. Predictive medicine, we are predicting a possibility which was coming in picture now. We have started seeing it. Preventive medicine and precision medicine, which you all know. You see the social media, interactions, behavior, environmental, genomics, health records, metabolomics, transcriptomics, and medications history, and tell what possible diagnosis this man can be having. And precision medicine, you all know, I don't think I need to justify this. It is already there into market. So the future is already known. You are going to be a part of the whole cycle, what you see. Everything is predicted beforehand by somebody else. You are a participant into the whole process of this participatory medicine, into which if you look at one of the examples which I tell you, a big data is going to tell you what is going to be happening. I'll give you a small example. Look at a CA prostate. If you look at a prediction of a person for a PSA, AI data of the epidemiological data will tell which patients have to go for a PSA depending upon their family history and their family history of other diseases, etc. So they get a PSA and come to you. Your preoperative MRI is going to be defined or probably read by AI and tell whether the predictability of possibility of having a CA prostate in that patient. And a biopsy, an MR fusion will direct you where your needle has to go, and that MR fusion will do a biopsy. Biopsy reporting is AI based. Though the pathologist reports, an AI will allocate or validate whether it is 3+3 or a 3+4. Radical prostatectomy, deep learning will allow your robot to function or make you function in the way it has to function based on the MR image fusion. And post-op biopsy risk stratification is again artificial intelligence based, nomogram based, or AI based. Additional therapy, artificial intelligence, genomics, and their BRCA mutations, etc. will tell which patient will require what is going to be done. Metastatic disease, again, genomics and genomics will guide what sort of a treatment, whether chemotherapy or PARP inhibitors, what you need to take. Then where is the urologist here? What is his brain doing here? You are guided to do surgery. You are guided to take decisions. You are guided by AI to tell what diagnosis is going to be there. So what are you here? You are just a participant in the whole process. That is going to be the future. So the conclusions are: realize that monopoly doesn't exist any further. Adapt to the reality. You are into a phase or possibly a period or decade of a participatory medicine where patients and other epidemiological or genomic, etc., all other fields come into picture in decision making. Value-based healthcare is going to be the future, and entrepreneurship or self-employment to get away or create your own, build teams and have better power. Thank you very much.
Thank you, sir, for an enlightening talk on entrepreneurship and corporatization. As you know, it's still already in the scene today, and the days are not long when it will be entirely the system will be corporatized. So it's open to. Yeah.
In the same ultimate slide, we are here to take the responsibility for everything.
Yes.
And if
Written
there is
down.
a court of law, when something goes wrong,
You are standing
none
there.
of them will come back.
The AI will not come back, but it will get validated over a period of time, sir. At present, it is not validated, but will get definitely validated over a period of time. Thank you, sir.
Thank you, sir. Over to Dr. Santosh Kumar to.
Now I request Dr. Sabnis to give his talk on PCNL, how much a small tract is worthwhile. Dr. Sabnis, please.
कल वापस कल रहेंगे सुबह जा रहे हैं थोड़ा सा फैमिली कमिटमेंट है
Well, thank you very much. And Malik said that it is difficult to talk after Ajay Kumar. But for me, it is after Ajay Kumar, after Malik, it is still more difficult to talk. And especially I'm sandwiched between the talks which are actually non-neurological, because he talked of ethics, Malik talked of corporatization. There are talks after the finance and the yoga, and I'm pushed in between for the academic talk. So I wish I was also given some non-neurology topic and I would have delivered that talk. But anyway, I'm here to talk on this academic talk, and that is what we are existing today. So Malik, we are here. So we are not going to disappear because there are many such things will keep on coming up. So I'm going to talk on the PCNL tract, how small is the worth? Well, as you know that
how it goes forward. Okay. Well, we know that PCNL was invented almost 40 years back, but still there is a fear to perform PCNL because there is a potentiality of complications. Western world is moving away from PCNL. And as we know that incidence of large and second stone is going down. So that's a reality and that's a fact. If you see what are the complications of PCNL, all this, there are many complications are enumerated. And we all know that all these complications of PCNL are actually can be contributed to the tract size. And that has been proved in the large database, CROWS data study involving more than 6,000 patients. And what they have predicted is that sheath size was predictive of bleeding complication, which is the most troublesome and most worrisome complication, which all of us are afraid of. And therefore, with this, when we realize that a sheath size is the one which actually plays an important role, then the research kept on and then the mini-perk arrived. So that was in 2000 that mini-perk formally came into the picture. And now if you see, after that mini-perk was first described in year 98 and 2000, then there are multiple centers, multiple publications, multiple papers are published. And if you see here, the number is rising. If you see the publications related to mini-perk. We also took part in this various studies. And what we first did study was that if you have a same size stone, when that was the indication of mini PCL of 1 to 2 centimeter size, and if you compare the conventional tract size and the small size, the clearance, everything was almost the same, but the tubeless was more in mini-perk. And most important thing, clearance was almost the same, but the most important thing was the analgesic requirements, the mean hemoglobin drop, and the hospital stay was considerably less in mini-perk. So there was definitely a benefit in terms of the hemoglobin drop, pain, and various other things when we do same size stone with conventional or this. So obviously, it was very clear from various publications that mini-perk was suitable for small stone less than 2 centimeter. There was no doubt about it. However, once we understood that, okay, mini-perk is good, then it opened a new door and a new era of miniaturized PCNL was started. We started from conventional PCNL to mini-perk, which was quite all right. But then now there are still minimally invasive PCNL started coming up and further miniaturization was done. And the quest to reduce the tract size further continued. So that was the thing. So now after this mini-perk was established, the miniaturization became the buzzword. People thought that, okay, now let us go still further down, further down, further down. And therefore mini-perk, ultra mini-perk, micro-perk, super-perk, super mini-perk, extra mini-perk, micro mini-perk, lots of things came in and started pushing that, okay, that is good. So there was a lot of confusion about the terminologies as to what exactly is the terminology. What do you mean by super mini-perk? What do you mean by super-perk? What do you mean by micro mini and things like that? And this was an important publication in 2015. And they summarize everything. And what they recommended is that for the uniformity, the PCNL tract size should be described in this manner, where the tract size is XL is more than 25. That's a conventional what we actually talk. Large tract sizes between 10 to 25. Mini-perk or mini tract size is the 15 to 20. Small is 10 to 15. Extra small is 5 to 10. And extra small is less than 5 French tract size. So that was recommended that this terminology will clarify everything and will give uniform nature as to what exactly is thing. So ultra mini-perk was again the 11 French size. So that was a S size tract. Stores actually adopted this terminology. And now if you see all instruments which are coming by stores, they are now MIP-S or MIP-XS or MIP-S and things like that. So stores came out with the 7.5 nephroscope, which has either 11 or /12 size or 8.4, 9.5 size tract. And that was the thing. So this was the further reduction in the tract size. When we started talking how much is the worth and what is the worth, what is the benefit. So this is the 11 /12 French, 7.5 nephroscope. And basically the procedure remains same. You do the puncture of the pelvic cholesterol system, whichever way you want to do it. Approach the difference is that this is always a single tract dilatation. Once you make a puncture, once you put a wire, you just have to dilate once, that's it. And once you dilate the tract, put a sheath over it. and then see the stone. And now the only energy source, if you go further miniaturization, on Miniperk, you can use the energy source of the lithoclast, you can use shock pulse, you can use triology, you can use laser, you can use anything, because the channel size of that scope is 6 French. But as you further go down, the channel size goes down, then only possibility is laser. So if you go further down, the only energy source is the laser one. So what are the dilemmas when you go further down, especially MIP-S or MIP-XS, that is from 5 to 10 and 10 to 15, is challenges in fragmentation. Retrieval is again a concern. Intraoperative vision is a problem. Even if there is a small blood clot, a 1 cc, half cc, it hampers the vision and you have to increase the tract size. And maintaining the acceptable clearance rate is again a challenge. Further reduction of tract size, the MicroPerk came in, and this was just a 16 gauge size needle. So 16 gauge is 4.85 French. So it was a less than 5 French tract size, and just a puncture, no tract dilatation. The difference between MicroPerk and all other miniaturized PCNL was that this is a one-step procedure. You just puncture and that's it. Now you start fragmenting and dusting the stone. That's it. No wire, no dilatation, no removal of this sheath, no removal of that sheath. That's it. So this was the further reduction of tract size. So that is what is this Miniperk. This is how it is done. And at the end, obviously, in this case, there is no question of retrieval of fragments. There is no question of putting any sheath, and you just have a puncture mark. That's it. The question is that what are the dilemmas? No evacuation of fragments and therefore clearance, obviously, like RIRS. Any blood clot, there is no possibility to continue. Not possible to go from one calyx to other calyx, but just a needle, it will bend. And irrigation pressure is required under pressure. So that was a problem. So the question now, when we are coming at the end of the talk, is that how small can we go? What is the correct size? And are we stretching our limit too far? This requires a real audit of minimally invasive PCNL and MIPs. So there are a lot of papers started coming up, realizing that all these minimally invasive PCNLs which have been introduced, yes, the smaller tract is better, but how small, is it really better or not? Then tract size in percutaneous nephrolithotomy, miniaturizations, can it improve the outcome, overall clearance rate, overall the hospital stay, overall, what is the difference? And then came the systematic review as to tract size, miniaturized PCNL, systematic review, and that was what they concluded is that Miniperk tract size is good, but in the smaller tract size, actually you need to assess person to person, case to case, whether it has really benefits or not, because there are more problems, there are more other things. So in conclusion, Miniperk is efficacious in terms of stone free rate. It is safe, morbidity is much less, pain complications are much less. It is quick, relatively large fragments can come out, suction can be applied, shock pulse, triology, various other efficient energy sources can be used, tubeless procedure can be performed, and hospital stay can significantly come down. Now, once you have this sort of a result, going further down, whether you are getting any additional benefit or not in comparison to all that is the one which is the question which we need to answer. And if you see all other still further smaller PCNLs, the pelvic pressure can rise, retrieval of fragments is a concern, operative time gets prolonged, instrument is too delicate, wear and tear is more, irrigation poses a challenge, and hence vision has always a problem, inability to insert any forceps or anything, and suction, even if it is placed on the sheath, there are limitations of fragments which can come out. And therefore, to conclude, Miniperk at present is a standardized, most concerns are overcome, vision is good, forceps can be inserted, Ultra Miniperk and other things, just take it out, not yet proved to have too much of advantage over it. And time will tell once several randomized trials are published, because at present, whatever series which are published are the case series. But once you have large randomized trial comparing all these things, we'll realize. But in our own experience, now we have realized that further stretching a limit too far down may not yield much beneficial or much benefits or much advantages to this. Thank you very much.
Thank you, Dr. Sabnis, for enlightening and the procedure to reduce the suffering from PCNL by doing miniaturization of the size. And we had 3 lectures of all the stalwarts of urology on ethical issue and corporatization. And if patient is healing by the good urologist hand or surgeon's hand, then everything can be taken care of, and urologists cannot be miniaturized by corporatization if they are doing excellent job. By this comment, back to Professor Desai. Sir, please.
What was the question?
No, he has just commented, that's it.
My comment at the moment is the mini perk was the first step. Reducing the size. I asked Arthur Smith when he did a PCNL, what was the size you were thinking? Why did you think 34 was a? He says that initially I thought it was 54 because I think you can pick up the stone. Why? There was no energy. And the ultrasound came, so he reduced it to 34. Then come the lithoclast master. And then you realize that size, you don't need that big size because you can break the stone smaller. So they went on smaller and smaller. The micro perk we devised because there were situations while we were doing ESWL or while we are doing the RIRS or a PCNL, there were stones in a awkward calyx which could not be reached. And here you can puncture and you can polarize the stone with laser. And then micro perk was not designed to be a main part of the PCNL. For children, small stone in the pelvis is okay, soft stone is all right. Then slowly we started expanding its indication. But it realized that what is more important is with miniaturization, the energy. And now we have the energy which polarizes the stone. You take shock pulse, you take trilogy, you take the Moses, you take the thulium, they polarize a stone. So you need to take it out, but you can't catch it and take it out. Previously, you used to catch with the forceps or a basket and then thing and take it out. Now it is so small, you can't. So this mini perk has come with the super perk, with a suction. So mini perk with the suction become simultaneous with, so a size is required. You can only address the size because reducing the size reduces the complication. The tract size reduces and then the infundibulum is small. You don't have to dilate the infundibulum or remove the cortex, so that bleeding becomes less. The bleeding was our paper on 2004 by Rajesh Kukrecha. The cause of the bleeding in PCNL, I think is a pioneering work where he has attributed the second slide which he showed, or to the size of the tract. Thus removing reducing the size was needed for the controlling the complication. But by the time the stone size reduced, energy came which could break the stone lesser. So you have the advance. So it's not, you cannot look at this thing with a one point, the size with energy, size with suction device, size with evacuation, and then you got an answer. I think we are on the way to clearing. The AUA panel says total clearance with the PCNL was 72%. Flexible ureteroscopy, 52%. Nothing was 100%. But today, for last 2 years, we have been able to show with mini perk and suction and with laser or trilogy or a shock pulse, if you're planning either in one sitting or 2 sitting, you can have 100% stroke clearance. I think we are very near to the solution. It has taken us 40 years to reach this solution. It took 100 years of open surgery to devise the inotropic nephrolithotomy, where you can clear the stone completely. 95% clearance of the stone that time, our paper, and with preservation of kidney function. And now it has taken 40 years to reach a place where, with reducing the size, developing the energy and suction, we have been able to do it. Now, I'm sure the flexible ureteroscopy is small. When you say miniaturization of PCNLs may not have a help that much, but definitely the help with other additions. Similarly, a miniaturization of the ureteroscope, which is done to reduce the complication, or a disposable ureteroscope to reduce the complication, along with the energy, but still you cannot remove the stone. Now they are coming out with the suction with the sheath, or a different device, KVAC, where after using the ureteroscopy, you use that and go to the each calyx and suck out all the fragment, the polarization you've seen. I think it's an ongoing process. It is never standard. I think in 5 years' time, we never talked about mini-perk 10 years' time. And when we published first time, the mini-perk was presented was 1987 in Jodhpur conference. That was the first time. In 87, it we presented the ureteroscopy first time. But now things change. That has become a history. I think what is important is the experience regarding complication, regarding clearance, regarding the cost effectiveness, regarding the incidence of the stone, prevention of the stone. All things are important. I think we are on the right path. We are on the right path because we do have to criticize everything what we do. Then only you can produce something better.
Thank you very much, sir, for a wonderful moderation of this session. I will request all speakers to please come on the dais for a group photograph. Professor Dr. Ajay Kumar, sir, Dr. C. Mallikarjun, please come on the dais from this. And meanwhile, I request the convener of the next session, Dr. Kamalji Singh, to please come on the dais to take everything in his hand. I will request Dr. Kamalji Singh to please start the session. We have 30 minutes sharp and we'll wind up session 30 minutes. Thank you.
Good evening, everybody. The time has been set and I will not come in between. The first speaker in this finance sector discussion, no issues, is going to be Dr. Anish Gupta. Dr. Anish is practicing urologist at Delhi. In last 1.5 years, we have seen his meteoric rise in world of finance. He's an excellent speaker and we are looking forward for a talk from him.
Hi, Kamal sir, I'll start. The slides will keep on coming. That's fine. Hello, everyone. Talking on Euro finance, I thought Sabnis sir could also sit with Kamal sir, because that is something he has taught all of us. So I am going to be talking on what is known as goal-based. Right. So I'm going to be talking on goal-based investment planning. You do an ethical practice, you do an unethical practice, you do it in corporate, you do it in private, or you do a roaming practice. You still earn money and you need that to grow. And you need to save it properly so that it can meet your goals. So here I am with my topic. It's back to the future goal-based investment planning. It's an approach to investment that is linked to our financial goals. We map our savings and investment to a fixed goal aimed at bringing a discipline in the investing method. You see, when the savings are not linked to any goal, it makes the investment rather random, without a specific duration to invest or a specific return we are expecting. This unpredictability can be mitigated by goal-based planning. Whatever I'm going to talk is self-learning. I have no disclaimers. Where do we begin? There is no ideal time to start investing. Whenever we plan for a goal is the time to begin the investing journey. The earlier we begin, the possibility of achieving our goals with lower amounts increases. For example, when we are investing for a long-term goal like a retirement, if we start investing at the age of 35, we have a longer period to accumulate our funds as against when we start investing at 45. Also, we must understand that the monthly outgo will be much lesser when we start investing earlier, vis-a-vis later. Where to begin? You see, our aim is to create a financial corpus for goals such as building an emergency fund, buying a car, scheduling a vacation, planning for retirement, child's education or marriage. It can range anywhere from a few years to 15 to 20 years. All these goals require different amount of investment, A, and B, we cannot treat them like out-of-pocket expenses. That can be indulged without a specific plan in mind. For example, I know 6 lakhs is very hypothetical. If I'm looking to buy a car of 6 lakhs today, but not today, and I am considering to buy it after 3 years, at an inflation of 6%, it is going to cost me 7.15 lakhs after 3 years. So I need to keep that in mind, and I don't need to save 6 lakhs. I need to save 7.15 lakhs. Similarly, and that's now I'm going to talk of the larger amounts. I'm going to talk of my child's education 15 years down the line. My daughter's 3. Right now, if the education is going to cost me 20 lakh, and I'm just putting the inflation figure here, 15 years down the line, it is going to cost me 48 lakhs for the same education. I graduated from Manipal with a 60,000 fees. I believe the fees in Manipal today annually is around 10 lakh bucks. So you can imagine in 22 years where we have reached, and 15 years where we will go. This is interesting, and this is very relevant to doctors. Economic phases of the life of a doctor. The first being the subsistence phase, which is up to 35. You know, we always say doctors don't earn till 35. Doctors don't get to invest into anything. Well, you are investing into knowledge. You are investing into education, because that is what is going to provide you for the next 30 years. It is also the time for securing income from health accidents and disability insurance. It is the time to begin an automatic saving plan to ensure the base of a financial pyramid. I'll come down to the talk on financial pyramid in the end, and provide you with enough capital reserve for an emergency fund and liquidity. The stabilization phase, which is in young urologist, is from 35 to 45, is when one secures his living standards. In this age, one needs to educate oneself, and that is what we're trying to do, to be profitable, have long-term strategies for building capital reserves, and supplement the basic foundation of what we already have. We must learn to profit from market cycles with mutual funds, stocks, gold, and security accounts. Next comes the speculation phase, which for doctors comes a little late. It's around 45 to 60. This is the period of high growth, when the basic and fixed costs sink and earnings rise. Assuming that one has saved for our children's education and marriage, there is more room to play around and more room for risk as we move to more dynamic and aggressive portfolio management. The last being the harvest phase, where you secured your children's and everyone's future, and now you can reap the harvest of your savings from the last 30 years of work. This normally involves investing in low risk instruments. We will come to that. So what is the growth required? You know, that is one question which will always ask, people will ask. This is a figure which must be remembered. You need your money to grow at 15%. Growth required is GDP plus inflation plus 2. That is a very simple thing to remember, which comes out to be around 15%. So you need your money to grow at 15% if you really want this money today to be of any value 5 years or 10 years or 20 years down the line. And this is an annual growth. Does that mean you don't take risk? Well, risk hai to ishq hai. So you need to learn to take risk. And that is only way you can grow the money, because there is no security or there is no instrument in the world which has a fixed interest or return rate. Investing for short-term goals. So, we in finance divide goals into 3 terms. Anything which is short-term is 2 to 3 years. Medium term is around 3 to 8 years. And anything beyond that is considered long-term. And accordingly, we must be investing into our portfolio. If we have a goal to be met over the next 3 years, let's say, it doesn't allow us much time for the money to grow. Hence, an investment option has to be secured that ensures safety of the invested capital. Here, the aim is not growth. Here, the aim is safety of the capital. Based on the expected returns, set aside a fixed amount to invest in earmarked category of fund. Debt mutual funds could allow you reasonable returns over the short term. As we see from the table above, debt mutual funds invest in bond or other instruments that earn an interest. So the risk incurred is lesser. The returns are also lower in comparison to equities, but they are higher than returns on bank FDs. A recurring deposit may be an option if you prefer a risk-free option. Investing in equities for short term may be risky. Arbitrage funds are again something which are popular for low risk short term, though their returns over the last few years have not been as great. I know Sabnis sir is a big fan of arbitrage fund. Investing for medium term goals. Medium term goals are those which are achievable over 3 to 8 years. They provide a larger scope in choosing investment avenues. If you're comfortable taking some amount of risk, you could do what is known as an 80-20 mix of debt and equity mutual funds, or stick completely with index equity mutual funds. Now you see an index, and we were talking, Dr. Subhash Yadav was talking to me about that. An index has beaten any mutual fund by around 15% growth per annum. So if you were to just invest in Nifty index and nothing else, you are beating everything and coming on to exactly where I was saying, which is 15%. So you don't need to be ingenious too much in investing. You need to stick to a plan and you would get there eventually. That is what is very important. Equity index funds again are for passive investment, which mirror the performance of index. They lower the risk compared to an equity mutual fund, where the mutual manager looks to beat the benchmark. And here you are not doing any active stock selection. You're just following the Nifty because one of the 50 are going to grow and it is going to beat the average returns. An aggressive investor could do an equal mix of debt and equity funds to achieve a medium-term goal. Going on to long-term goals, which are 8 to 10 years or more. Normally, if you are looking for an 8 to 10-year-old goal far away from here, this is the fund you can invest in equity, directly or equity fund, because you are willing to take that risk. The market's going to correct. I don't know how many of you have been following, there's been some correction going on. So you shouldn't be worried about your long-term goal if you're looking at that with this kind of portfolio, because if it corrects even now, it is going to bounce back eventually. And that is what you must know. Someone in my group asked me, I have a large amount of money invested in equity. Should I be withdrawing it, waiting for a level to come? Why do you want to withdraw it? Why do you just leave it there? And you can supplement it as you want. You don't need to play around with your long-term portfolio. You must understand that, because you are investing with a goal in mind. That is very, very important to understand. Typically, long-term goals are accumulated, like retirement funds, saving for children's education, or starting a business. Equity mutual funds or investment in direct equities are the two solutions that you could try to get the required amount to meet your goals. You could try to do it a self approach, but not without solid research. No tips from Kamal sir, me, or anyone. PP sir can give, or even approach a certified, and it's even actually better to approach a certified financial planner if your portfolio is large, so that you don't end up taking the risk. There is no harm giving some part of your portfolio to the certified financial planner. I'm going to come to a very interesting part, and I like to talk about this emergency fund a lot. People don't pay a lot of heed to it. We do our financial planning for children's education. We do our financial planning for so many things, but we don't do it for an emergency fund. For instance, the pandemic has taught us the importance of having an emergency fund. You could use liquid funds to create a corpus that would take care of your expenses for 6 months, even if there was a medical emergency or job loss, which could have been done by a lot of us. The reasoning behind pegging the size of our emergency fund to monthly living expense is that it should help our family tide over periods of income loss. A lot of people had minimum guarantee not being given in the last pandemic, and there were many issues. People did not have, private practitioners did not have enough cases. I've had known tos who have living in mansions in Noida and driving BMWs, and they do not have the money to pay off their EMIs because they have not planned for a 6-month recession in the market of medicine, which is unexpected. Well, it is logical. Job losses or accidents are not only the events that can cause large out-of-the-pocket expenses and force you into debts. In recent times, in the last 1 year, I know many families who are rich but have had to take loan from others because multiple family members were in hospital for a long period of time, incurring a large expense. Insurance helps, but not in these times. There can be natural calamities where the insurance doesn't cover. There can be sub-clauses where the insurance doesn't cover. And these ringers put us in trouble at the end moment of time. To guard against such exclusions, what should be done? It would be best to build a buffer of around 1 to 2 lakhs more into the emergency fund over and above the 6 to 9 months monthly living expense. How do I do it? I will tell you in the end. But let me come to a very important component, which is very important for young people. There is a component of cash in emergency. Yeah, we are in 12 minutes. I have 3 more minutes. Thanks to the rise of net banking and digital wallets, most of us can get by with very little cash in normal hands. But in extraordinary times, currency turns out to be the king. Don't keep enough that you worry at demonetization, but keep enough that if you have an emergency, you have enough cash in hand. You know, people in Chennai in recent floods could not operate ATMs because none of the ATMs had cash in them. So how will you pay people when you don't have cash? And now people are accepting, even the Sabjiwala is accepting a Paytm, but earlier they weren't. And you can't bank on Paytm always. An emergency fund lying in a bank, FD or mutual fund may not meet all the needs in such a case. About a month's living expense should always be there at home in cash. Focus at safety, not returns. Saving account, bank, fixed deposits, and liquid debt funds are the usual avenues. But when making these selections, avoid the temptation to shoot for high returns. For emergency money, it is best to stick to systematically important banks despite uninspiring rates. With liquid or debt funds, there is even more reason not to be lured by returns. The crisis that Franklin lent into tell us that debt mutual funds with higher yields than peers are likely to be taking on both credit and liquidity risks. It is always best to be conservative with government bond-backed securities. Prioritize liquidity so that you can withdraw the cash as early as possible in 3 to 4 days' time. I'm going to conclude with this wealth pyramid. You must understand this pyramid of investment. What is the safest? What is the riskiest? The safest being the blue, cash and cash equivalents, guaranteed certain certificates, money markets, treasury bills. Low risk being bonds, bank deposit, government bonds. Moderate risk being equity-based investment, and most speculative being futures, stock options, cryptocurrency, metals, or small cap mutual funds. I have 30 seconds left, and I like to end with a quote, and I normally do that. I end with a quote from Gita. Indrani pranayur indre bhaye param mana manastu para buddhir yo buddhe paratastu sab. The senses are superior to the gross body, and superior to the senses is mind. Beyond the mind is intellect, and even beyond the mind, intellect is soul. I hope I've been able to stimulate the intellect, if not the soul. Thank you so much.
Thank you, Dr. Anish. Since we are running little short of time, I will request Dr. Ankush to spare some time out of 15 minutes of his 15 minutes. So Dr. Anish was Back to Future. We have day after tomorrow now next coming in. Dr. Ankush Jairath, he's a
Hi, good evening all. Today I am going to discuss cryptocurrency, what all you should be knowing. So this is the hottest topic going on around. So firstly, understanding our financial system, initially came the concept of barter system, in which one good is exchanged in place of the other. It has got a number of flaws. So then it was replaced by metal exchange system, in which one metal is exchanged in place of other. But what about the microtransaction, which were not possible? So government came with the solution to issue currency backed by gold. But as the gold reserves were limited, so printed currency was also limited. But in view of ever-growing economy, more currency notes were needed. So government switched over to fiat currency notes, in which government can print any amount of money, or even that money government or banks have total control of. Most of you must not be knowing that around 20% of all the circulating fiat were minted in the last single 1 year. So to overcome this problem, the concept of cryptocurrency was introduced by Satoshi Nakamoto in 2008 in form of Bitcoin white paper, which is nothing but a kind of digital form of cash based on software algorithm where peer-to-peer transfers were made with no intermediary involvement. That is, it is totally decentralized, not controlled by any banks or any entity. It has got no geographical barrier. Secure electronic transactions take place over the blockchain, in which all the information data like sender, receiver, time and amount of transaction are stored in blocks. So these blocks are interconnected and linked to each other so that you cannot delete or modify the data. That means this is immutable. So this peer-to-peer transaction, which is totally decentralized, immutability, simplicity and efficacy, with high speed and low transaction cost, made crypto into next level of financial service. Previously, there were limited exchanges on which you can trade cryptocurrency, but lately number of exchanges has came up, which gives you various options to spot, option trade, future trade, stake, or even earn on your stored crypto, just like banks do. You can now easily convert your crypto into fiat with very high liquidity, and even convert your crypto into stable coins when the volatility is quite high. So crypto is now accepted at more and more places, maybe at Amazon, Tesla, Microsoft, and so on. Even use cases of the blockchain technology has increased tremendously in every sector, may it be travel, IoT, energy, cybersecurity, cloud storage, banking, automotive, real estate, or gaming. So this all has transformed crypto as a next level hedge fund. So are we in technology? No, that's the only part to be taken care by cryptographers. Why will do take care of the profit part here. So what are basically cryptocurrencies can be classified into three things. One is Bitcoin, all the coins other than Bitcoin are alternate coins. And some are stable coins whose value doesn't change and is equal to 1 USD. According to me, your long-term portfolio should contain some amount of Bitcoin, Ethereum, other coins other than this, which can give you very good returns in long term. Long term, when I say, I am speaking of holding period of about 2 to 3 years, and the returns they can give is around 5 to 20x. So these coins are Bit, Cardano, Matic, Solana, DOT, and Bikonomi. This is according to me. I think they will definitely going to give you very good long-term returns. In short term, you can search for news-based coins. The holding period can vary from 1 to 3 months or so. These are the sites where you can find data of each and every coin. What about the price speculation of Bitcoin and other cryptocurrencies? So according to Bitcoin fair value and peak algorithm regression bands, as well as 4-year cycle theory, both says the same thing. That is, there will be lengthening of the bull cycle, but with diminished returns. So in the first bull cycle of Bitcoin, we have seen a woofing return of 92x. In the second, we have seen the return of 27x, which was in 2017. The ongoing bull cycle, we are expecting a return of around 10 to 25x. So which corresponds to value of Bitcoin around 80,000 to 1,20,000 USD. And if bear market comes after that, that is the usual case. So it should not go below 20,000 to 30,000 USD before legging up for the next bull cycle. So this bull cycle repeats every 4 years. So where and how to buy crypto in India? The main exchanges you can say in India are WazirX, BitBNS, Zappay, and CoinDCX. In the world, undoubtedly the #1 exchange is Binance. Here I will like to mention about CoinDCX, that it has got a very good number of coins to trade on, very high liquidity. It offers you option future trading with leverage, and it has got the lowest maker as well as a taker fees of only 0.1%. Rest of the things almost are same in all the Indian exchanges. So when and how much to invest? So never invest more than you can afford to lose. You should diversify your investment. It is okay that you are investing in mutual funds and shares for very long period, but you should change with the changing trend, as trend is your best friend. So my advice is that you should put something of your portfolio, let's say 5%, you can start with 5% of your total invested portfolio and put into crypto and forget for 2 to 3 years. Do not go all in on day one. Use 3-part investment. What 3-part investment is that you can buy 1/3 of the amount today itself. Next 1/3 when the market has a correction of around 20 to 25%, and rest when it further goes 20 to 25% down. You can make different kind of portfolio, long-term, medium-term, and trading portfolio. Here I will like to mention that 2 things, that crypto is a 24/7, 365 days thing. So the trading goes on all the day. So it is a good thing also as well as bad thing also. So it can be stressful if you are trading on crypto. And good thing is that as we are very busy in our daytime, so we can trade in evening or nighttime also. And it is highly volatile. You can have a gains of 100% in 24 hours, as well as losses of 100% also in 24 hours. So it is very, very volatile. So what is the legal status at present in India? So there is a cryptocurrency bill which was to be introduced in this winter session. No one knows exactly as what it contains because it is not made public. Though the government is saying they are very near to finalize a crypto bill, decision may not be taken in this winter session as it is very difficult to regulate it. But some things are very much clear about this crypto bill, that Bitcoin or any cryptocurrency will never be a legal tender or mode of payment. Even stocks are not. But it will be legal as a tradable asset. So there is no blanket ban. The government will limit peer-to-peer transfers as well as appoint SEBI as chief regulator of crypto assets and exchanges. What does it mean? As that you can only store your cryptocurrencies on SEBI approved exchanges, as well as trade also on only SEBI approved exchanges. Your data will be 100% KYC backed. Violators may face jail term even. Couple of days back, there was a news that our Prime Minister might take a final call on this cryptocurrency bill. So should you be worried at all? So those who are thinking of trading on a SEBI approved Indian exchange should not be worried at all. The downside of it is you cannot store it on private wallet. You can store it only on Indian exchange wallets. So we will not be able to take part in crypto innovations like DeFi, NFTs, dApps, blockchain-based games. So the whole idea of crypto, that is peer-to-peer, as well as decentralization, will get defeated, and such innovations will become inaccessible to us. If you are holding Bitcoin as an investment, short-term hold 20%, long-term hold 30% on profit. You have to pay as tax. If you are trading, then income arising out of Bitcoin subjected to tax as per individual slab rates. So still thinking to invest in crypto, what I will recommend is just invest that much amount which you would have spent on vacation when COVID was there, and by default you have saved it. It depends on future. It depends on you what future holds for you. You want to buy Ferrari or Lamborghini while still young, or you want to give it your earning benefit to your kids. It depends on you only. Still not convinced? Just see, Bitcoin is now 9th most valuable asset by market cap. I'm pretty much sure it will replace gold in near future. Multiple top companies of the world, I'm speaking about public companies because they have to give how much investment they have in Bitcoin. Be it MicroStrategy or Tesla, they have very high stakes in cryptocurrency. MicroStrategy hold around 121,000 of Bitcoin, while Tesla hold around 50,000 of Bitcoin. So at least have faith in their studies, as you will be still considered early to adopt this revolutionary thing. So invest wisely, do your own research. Thank you. Yes, sir. No. These are now, because this concept has not yet came, but while the government is regulating crypto, they are yet to introduce a cryptocurrency bill in the parliament. Discussion is already going on in the parliament in this winter session also. But I am of the opinion that they will do this thing, that they will appoint SEBI. At present, there is no SEBI approved exchange. They will appoint SEBI as chief regulator of all the exchanges, and you have to trade and store your crypto only on SEBI approved exchange. Yes. Yes. So what then the government will give you a time period to transfer your crypto to a SEBI approved exchange, and you have to give all the history of your whatever buying or selling you have done till now in crypto.
As of now, whatever you are earning,
yes,
in short term or long term, as of whatever you are earning on Bitcoin or
Yes.
whatever on crypto, are you paying tax as per the prevailing rate?
Yes.
So are you declaring all these assets in your annual?
Yes.
You are declaring it.
Yes.
So it is your like a bank money, but the
Yes.
bank is not yet approved by the government of India.
Right.
Should I say that?
Yes. So at present, you have to show income from other sources because there is no taxation policy as such. So you have to show whatever income you are generating, whatever profit you are generating, that it is coming from other sources, because there is no as such category of cryptocurrency.
See, at present,
Dr. BP Singh.
fear in
BP
the
Singh, sir,
public-
please.
last
Sir, please, we are really running short of time, sir. I will request, please grab onto Ankush and Anish. They are here with you. You can ask them anything.
Thank
Ankush is
you.
too good in crypto. I hand over stage back to
Thank you, Dr.
Dr. Anup.
Kamaljeet. I will request Kamaljeet and both the speakers to come on the dais for its photograph. And meanwhile, I invite the chairperson for the next session, Dr. Shivam Priyadarshi and Dr. Ranjit Sinha, sir, to please come on the dais. And we have to finish in 30 minutes, sir. This is my humble request. We are really short of time. 30 minutes, exact 30 minutes, sir. Yes, sir.
Yeah, so very good evening. We have been rightly placed in between two hot topics. We already have a topic on money, which is quite hot. And we are going to have a very hot discussion after this. And it is everybody's guess, right? It's a GBM. So in between two, we will have some cool time, some breathing time. So I would just like all of you to just relax yourself as much as possible. Keep your back straight and just observe your breath and listen to us. So the previous speaker had rightly said that they had been able to stimulate the intellect, but not the soul. So we would try to stimulate that soul in the coming 15 to 30 minutes. So what we will do is, I will have a short presentation on yoga, and Dr. Sinam will give some practical tips. He will show some asanas, and particularly his favorite, Jal Neti. So Jal Neti is very important, particularly during this COVID time. This has been helpful in many ways. So this would be a very important practical tip for all of us to how to do Jal Neti. So I would just start with a small presentation, and then you just try to arrange your Jal Neti and everything is fine. So yoga, as we all know, comes from a word in Sanskrit called yuj. Yuj means joining. So actually it means joining the two, that is the individual and the ultimate or the super consciousness or the collective consciousness or the Brahma, whatever you say. So it's a union of Atma and the Almighty. And it is actually not just a sense of, it not just develops a sense of well-being, the physical or mental well-being, or it is not just an art of living also. I call it, yoga is an art of being, because yoga is a journey which takes you from yourself, through yourself, to the self. Because actually, ultimately, this is a process which leads to self-realization, a realization of your own inner being. So that is yoga. So yoga is a journey which carries you from your body to mind. That is what we call Hatha Yoga. And from mind to soul, that is Raj Yoga. So our allopathic medicine is disease-centric. We focus on disease and its treatment, whereas yoga is a medicine of health. It integrates body, mind, and soul. Yoga is as old as the universe because the creator himself is called Adi Yogi, Lord Shiva. So if we go into the history of yoga, in the pre-classical era, about 5,000, 6,000 years old, our Vedas and Upanishads say that our sages, saints used to have penance in jungles, mountains, rivers, in different postures. But there was no systematic approach towards yoga. It was only in the 300 BC with Patanjali, Rishi Patanjali, who wrote the treatise Patanjali Yoga Sutra, when yoga came as in a systematic format. And then after that, there was a lull for almost 1,000 centuries. In only 15th century, there was a yogi called Svatvarama, who again focused on yoga, but he focused more on the bodily practices. So Hatha Yoga became very popular and almost synonymous with yoga, though it was not actual yoga. And then later in the 19th century and early 20th century, Krishnamacharya, who actually popularized Hatha Yoga, and he's called the father of modern yoga. And then later, his disciples, Pallavi Joyce, Iyengar, Vikram, all they started schools of yoga in different parts of the world, and yoga became so popular throughout the world. So this we have already discussed. So it's a journey from body to mind and to soul, and ultimately it liberates your spirit from the illusion of time, space, and causation. So Patanjali Yoga Sutra has 8 limbs. The first 4 limbs are the Hatha Yoga, Yam, Niyam, Pranayam, and Asana. And the next 4 are Pratyahar, Dharana, Dhyan, Samadhi. So we can just, to simplify the whole, all 8 limbs, we can say that this is like you are driving a car on the road, and your food, water, and air that you take is the fuel. And the lubricants, asanas are the lubricants. And pranayam is the battery, which ignites and starts the car. And your meditative driver is the meditative soul. So if we drive a car like this, you need to follow certain rules. So yam are the self-restraints which you need to follow on the road if you want to reach your destination. So these are ahimsa, satya, aste, brahmacharya, and aparigraha. And you need to follow these with fixed observance and self-discipline. And these are called niyam. So they are shauch is cleanliness, santosh, tap, swadhyay, and ishwar pranidhyan. And then these asanas will help you to attain a comfortable, relaxed posture for this whole journey, because otherwise you will not be able to drive your car for such a long period. So that's why it is called Sthira Sukham Asanam. So the whole purpose of yoga is to make your asana is to make you in a comfortable, relaxed posture only. That's the only aim. It's not to have physical strength, so that you can go into the next step of yoga. Pranayam is something which is a bridge between your mind and body. It helps not only to control your breath, but also helps to control your mind. A very simple example is, if you are angry, your breathing would be fast and shallow. And if you are very calm, your breathing would be deep and slow. So if you can control your breath, you can make it slow and deep, your mind also will remain calm. So this is pranayam, which will help you to bridge this gap. And then pratyahar, the 5th limb. Till now, we had all our energies going out. Now, if you want to start your inward journey, you need to take all these senses in the inward direction. So pratyahar is putting all these senses inward. So it is a bridge between bahirang and antarang. And then, even if you take your energy inside, your mind still is wavering. It's very important to have concentration of your mind. And that is dharana. Dharana is not meditation. It is just you have to focus your mind on a particular thing so that you remain focused and concentrated. And once you have that kind of concentration, then some moments or glimpses can be of a state of thoughtlessness, when you reach a state where you are totally calm, without any thought, without any emotion, and that is meditation. So that's why they say that meditation cannot be done. It can just happen if you have practiced all these limbs of yoga. And then the ultimate stage is samadhi. That is, if this state of awareness remains persistently throughout your life, you have achieved samadhi. When your own inner self merges into the total whole consciousness. So when you realize that you are not an individual, you are just a part of this collective consciousness, a part of this whole collective energy. So that was just a brief summary about what is yoga. And now I would request Dr. Sinam to give some practical tips about asanas and the Jal Neti, please.
Thank you.
Yeah.
Gurumdari, my Manipuri language, there's famous for sports, Manipur, that Mirabai, Tenu, Mary Kom, all of sports activity. Anyway, what I want to say is that in 24 hours time you get in a day, our Shivam has described, keep at least 45 minutes for your body. Love your body. If your Atma, Jiva, what my friend has described, that is staying in your body. If the body is not fine, it is not all right, the Atma will leave. Then it's the end of the road. Many of the young urologists recently in Kerala, as of 45 or so, he kicked the bucket. So I fervently request that every one of us must keep some time for your health. Even a beggar in the railway station of any part of our country, he will not beg when the sun is set. He will have his grub and he will sleep in his hut. And even a cow will not grow, will go in the graze in the night. They think that it is for taking rest. So body, mind, soul, my friend has told very nicely, we have to take care. And your mind is a monkey mind. Monkey, it is flickering. Now Sabris may be thinking, Nadiyan mein wo case kya ho raha hai, hematuria ho raha hai, iske pal wo puncture kaisa karna hai. Understand? And once your health is gone, puncture sab chala gaya. Initial puncture sab chala gaya. So we have to take care. So with these few things, I will just try to show some of the asanas. By doing these asanas, there is a physical change in your body. What my friend has described, that last part, can you put a slide of that Pratyahara Dharana? That will give you your spiritual health. Health is not just a physical, it is a physical, mental, social. So these three has to be achieved. You have to read your scriptures depending on your faith, whatever religious book, please read. So let me show you the physical.
I'm not able to.
The physical thing, once you regularly practice your that asanas, your muscle, your ligaments will be stretchable and it will be more supple. Your backache and all those things will disappear. Dopamine, the good feeling chemical, dopamine, serotonin, dopamine, oxytocin, serotonin, endorphin. Endorphin will be secreted. Your pain will disappear. So let me show you one Supta Vajrasana. Here, first step is Ardha Ustasana, half camel pose like this. Full camel pose, this, you touch your heel, and Supta Vajrasana like this. No? So because of prolonged practice, I can go to this extent without any problem. So this, you as Shivam has mentioned, Stilam Sukham Asana. Dr. Rajan is stationed like that. Don't do that. Whatever is comfortable to you. Suppose you are comfortable up to this, do that up to that. Slowly, slowly you feel that, oh, he is doing like that. I will do. It is not the way. So that you are. Then Sarvanga Asana. Standing on the shoulder. Yeah.
The best thing is Dr. Sinam is more than 70. Still, he's doing these asanas, doing every day. He wakes up at 4:30, and they have an online yoga program. And the members are from throughout the country, and some are from abroad also.
Yeah.
So, no, he would be able to touch it. Okay, wonderful, wonderful. Now we will have a later, sometime later. You show the Jal Neti, sir. Jal Neti, and then we will have the video.
Jal Neti is something about Jal water, Neti guiding. Jal Neti, so this is particularly very important at this era of COVID, where virus is entering to the nose. So what I will do is, you have to put the
Just see how he is
drip
doing.
of water with saline, and you bend like this forward and take your respiration through your mouth. I am going to put the water
through one nostril left, then right, and will come out to the right. So take like this, like that.
So this is warm water with just a pinch of salt. So warm saline water. So this will help to clean the passage, nose, your nasopharynx and yeah. Then you have to look at the other one.
Yes, other, so because of time constraint, I think.
Yeah, I think it's okay.
Only one will do, and after that, you just squeeze it out.
So.
And just one asana, I will just take one Surya Namaskar. We are praying to the Surya Deva, and that consists of
12 steps.
12 steps. Mudra or Pratna Mudra. Mudra means your hand hold. Yeah, hand mudra like this. You put your index and the thumb like this. Yeah, mudra. No, Gyan mudra. Gyan mudra like this. So this is the Pratna Mudra. This is the first step of your Surya Namaskar. The first. Second, like this, Adha Chakrasana. Padasana.
The best part of Surya Namaskar is that it
you
can do all the different types of muscles in particular one kind of exercise.
Pavarasana, mountain pose, Ashtanga. This is the Ashtanga means eye. You are having two legs, 2 feet the feet are touching ground. The hand 4, 2 means 6, then means yes, and the chin. This is Ashtanga.
Ashtanga.
Ashtanga. Yeah. And while doing, you must be mindful about your respiration. You must take inspiration, pull up. Okay. And if Shiva says,
Any kind of asana is very important to keep yourself relaxed.
Relax.
Your body should be relaxed, your breathing should be relaxed. And after every asana, you should do a savasana. Because during asana, you actually stretch your muscles, tighten your muscles, strain yourself. But in savasana, you relax muscles. So actual benefit of any asana comes during savasana. So it is very important that every asana should be followed by a savasana.
and Titanic heroine came to
Video, please, video.
Jaipur to learn the yoga, spending lakhs of rupees.
Yeah.
We are in India. It is our Prime Minister, born in the UN, and everybody agreed. All 177 countries agreed to observe 21st June. Is a proud moment for our country.
Yes.
The whole world is practicing. Whether it is Christian, whether it is Muslim.
Yeah.
So
we'll show a small video
Yeah.
clip. The
Thank you
basic
very much.
purpose of showing this video clip is that, as you all know, yoga as Bhat Yoga, Asana, Pranayama, it is actually not yoga. It's not a full yoga. So the ultimate aim of yoga is dharana, dhyan, and samadhi. So meditation, I think, is the most important part, the ultimate part of yoga. This is a small video clip that I have made on meditation and how to maintain the sitting postures and do meditation. Yes, please go ahead.
The first 6 limbs just prepare us for meditation. In fact, there is no technique to learn meditation, but these only help us to be in the state of meditation, which is a pure state of awareness, where thoughts no more control us, and we are one with the existence. As said in Yoga Sutra, Chitta Vritti Nirodha. We can light some incense, have a soft background music, wear comfortable loose clothes, and choose a natural airy surrounding. If not comfortable sitting on the ground, you can sit on a chair, but don't use the backrest. Instead, sit in the front part with your back straight. The best posture would be a sitting posture on the ground. You can take a small cushion and sit on the cushion in its front part so that the buttocks lie on the cushion. The first asana is the simplest one, which is Sukhasana.
That was Sukhasana. This is Ardha Siddha.
The second sitting posture is Ardha Siddhasana, where the heel presses on the perineum and the right leg on the left thigh. So this is Ardha Siddhasana.
And this is
The
Siddhasana.
third posture is Siddhasana, where the left foot goes on the right thigh. And the fourth one, which is the most optimum sitting posture, is Padmasana, where the 2 feet are on the 2 thighs. The whole objective of yoga is to learn to be in a comfortable, relaxed posture for meditation, as said in Yoga Sutra, Sthir Sukham Asanam. The eyes can remain either open or closed. Some people feel drowsy or sleepy with closed eyes. They can keep their eyes either open or half open. Head should be straight, not tilted back or on front.
Try to keep
Chin
your back
can be
straight.
slightly down at an angle of 45 degrees. Hand could be in various mudras.
This is
This
Dhyan
is
Mudra.
Dhyana Mudra, or it could be Vayu Mudra, Sunya Mudra, or the Surya Mudra, and the Prithvi Mudra. Dhyana Mudra,
This is Dhyan Mudra. This is probably
where the
the
left
best for
palm
meditation.
is considered as the world of illusion, and the right palm, the spiritual world. Keep your back, neck, and head in one straight alignment. Imagine yourself as a stack of coins or a puppet on a string which is being pulled up. With each inhalation, straighten yourself up, and with each exhalation, relax yourself. For centering and finding the center of gravity, you can rock your body sideways or back and forth, finding your own center. Try to straighten yourself up, and with each exhalation, relax yourself. Relax your whole body. Start from your feet. Try to tense them and then relax. Similarly, proceed up in your leg, thigh muscles, back, shoulders, and head, especially the muscles around your eyes, face, and scalp. Relax them completely. Then come and observe your breathing. Our breathing has 4 phases. Inhalation is Purak. Then there is a slight pause, which is Kumbhak. Exhalation is Rechak. And then there is a slightly longer pause, again Kumbhak. Remain aware of these 4 phases of breathing and observe them. Remain aware of all sensations. It could be a pressure sensation, it could be a little pain in your back, or it could be some tingling in your shoulders. Also remain aware of all the sounds in the environment or the smell. You might be distracted by some thoughts, but as you observe them, they tend to go and you come back to your own breath. Keep observing your breath. Gently open your eyes and let all the forms, images, and colors come into your eyes and just observe them. Slowly unlock your Padmasana. Be aware of all the physical movements.
Right. You can just
You end
stop it here.
with
So, so that was just a small brief thing about how to have a meditative posture. So, Dr. Sinam, your last remarks, and then we'll end.
Today, my only thing what I want to describe to the overstanding is that not your body, at least 10, 45 minutes for our body. Otherwise, we will go like a dog to go over for 1 year. When you try to open, you will produce
it will be very smooth and like that. Same principle is applied in our body. Love your body. That is what I want to give to others. What I am achieving for last 25 years, 21 years, I have been practicing. I joined just like that in my hospital where this yoga session was there. And just like the lozenge, once you put in your mouth, whether it's deaf, dumb or child, it is sweet. Yoga is sweet once you practice. Thank you very much.
Thank you very much, Dr. Shivam, Dr. Ranjit, and we will have a group photograph here. And I think that has put the very calm kind of ending to our conference the second day. We're going to start the GBM for this 31st annual conference of NJ DUCCON 2021. I will request our president, sir, NJ DUCI, Dr. Sudhir Raval, sir, to come on the dais. Our treasurer, Professor Nachiket Vyas, to please come on the dais. We're going to distribute the agenda, and already we have circulated the agenda on email multiple times. And we have been given 1 hour, so we have to stick to our time so that we can all enjoy the cultural program. Audiovisual person, can somebody come here? Connect my laptop here quickly. One person stand here and connect my laptop, please. So connect karo. आपका है बुलाएं या मैं लाऊं कनेक्टर है माइक्स ऑन कर दीजिए प्लीज माइक्स ऑन द डायस हो गया ओके साबिर प्रेजेंटेशन but ठीक छोड़ so I will request everyone to please settle down. We're going to start the GBM now. And the chair of this session is our president, Dr. Sudhir Raval, sir. So whatever you say, please address to our president, sir. So first of all, the roll call. So I think we have the decorum, the quorum is complete because we have close to